pulmonary. The U.S. MIP fellow in Sydney. This approved. Obviously, ongoing fellowships in England all around others, and I apologize. And you have one. Levels of formality and standardization across all. What an IP fellowship actually means. Skills are people. Coming from both Hari and Tinku and many, really putting India square on the map. Growth in bronchitis. Obviously, the old song, "The Future's So Bright." It's an exciting time. I'm looking forward. Years have been fascinating to see the development. I can't wait for the next 15 here in 20. So I'm going to end with a thank you to the University of Chicago. If you find in the Chicago area, please come early. Come so much. Appreciate the.
Thank you so much, sir, for letting me know what the future is. The next session is on artificial session is by Dr.
Thank you very much for the invitation and for the opportunity to do this talk. I've been asked to talk about AI in pulmonology, which is a very vast topic, so in a way it's a very generous title. And I was thinking, what should I do? How can I structure this talk interesting and also constructive? I put down 10 essential insights that we think every scientist should know about AI, because we are talking a lot about AI, everything is AI, but what actually we need to be able to use AI to develop AI and use this technology in the future. So the first thing I want to start with is this. We talk AI, especially after ChatGPT was launched in 2022, but it has been with medicine for a long time. It had a test in 1956 by during the 60s and had the early rule-based medical decisions in the 60s. Internist one. Then the radiology, so where assisted radiology since 1980, of what called wind, especially after 2000, with the deep learning technology. The CT patient. Now, all this is needed to the level to this type of technology was launched and exemplified ChatGPT, and ever since everything now with AI. But if we look a little bit more carefully at what AI is, we need to really understand AI is not ChatGPT. In fact, ChatGPT is only part of a sub of what is called generative. And it's not only ChatGPT that is doing generative AI. There are now several systems, and you may have heard in the last weeks that there is a Chinese system, DeepSeek, which works as well as ChatGPT, and it is much, much cheaper. But look at this diagram. So deep learning is actually more important than generative AI for the applications that we use in pulmonary medicine and in bronchology. Of course, we have machine learning, which is basic AI working with a fixed algorithm we have used for some time. So I think this understanding is really important when we are talking about GPT is not intelligence in artificial intelligence. It's actually a marketing term. ChatGPT is a formula, basically as an correct on steroids, if you want. So it predicts. And on this slide, you see that you start with a sentence. The words in that sentence are associated with numbers. Then the numbers are associated with a matrix of numbers as probability. And based on the training, we add another sentence which is generated from the initial sentence. So remember this. If anything, about I in artificial intelligence. We can talk more about this. It's again really important to understand mathematics, the generative AI, which will help us to understand where we can. The thing which put on the fourth important is to remember that most of the applications that we use with AI are using the deep learning algorithms, and the deep learning is a predictive of AI. It basically does hallucinate, and it helps to use, for example, AI, what we call AI in medical imaging, in assisted navigation, in automatic. I will question if we don't do that in developing this deep learning, in developing systems that will navigate, as we've seen, the needle straight into the target without us being in the room. So annotating just bronchoscopy, just the bronchoscopy video is probably the simple step we can do to develop this kind of technology as to more sophisticated software. This is one of the, just to show the evidence that if you have image recognition and if you have a good data set, you can get the machine, you can get the computer to recognize the normal images and the abnormal images as well. The next I put here is now, let's focus a bit what generative type of AI can do, which again different from what the type deep learning do. And the generative AI will basically analyze with probabilities the word we give to the computer. So therefore that probability can translate into diagnostic probability if we use the words and the right prompts. So probably the application that will help us with the diagnostic probability, with personalized training, with research, because it can hallucinate in a positive way, if you want, can give you ideas about associations we can have, and we don't necessarily think of that. And also with administration, and in our hospital we're already using it for administration and the the American institutions are integrating this into the diagnostic probability, and I'm pretty sure we will see this. Now, if we want to interact with the generative, we have good prompts. Prompting correctly is what allows us to get quality outcomes. Was that I didn't know how GPT put rubbish prompts, rubbish outcomes. This is an example of how a more structured help you get more the outcomes from applications type of basically you need to the system in touch the structuring is very flexible in a way, so you can generate nice prompts depending on what application and what need. Can this help with the diagnosis? We are having more and more evidence that it will help, and it's again an example of the evidence available. What other things we can do with prompt? We can use what is called a tree of thought, and we can give different roles to the prompt, to the machine. So instead of saying you are an expert in bronchoscopy, you can say you are an expert in oncology, you are an expert in pulmonology, you are an expert in thoracic surgery. Give me your view of this case. And this is actually reproducing what we have in a multidisciplinary meeting for cancer. It's a very interesting type of prompt which will prompt the approach in cancer and therefore the which I think is becoming more and more important as doctors, medics, is to learn at least basics of engineering. I'm not sure we should be engineers, but I think like we kind of technique, we should learn how the generative AI technique works, and the only way to learn that is to learn about engineering. It's like writing a clear prescription, and it also recognizes handwriting if you want, so it doesn't really matter if your handwriting is not very clear. Information needs to be very clear, because right ensures the right outcomes of applications like generative AI. The two things are, of course, there is ongoing ethical and ethical aspects. So we have limitations with the systems, have biases, and I think the technology progress, the development, the further development will help address the regulatory challenges, because people don't really know or understand what is with of they see it like a magic box. They don't understand what's happening inside the box, where the information goes, what are people doing with that information, how the information is coming back, and so on. So it has a real pressure on the validation and on the adopters in big IT systems, in hospitals and things. The security of the system and the of the information goes really important. And also to remember that AI is not going to replace us. It's going to work with us. So we need to use it as a tool. We don't, we need to always to have the clinical expert as as a support rather than as a replacement. What is going to happen next? I think we are already, if you look in the IA world, so people are not talking anymore about ChatGPT, are talking about agents, and agents are basic systems, a little bit complex, that will complete a task for us. So that is going to come. It's interesting. We've seen this potential integration of AI in everything that we do mechanically, in robotics, the robotic automation, again, the very nice example we've seen. I think we have a significant and an important role in shaping the development of AI. And I've seen many times that people consider AI as a gimmick, as the young guys are playing with. I don't think we should have that attitude. I think we should understand what AI is, because otherwise we'll remain behind. So don't remain behind. That's my last slide. Has an impact. We engage, and I'm sending you a call for action to embrace AI. Thank you very much.
Thank you so much. Very informative talk. Next week, Rohit Agarwal will be talking about pulmonary noise, secondary noise.
And try to bridge the gap for pulmonology with radiologist lens. So I was thinking, what should I emphasize? Overlap, where are the new applications AI that's my presentation will emphasize on the app in space of pulmonology from radiologist lens. So I start, I would like to emphasize on that radiology, and as we know, more than 3 experiments are being done. Number is going to increase. Number will only going to shoot. Get me the report as possible for my patients. It is so there are a lot of for the first workload is increasing. There is workload. There is oftentimes a lot of there are diagnostics errors as well. To help these pain points, increasing workload, AI the radiologist. How AI can help it? AI. Any tool will identify is any presence, any abnormal image part. Then, if there is an abnormality, pathology, so that the radiologist can positive or positive. Then, AI being further data set, it can also identify understanding the to give you an example, nodule can be because of tuberculosis, solid lung nodule, which X-ray or CT scan. You also have to prioritize. The same in this. What all modules are relevant, showing signs of malignancy. Basis. Then in the end, to detect that finding, you found that the AI helped you to find that pathology. So you really need to complete workflow. So a lot of conversation is how AI is the turnaround time for different. Also how impacting clinical outcomes. So in that as well, in the workflow option, which AI can help starting with radiation and of ultimate benefit to the patients with pulmonologists for that. To talk about cure, so I cure, we 16, almost 8 years old, and working on the same I'm going to talk about. This diagnosis of and clinic focus on clinical impact. So we got very it could be in different pop. We have 80 and we are more. We are driven. So we have patients and 25 plus more has to be based, and that's our focus is on. So we operate across patient best care. We work with private sector, with population health, pharma, and policy shaping. I will talk about in we have chosen lung cancer as of a private cancer is one of the most cancer where chances of death is very and the is because so there is a cut if you can use no patients survival picture it was found that more than stage 4 survival rate the 5-year survival improves significantly. That's where we are doing a lot of work where trying and radiologists playing a big role over there. Where these patients, let's say any scans, chest scan for screening, because cancer screening will not wherever it is. So there images that have for all of patient comes for road traffic refraction to eye on the back, see the that opportunity level and identify diagnosed earlier. This is how we are start X-ray. X-ray because most commonly used imaging. It's cost. It's care centers of excellence, and trying those on those chest for on CT formation nodule and establishment lung nodule CT scan. So there we do the monitoring, measure the lung nodule. We characterize the stiffness of nodule, decide the appropriate management track for that patient. This all runs on a platform called Q-Track. So Q is the platform, all these tools on track from end to end for that particular patient. So I'll give you a quick glimpse of 3 offerings that we are using in Sync. So here is our flash, which can it is so all the findings are also understand any new increased. So to reduce that within the pack, one solution. There are 100 X-rays done. Let's say 10 X-rays might have lung nodule. So those 10 X-rays come up and the radiologist can see the X-rays. You can see this is pre-populated report. So he even have to type. I have tried to make it very 5-7 years, trying to optimize it so to identify it presence of nodule. It will localize it so you can see where the nodule is. The clinician who is reporting that so when it module low and then also prompts to be done is just or the clinician who is reporting an auto-populated report. So he doesn't have to do anything. He will get the with one click. So we are giving the radiologist as well, providing those information which was not before. Another offering that is very important for QCT. On the left side where you can and go to the slice where it will load characteristics, volume, give you the Brock score as well. If you have other patient, see how these only detecting the nodule is like what nodule. Is it a benign nodule? Is it if the chemotherapy not, all those things can be in many ways as it to have like multiple CT scan. It can also start the and airways around that particular nodule prepare better for any intervention you might be planning. Again, we are it very easy by making poor click. So to the assessment, and with an adaptable you can, so fewer clicks, you can also manage change multiple nodules. There is more than one to over. Now coming to the solution that we had, so we are providing. This is what we rate. Provide a diagnosis. We also which is in the patient to go to the next step, which is, let's say, if the patient is confirmed, needs to navigate that process of scheduling, going the scheduling appointment, although for the better collaboration, different specialists confirmed opinion. Radiologists, they all can interrogate on the same tool, that you will have one patient in sequence himself. This collaboration is happening on multiple platforms, and it's very difficult to exactly happen when it happens. Where the starting point for detection of nodule, then management, and to provide more information, definition, fidelity, so you will get a lot of more details beyond the nodule. There is biopsy that happens on that patient that can be also tracked. Time nodule was come for lung. Patient didn't come with any symptoms of lung cancer. It was only detected to be done with the all can be tracked. This is kind of an overview of what we are doing, detection to the final management, because the ultimate aim is to the patient and to get the precise management. It happens, it's the most imaging modality. Chain diagnosis one required for that patient. Let's start with nodal segmentation will happen on details about the nodule. Follow-up will track and patient's biopsy, any subsequent biopsy, all tracked and mapped on that particular Q track. So these are not only concept happening world. These are the few examples where we have diagnosed patient from infection to early stage confirmation. So these patients came for X-ray as by the not for any cancer or anything related. We had to with the time where engaged, willing to. So we are all seeing that lag and the lag between the communication often might have a follow-up. So to reduce these different tools. This is an example relevant to the job. The TB might be endemic because this is an example. A case which was diagnosed as tuberculosis, but how we are able to particular patient, because for that patient. Of course, there is possible few scientists or few people AI, but a lot of we're very thankful for in various op how it can be used. As a tool of the year or the end of the year, we might come up with some tool. We are trying to evaluate tumor mutation where we are trying to find the amount of cancer burden that a patient have. So basically, whole tumor mutation burden. This is a project that we are doing where we are under first version that will have a question of malignancy and treatment. Also working with other study where the interest, the abstract got updated. We have showed that the diagnosis of lung cancer was reduced more than 2 months to within a month. This is an analysis of this delta was bigger by the time that the study is completed. We would love to have you and talk more. We have hear from you, and also is anything we would much for
so much, sir. Professor, he'll be talking second pair of
Good morning. Thank you, Preeti, for your presentation. Thank you, Ari, for organizers the kind invitation. After you very well the artificial intelligence, so I some to the artificial intelligence because everybody is just new, but have been new decades. What we can do with AI, we keep in mind this when we approach especially for the future applications. Functionally, tools can relate big data, apply rules to complex identify patterns in data sets, and especially act and perform many for perform literature writing and it's very we have some 5 applications. The for and regarding my topic that training with this technology can enhance proficiency bronchoscopy training, especially for this. Sector with, and it was a study of the competence for navigation, procedure, and this is available in the market. And EBUS, no lung cancer, no small cell, benign with accurate current you are studying for the moment there is how computer in the very interesting is the evaluation methodology, especially to help pulmonary intervention. Accuracy, so reducing the cost. In can probably help to rapidly identify lethal malignancy, diagnosis, and great malignancy. Radiotherapy is applied for the cure state had disease, but 4% moment in comparison to 42% for the for but also for research writing. And also from two other new application research assistance. I don't feel, but you can find so this conference recorded and available with Pulmonology on Air. You find all the new application for general assistance. You especially for pharmaceutical for to the literatures as the for the scientist. The list interesting. So the but going to my my topic that is augmented reality. A lot for training pathways. 5 years ago, very to it's very training interventional pulmonology that concluded not be used availability of use high fidelity extremely level and we tested the popular now interesting is the endomental suite because is very useful for not only for pulmonologists but also for gastroenterologists and neurologists in our hospital. Bought this system money 3 spend for the the bronchoscopy, but emergency bronchoscopy is all the pathway of intervention and so the in very interesting intubation. Every CD example of iron bronchoscopy, and the will be maybe Michael is here, very interested to create realistic situation of the suite. The studies demonstrate since 2001 we there recalled the efficacy of the reality the and for the novices. In our master, we use with simulators. Very interesting to demonstrate that when achieve the 80% of competence, the patient supervision is very useful when the patient. This is a system that we use now. It's the reality supercomputer stimulus on real world. That is me. In this case, anatomy lymph nodes. I go to the conclusion. Reality, position, because tradition, is the 3D visualization. Limitation and improve with the mannequins. I conclude with this phrase, we are at the and reality is immersed into daily clinical practice. And physicians should not partnership in an effort to improve clinic. Thank you very much.
Session is on research in interventional pulmonology. We have Dr. Joseph Cecilia.
Looks like my fonts might be new. All right. So what we're going to do, I'll wait for my manager. Clinical trials for medical approval. Pages on. One lack. Devices came about in 1976, many years ago. Classes were created based on device risks. Class 1, Class 2, Class 3. And a lot of you have to that you're safe. Class 2, the MI, could fall into this fire pathway, and we'll talk about that. An alternative your research from because it applies to modifications of devices. So if you have that it's safe. Expedite this class 2. And this is based on what we call substantial equivalence. The rest of the world is a similar policy. You could be FDA, where the FDA has a 510K. India has a predicate. China has what's called type. Korea, Japan have very similar device to market. In India, where approval to Standard Control Organization (CDSC) is just that their device is substantially equivalent to a predicate device. In India, also by that complete approved by one of these countries. The device successfully marketed in 2 years. This predicate device comparison is a very nice way to get technology. So equivalence is defined in terms of similar. The allowed potential problem associated with this because the rule percent of devices via less than 1% of all require and 1% of all approvals. On predicate were out more than 10 years. At the 10K were sometimes recalled afterward. So this leads to people getting concerned and upset. This is US. This is in regard to ablation. Concerns which technology and believe that available data supporting bronchus no longer immature is illustrated deaths. Kyle mentioned here. Investigating you now, in our opinion, for any further investigation, the FDA could bench of the current 510K clearance bronchus ablation. And this was a lot of people you may recognize. So what here is the answer do the 510K or do we do more research to bring out a division certainly within our organization and our used, but there's studies out there that use very liberal definitions of diagnostic yield as well. We'll talk about this more tomorrow in a talk that I have on diagnostic yield. But again, these could be very, very different. If you look at this is just an experimental cohort, but again, depending on how you define diagnostic yield, you could have yields that are 20% different. You could go from 89% down to 66%. Same patients, same outcomes, defined differently, huge differences in diagnostic yield depending on how you define it. The Navigate trial, which is one of our landmark trials, they reported out a 72% diagnostic yield, but if you use a strict definition filter, their yield drops to about 54%, which is a coin flip. A coin flip which is free, navigational bronchoscopy which is not. Look at all the robot trials out there in the literature. Their diagnostic yield has been all over, definitions has been all over the place, from non-existent to intermediate to strict. So how do you compare studies? One study that says I have a 98% diagnostic yield, but used a very liberal definition of diagnostic yield. Well, cancer prevalence also, right, also impacts this. In the United States, it's a huge problem because in the shaded areas in the United States, there's a significant amount of benign fungal disease causing nodules. So if I'm when things are all over the place the way they are. And what are the correct endpoints? Is diagnostic yield really the right measure of success, right? Should we consider other endpoints, such as diagnostic accuracy, such as tool and lesion? I would argue that a radiographic tool and lesion, if I could put a needle out into a nodule, prove that the needle is in that nodule radiographically, I think that I've done exactly what the technology prepared me to do. Everything else after that is completely separate from the technology. How I do the biopsy, how the slide is prepped, how the pathologist reads it. So I would perhaps argue that tool and lesion may be a better surrogate than diagnostic yield. Again, these aren't things that are discussed right now in our medical literature. So, you know, in the US we have this term, don't compare apples with oranges. And the same thing goes for the clinical trials. So if you can't compare these clinical trials, what do you do? How do you do this? And how do you mitigate this when you want to bring a device to the FDA for approval? So, in my summary opinion, in Kyle's font, in my opinion, I think clinical trials prior to FDA approval are expensive, time-consuming, and they're very difficult design in a variety of ways. And as a result, vulnerable, at-risk, and really in-need patients who could benefit from technology are prevented from obtaining potentially beneficial diagnostic therapeutic procedures. The 510K process, certainly not perfect, but to expedite a new technology that can help people to the market, I think is the best way of getting cutting-edge technology to the market. We should just get things to the market and have robust post-marketing surveillance, especially for safety, which is critical. You could do these clinical trials, word of mouth, however you want to do it, but all these things influence adoption. And trust me, if we bring a technology to the market that doesn't work, nobody's going to use it. If you bring a technology to the market that works extraordinarily well, people are going to talk and they're going to say, hey, I'm doing really great with this. You should get this. You should get this. And that's, I think, how robotic bronchoscopy has just mushroomed in the United States. And I think that's how things should be. Again, just my opinion. But again, I'll end this on the famous economist John Keynes, who said, markets are moved by animal spirits. That's us. That's us people in this room, and not by reason. Thank you.
Thank you so much, sir. Any comments from the chairs are welcome.
Great talk, Joe. I mean, I think you've highlighted beautifully the dilemmas between research, time over research, but at the same time, I think the counterpoint would be that if we don't do research, for example, a very simple scenario for ion bronchoscope, robotic bronchoscope, is that we could probably sample more than 50% of the nodules that they're recommending with very cheap, effective transthoracic guided CT guided biopsy. So really, to get this incremental progression in medicine, it takes time, but that way we get the right answers.
Yeah, look, I agree with you, and that's why I showed the data from the Da Vinci robot, right? It's a surgical robot, has never been proven to be superior to laparoscopic procedures, but way more expensive. And you know, I think there are analogies to robotic bronchoscopy that could be applied and lessons learned. That being said, I don't know how you right now go about fixing that problem.
So it's not. So I think the answer, in my view, is that it's not that we should cut research. We need to reduce the time it takes, and the only way to do that is to choose the correct endpoints.
Correct.
Yes, there is a question and then...
Is that Dr. Toma? I can't see.
I have just a question waiting for Tom.
Okay.
Thank you, Joe, for your presentation. My question is regarding the endpoints.
Yeah.
So we are dealing with very small nodules.
Yes.
And the biology of these nodules, even if they are tumors, are not yet well known. So what can we define the endpoints when we are dealing with these small nodules? Is it better to wait and see, to have some other elements to detect biologic behavior, or just to biopsy them?
So if you come into some of our chat groups, you'll see this argument. There's one going on just yesterday. Not an argument, but a discussion. Look, these robots, the robotic bronchoscopy in the U.S., when paired with imaging, really, you know, Pavlov in the UK is doing this. You could really get down and get a tool in a 7 to 8 millimeter nodule very easily, and you get tissue. You could get great tissue with needle, forceps, cryoprobe. But just because you can doesn't always mean you should. I think that you have to be a responsible physician, do the right procedure on the right patient. Maybe look for radiographic progression before you do things. You know, doing something and having the wisdom to do something are two different things. So it's a great point. And how you regulate that, you know, I don't think you can. I think it just has to be on an individual basis. There's in the U.S. we call them quacks, right? They're quack doctors, you know, everywhere. I can't control that a doctor 10 miles down the road is not as good as me. It's just the way it is. You have to, I think that the only way to kind of move forward is you do your procedures, you track and report your quality, your outcomes, and let the patients decide where they want to go.
So I hope the microphone works. I'm Tudor Toma. I work in London. I've been involved many years ago with the endoscopy.
We cannot understand. Can you?
Just right here.
Echo.
So just do it here.
I've been involved with the endoscopic lung volume reduction from the very beginning, and it took 20 years for this procedure to be approved. The main reason at the beginning was that the FDA was requiring an endpoint for the trial, which was not the right endpoint. This procedure was called volume reduction, and they were looking for FEV1. So what does the American community do for synchronizing the FDA with the realities of clinical medicine? That's the first question. And I have a comment regarding your fonts on the PowerPoint.
Oh, thank you.
So the way to solve that problem, you go into preferences, you save the file with embedded fonts, and it will come up with a good font.
Did you get that, Hogarth? Having worked with the FDA myself, they're very, very difficult. We could talk for hours on the FDA. They don't have the right experts on their experts panel. When you go to FDA and you negotiate with the FDA for a robotic bronchoscope, they may have an anesthesiologist, a pediatrician, and nothing against them, and an ENT surgeon on the panel. They don't understand what we do, so it's very, very difficult. Look, I showed you in my talk, I don't think diagnostic yield is the best outcome because our technology to get to a nodule does that. It gets you to the nodule. After that, you know, the cytology interpretation, how you process your sample, that has nothing to do with the technology. I would argue that the robot exists to take me to the nodule. I mean, there's surgeons here. You go and do your wedge resection, right? And if you do a wedge resection and it comes back, non-diagnostic or benign, is that your fault? No. I mean, if the pathologist isn't good reading it, is that your fault? No, we don't judge you by the pathologist. We shouldn't judge the technology by that. So that, endpoints, I think, are incredibly important in how we move forward. I just think we're using the wrong endpoints. It's just my opinion, but it's hard to tell a patient that, right? Yeah, so
thank you. I think in sake of time, we have to stop.
Okay, thank you.
Thank you so much, chairs, for the valuable insight. Moving on to the next session on endobronchial ultrasound, mediastinum and beyond, we have for the first lecture, Professor Felix Herth. He'll be taking us through 20 years of EBUS TBNA.
Good morning. So moving back to the stuff we already have in our hand, which is approved, which is reimbursed, and not talking about what is coming next. So it's a pleasure to be here again in Hyderabad, and I want to thank Hari and his team to inviting me. And my privilege is to show you how the development of the EBUS happens. So no data, only pictures. My conflict, Olympus Medical, is on, and I have had the privilege to work with that company for a long time, and I will show you what we together brought to the market. So I should talk about the history. So what happened, what was the clinical scenario before the 2000s? We have had the CAT scan, and I just talked with Stefano Gasparini. He started working in bronchoscopy, not even having access to the CAT scan. So I was privileged that we have had CAT scans, we have had patients with nodules, and we have had patients with lymph node involvements in the mediastinum. And our job was, and it is today, to stage the patient and then debate the patient with the colleagues how we can treat such a patient when he is suffering on cancer. And we use the same tools in the early 2000s than we are using today. We're using the TNM classification. We use the 5th edition. Now we're using the 9th edition. But I brought you that edition, and you see the lymph node in the mediastinum has been very important in the earlier TNM classifications like it is now in the actual TNM classification. So for us, the point is we have to know what happens in the mediastinum, and we should be able to do that via the endoscope. Because when you go back to the data regarding the CAT scan, and PET scanning was coming slowly in the market in the early 2000s, so we only have had CAT scans. When you only measure the size, we know by a lot of data that we maybe can also throw a coin if that lymph node is maybe malignant or it's a benign lymph node. So only measuring the image was not the solution, so we need technologies. And we have had technologies. Professor Copeland from Johns Hopkins brought in TBNA in 1978. In 1983, he published papers on the flexible needle. So therefore, an endoscopic technique was available where we should be able to stage the mediastinum in a proper way. But there have been papers published that TBNA is a great technology, but for whatever reason, the technology never really made it to the market. There have been surveys, the UK, the US, 10%, 20%. When you talk to the colleague, the reasons why they don't use the needle without any guidance system was more or less, it's a blind procedure. So I've stolen a picture from Stefano Gasparini's talks. It might be that you never hit the lymph node because you weren't able to see the lymph node. So therefore, the question was, what can we do to maybe have access to the mediastinum? And then we have done intensive research and came up with the radial EBUS probe. So radial EBUS probe was the beginning of endobronchial ultrasound in the airways. It was the first prototypes have been there in 1996, and then that balloon sheet was developed, and by having that balloon sheet added to the tip of the ultrasound probe, we were able to see the mediastinum, and this have been the lymph node seen by the radial EBUS probe. And at that time we thought, okay, now we can do that. We have seen where is the radial EBUS probe positioning, so 5th cartilage rings or 1 cartilage ring above the main carina, 11 o'clock position, and then we changed that radial probe to the needle, and that we did a second two-step procedure, so detecting the lymph nodes by the radial EBUS and then sticking in the needle in the second step, and we published that. But it still was cumbersome procedure. You have to do the radial EBUS first and the needle in, and on and on and on. So therefore, there was a meeting, and this is the original picture, and it was in a side room in a meeting of Franco Falcone in Bologna at that time, where Kazuya Fuku, a surgeon working at that time in Chiba, now had in Toronto, Mike Krasnick from Denmark, and myself met the Olympus engineers, and we asked them, can we get EBUS scope, a scope where we have the possibility to see the lymph nodes and do the puncture in the same time. And then the story started. That has been the first prototype. It was called the bumper scope. You see the needle is just shooting out straight ahead. And we have that ultrasound head, and there was again a balloon on. But you can imagine that we have seen the lymph node, but the needle was going in a completely different direction. So not really feasible, but not really useful. Then we tried to change the head of the ultrasound tip. Now the head was a little bit somehow comparable like you know it today, but the point was the needle was still shooting straight ahead, and therefore you have seen the needle for a short period when it just moved through the ultrasound image, but then you lost the control, so also it didn't work. And then really in 2002 we have got back from the engineers from Olympus for the first time the scope, which looks a little bit like the EBUS scope we have in use today. Now the big change was that the working channel where this needle is coming out is not longer straight ahead. It has the angulation that you really can follow the full time during the EBUS procedure, the way of the needle into the target. When you look at the end, it looks a little bit comparable to the GI scope Olympus developed. The GI scope has that elevator where you can change the angulation of the needle. That is, for size reason, not really possible by the bronchoscope, so therefore we have that angulation. And in 2003, then the final prototype came to Copenhagen, Chiba, and Heidelberg, and we did the final testings, and that is the scope that looks like the scope which was launched then in 2004. Next to that development of the EBUS scope, and there was a lot of development on the ultrasound processor itself, how many crystals, how you should position those crystals to get the image back. We worked on the frequencies, which we are able to get by different crystal settings. So there have been a lot of technical development on that, but on the other hand, there was a huge development on the needles. Because when you go back to Copenhagen, the needle is, the classical TBNA is the needle is not fixed, so you move the needle through the working channel. So initially we have used that Wong system, that wrong technique, but now we learned that we have to fix the needle with the sheet at the hub of the scope. So during that development of the needle, there was also, of the scope, there was also a huge development on the needle type. At the end, that was a product which has been launched in 2004, the needle. The scope, since that time, we have got smaller eboscopes, we have had eboscopes from other companies, we have now 8 companies providing us needles in different sizes with different tips of the needle, but at the end it's still a scope which have an angulated working channel, an ultrasound processor at the tip, and you can fix your needle that you protect your scope and you have a target procedure. The first publication, we debated that from the beginning, who is publishing what. So the first publication came from Mark. He reported that in 10 patients, and since that time, I don't know, I didn't count that, we have since 100 of EBUS papers, and at the end, in the CHESS guideline 2013 published, it was recommended for the first time that EBUS TBNA should be used as the technology #1 to diagnose the mediastinum. So at the end, it took us 6-7 years to develop the system, and it took us 9 years to bring a technology from the first time used into the guidelines. And as we have heard by the talks from Joe and others, it's nowadays more and more complicated, but I think our job as bronchoscopy is to creating the evidence that we really can have an idea how good the technology is, where we can work it, where are the limits and where are the hurdles, and I believe with the EBUS TBNA scope, that is a success story for our field. So therefore, we really can improve patients' care. We have a very easy handle technology, and it took us 9 up to 10 years to really bring a technology, having it for the first time in our hands into the clinical guidelines. And nowadays, EBUS TBNA is still the most used technologies when we want to diagnose lesions in the mediastinum, and having access to smaller and smaller EBUS scopes, I'm relatively sure that we're also moving those scopes in the near future more in the peripheral part of the lung. And therefore, I thank you for your attention.
Thank you so much, sir, for making us walk through 20 years of EBUS TBNA. For the next lecture, we have Professor Jürgen Etzel. He'll be talking about mediastinal cryobiopsy, evidence-based review.
Dear Chairman, thank you very much for the kind introduction, and Harry and his team that he organized that so well and invited me to this prestigious conference. In the next 15 minutes, I will give a short overview on mediastinal cryobiopsy. And if we think about mediastinal lymphadenopathy, we can order it in 2 main categories: malignant causes and benign causes. And most often we have the question when we have large lymph nodes whether it's a metastasis. And as Felix already pointed out, for metastases in the guidelines, EBUS TBNA or EUS TBNA is the first choice for tissue sampling. So what is with other primary cancers like lymphomas, myeloma and leukemia, or benign causes? And we know from studies that with EBUS TBNA we can make the diagnosis, for example, of sarcoidosis. And in this review here, the diagnostic yield was between 79 and 92%. So we don't have in all cases the diagnosis. And furthermore, we don't have in non-small cell lung cancer, in all cases, enough tissue for molecular genetic testing in the studies published so far, and it depends probably on the center, but it was between 20 and 40%. You can't do that at EBS-TBNA samples. And why is that? The reason for that is that we have small tissue samples and few cells, and the question is cryobiopsy here helpful? And if you talk about cryobiopsy, that's a transbronchial lymph node cryobiopsy, that's a sarcoidosis patient, that you get an impression how it looks like. The first paper published on this technique was published from Zhang. He had a patient with a mediastinal mass, and he couldn't get into this mass with another technique. So he performed a bronchoscopy with local anesthesia and midazolam. He used a 22 gauge needle and did 4 passes, and additionally he created a tunnel to the lymph node with an electric needle knife. He took 2 biopsies, and he had a freezing time of 15 seconds with a 1.1 cryoprobe, and he could make the diagnosis of a seminoma. Shortly after, there were the two main studies published from the same group. The first study was a study when they did a cryobiopsy and a TBNA in a randomized sequence. And they compared these 2 groups. They biopsied all lymph node stations, mainly for R and 7, but also the other lymph node stations. And it was quite well balanced between the both groups. And there was a significant difference in the diagnostic yield. 80% for the TBNA group and 92% for the cryobiopsy group, and that was statistically significant. Why was that? If you go into more detail, we had no difference in lung cancer patients. It was 66% in both groups, but there was a difference in lymphoma and benign disorders, mainly sarcoidosis and tuberculosis, and these differences drove the statistical significance. They had only minor bleeding, 2 pneumothoraces, not requiring a tube on 1 pneumomediastinum, also no intervention needed. Shortly after that, they published another study in Lancet Respiratory Medicine in 2022, including 297 patients, and 271 patients were enrolled. They compared 2 groups, either only EBS-TBNA or EBS-TBNA followed by cryobiopsy with the 1.1 millimeter probe. Again, almost every lymph node station was punctured, which is accessible with EBS, and again we had the same result. The definitive diagnosis was 81% in the TBNA group, and in the combined group was 93%. The procedure time was, of course, somewhat longer with the cryo group, and they had a few pneumothoraces and pneumodiastinums. Interestingly, there were 4 pneumothoraces after EBS-TBNA, and not only in the combined group. And as shown in the first study, the difference was driven mainly by lymphoma and by benign disorders. Lung cancer staging, there was no difference. Then let me address how they did it. That's different from center to center. They used an electric knife for tunneling. Then they introduced a 1.1 probe. In this study, they froze 7 seconds once. Let me show you a few other studies. That's a study from Hari here from Hyderabad, and he described 4 cases, and he described for the first time a tunneling technique with a needle. He froze 3 seconds and used a 1.1 probe. He didn't describe complications, and he was successful, and he could make the diagnosis in all cases, but we have to be honest, with the TBNA, we had also the diagnosis in all cases. The study from Arisa from Spain, he used also the tunneling technique with a needle. He took 3 biopsies and froze 4 seconds. And again, it was much better in the lymphoma and benign conditions, but he also had more often metastases detected in lung cancer than with the cryobiopsy compared with TBNA. But we have to admit that 78% diagnostic yield or sensitivity for EBAS TBNA in lung cancer is quite low value. There's also one study which didn't show a difference. That's a study from Gershman. He published 24 cases. He used a Procord needle with 4 passes, and he additionally used, if he couldn't pass the tunnel, a neodymium YAG laser to tunnel, to create a tunnel. He took 2 biopsies, in 18 cases with the 1.1 probe and in 6 cases with the 1.7 probe. Most cases, as you can see here on the right side, were sarcoidosis and cancer. And in with the cryo, he had a 1.1. He was diagnostic in 88%. With the 1.7, all cases were diagnostic, but there was no difference between TBNA and the cryo. And in fact, once diagnosis was missed by TBNA, and cryo made the diagnosis, and vice versa. And finally, the last study, the latest study published so far from our Swiss group, we collected 138 patients, and we had the same results as the Chinese and Heidelberg group. In lung cancer, there was not a difference between needle and the lung cancer, but if you look at the non-definitive diagnosis group with the TBNA, they switched to the benign disorder in a relatively large proportion. Let me go to a further point. So that was the first study we published on cryobiopsy as it's used today. And because we had the experience that cryo extraction was not very popular, we thought to use a very interesting title, and we called it The Use of Traditional Cryoprobes. That means a cryobiopsy in the age of molecular biology. We didn't know that time that this may be relevant in the future, to be honest. That's 2 case reports, one of a Japanese group. They couldn't make the diagnosis of this nodule here. Then they started to use a mediastinal forceps biopsy, but you can see here the squeezed tissue, and additionally there was, and in this case further analysis was not possible, and then they used a cryoprobe, and then they could make the diagnosis, and immunohistochemistry was much better possible, and it was a sarcoma. That's a case from Winterthur. That's a patient with ECOG 3. You couldn't go for chemotherapy, and we didn't get any tissue for molecular genetic testing in this patient. And so we did a cryobiopsy, and he had PD-L1 of 100%. And that's in line with the data which are published in the Lancet Respiratory paper from FAN. They described out of the non-small cell lung cancer patients, they could make the diagnosis with cryobiopsies in NGS testing in 97% of the cases and in 79% of the samples with the EBAS TBNA. So it seems that cryobiopsy may be superior here, but that's not proven. So these studies were summarized in systematic reviews and meta-analysis, and I show you one of these systematic reviews and meta-analysis. The design, to be honest, is only 2 randomized controlled trials. Then we have some prospective trials, and then then we have a case series. The sedation was also different. Some used general anesthesia with laryngeal masks, some used moderate sedation, and some used a tube. And finally, the tunneling technique was different. Mainly in the randomized trials, they used an electric knife. In the other studies, it's usually that they created the tunnel with a TBNA needle. So the needle which was used was also different. Usually a 19-gauge needle or 22-gauge needle was used, and the number of passes also differed, ranging from 2 to 7. For the cryoprobe, mainly the 1.1 probe was used. 1 to 7 biopsies were taken, and the average freezing time was 4 seconds. But that was also different from center to center, and in fact, we have no comparative trials. We don't know what's the best. But taking these together, the diagnostic yield of the cryobiopsy was better than with EBAS-TBNA. And in the funnel plot, there was no hint that we had a selection bias with these studies. The other meta-analysis showed also this advantage of the cryobiopsy, but the third meta-analysis claimed that we don't have enough data yet to make a distinct suggestion. So, in these 3 meta-analyses, it was described quite nicely, and I think that's true, that benign and possible lymphoproliferative diseases are better diagnosed with the cryoprobe compared with TBNA. Moreover, and that's also clear, that we can more accurately classify lymphomas with a cryoprobe than with the EBAS-TBNA, especially in Hodgkin's lymphoma. It may be also that cryobiopsy is superior, but that's not proven in molecular genetic testing of lung cancer. Coming to the complications, we have, they had only few complications described, pneumothoraces and mild bleeding, nothing relevant here, and no intervention needed so far. But that's not in the English literature. That's a German case published in Pulmonology in 2023. That was a cryobiopsy sample. That was a patient. They punctured this lymph node, and the patient developed a severe hematomediastinum, and luckily he survived. There are vessels, and they probably hit these vessels. So it's a technique, and not a lot of complications, relevant complications were described so far, but there may be complications if you do it in the wrong way and you hit vessels within a lymph node, or if you are not very controlled where your cryoprobe is when you take your biopsy. So in these meta-analyses, they say it has proven to be safe and is safe. I think you have to be cautious to state that in this way, because we don't have a lot of data and we don't know whether there will be some additional complications in the future, and for sure you can harm the patients if you don't do it in a proper way. Finally, I want to compare the forceps with the mediastinal forceps with the mediastinal cryo, and that's a series from India. They compared the EBAS-TBNA, EBAS-TBNA plus cryo, and EBAS-TBNA with forceps, and forceps in 34 patients, and they didn't see a difference in the diagnostic yield. However, the power of this study was fairly small. Another study published by Cheng in Pulmonology, they evaluated 155 patients. They did a EBUS TBNA followed by forceps biopsy or by cryobiopsy. If you compare TBNA plus forceps and TBNA plus cryo, there was no difference between the groups. If you compare forceps and cryo alone, there was a difference in favor of the cryobiopsy. And additionally, as mentioned previously, cryobiopsy was superior in the molecular genetic testing. So let me summarize. EBUS guided mediastinal cryobiopsy seems to be superior to EBUS TBNA in the diagnosis of lymphoma and benign lymphadenopathy. It seems to be equivalent for staging of lung cancer, molecular genetic testing, if necessary, and that has to be sure, is probably more often possible. We have rare complications, but we had one report of a mediastinal bleeding, so we have to be careful what we do, avoid vessels, biopsy on the bronchial side of the lymph node, and so on. And probably we don't know all complications which may be detected by the published data so far. So additionally, I want to mention, I think really that we have not sufficient data so far, and further studies are needed, especially addressing the patient selection, the complications, and the technique, including the mediastinal cryobiopsy via the esophagus. Thank you very much for your attention.
Thank you so much, sir, for the detailed evidence-based review. For the next talk about the applications of EBUS beyond the mediastinum, we have Professor Stefano Gasparini.
Hello, good morning everybody. It's a great pleasure and an honor for me to be here, and I thank the scientific committee for this kind invitation. Well, my topic will be EBUS TBNA, not only mediastinum. This is my conflict of interest disclosure. Well, this is the history of bronchoscopy. A lot of steps and a lot of new technology. But if we have to look at this history, we see that there are just few steps that really changed our way to perform bronchoscopy. Of course, the introduction of flexible bronchoscopy, the introduction of a flexible TBNA that opened the door of mediastinum to the bronchoscopist, and the introduction of EBUS TBNA. These are the pioneers of EBUS TBNA, as Professor Hert already showed us, Mark Krasnik, Casimiro Yasufuku, and Felix Hert. They demonstrated that the sensitivity of EBUS TBNA for staging was greater, higher than 94%, with a very, very high specificity. And according to this data, as Professor Hert showed us, some years later, EBUS TBNA was introduced as the first step for mediastinal staging in lung cancer by the guidelines. These are guidelines from the American College of Chest Physicians, but all the guidelines introduced EBUS TBNA for the staging of mediastinum. However, with the use of the convex echobronchoscope, in the following year we realized that such instrument was useful not only for the mediastinal staging, but also for diagnosing other conditions like pulmonary lesion, like some peripheral lesion in the lower lobe, like some pleural lesions adjacent to the mediastinum. The possibility to diagnose endovascular lesion was also possible. And with the EBUS probe, with the echobronchoscope, pulmonologists learn to go through the esophagus. Esophagus is a motorway that is going through the thorax, and thanks to the echobronchoscope, pulmonologists learn to use this way. I would like to show this possibility with practical example, with practical clinical cases. That is the main topic of my presentation. Start with the diagnosis of pulmonary lesion adjacent to the airways. You can see here a pulmonary lesion in close to the trachea. Well, the possibility to perform EBUS TBNA, the lesion is very well visible if you put the tip of your echobronchoscope on the lateral posterior angle of the trachea. And this is the diagnosis, was squamous cell carcinoma. Going close to the main bronchi, you can see here 1 centimeter lesion adjacent to the right main bronchus. It's very easy to visualize this lesion and to sample using EBUS TBNA, and you can have a diagnosis of adenocarcinoma. It's very easy. Going more in the periphery, this is another lesion that is close to the right main bronchus. You can see the echobronchoscopic view, the needle inside the lesion, and it was an hematoma. Here is a lesion that is close to the left main bronchus at the beginning of the left upper lobe bronchus. And you can see here the possibility to visualize the pulmonary artery that is close to the lesion, and very well the lesion that it's easy to sample using EBUS TBNA. And again, this is an adenocarcinoma. But if we move more in the periphery, you should know that it's possible to wedge the tip of your echobronchoscope in the segmental bronchi. For instance, these are 2 cases of lesion in the middle lobe. If it's possible to wedge your echobronchoscope in the middle lobe bronchus, and such lesion can be easily visualized, look at, and the fluoroscopic view of your echobronchoscope into the middle lobe bronchus, and the diagnosis was carcinoid in such case. And again, another lesion in the middle lobe bronchus. Insert your echobronchoscope peripherally to the middle lobe, into the middle lobe, and you can visualize the lesion also in this case. And here is the fluoroscopic view of your echobronchoscope, and the diagnosis in such case was adenocarcinoma. This is Galileo Galilei, an Italian scientist that in 1564 was born close to Florence, and it's very famous, his sentences, and yet it moves. It was referred to the heart. But yet it moves, we can also refer to the trachea. The trachea can be moved inside the mediastinum. And if you have a lesion, like in this case, that is not adjacent to the trachea, there is no problem. Bend the tip of your echobronchoscope, move the trachea toward the lesion, and put the trachea in contact with the lesion, and you can visualize the lesion, and you can get diagnosis even if there is 1 centimeter distance from the trachea to the lesion. Peripheral lesion. You can try. If you have a bronchus greater than 3-5 millimeter, you can wedge in that peripheral bronchus the tip of your echobronchoscope. And you can see here the very small peripheral lesion in the right lower lobe is 1 centimeter more or less, but there is a bronchus that is 5 millimeter very close to the lesion. If we put our echobronchoscope in this peripheral bronchus, we can visualize very well the lesion, and the diagnosis was carcinoid. Look at this nodule, 8 millimeter nodules in the right lower lobe. If a patient came to your hospital with such a lesion, what do you think? What is your approach? You can think, oh my God, I don't have combine CT, I don't have robotic bronchoscopy, or it's very difficult to perform percutaneous needle aspiration of such a small nodule. But if you look carefully to the CT scan, you will see that there is a bronchus, 5 millimeter, that is close to this small nodule. Well, if you are able to insert the echobronchoscope in such subsegmental bronchus and to wedge the tip of your echobronchoscope, you can visualize this 8 millimeter nodule, and it's possible to perform a safe sample with a high probability of diagnosis. And this case was a metastasis of urothelial cancer. So another very small nodule with a large branch of the pulmonary artery very close. So in this case, even it's difficult to hypothesize such approach using the tools that we have for peripheral lesion. You can visualize with your echobronchoscope inserted in this small bronchus that is close to the lesion. You can visualize the artery, you can visualize the nodule, and you can perform the sample in a safer way without involving the large branch of the pulmonary artery. Now we are on the left side. This is a peripheral nodule of the left lower lobe. You can see there is a very evident bronchus very close to the lesion, adjacent to the lesion. And you know that using a mini probe, radial hebus, when you have a lesion that is not in but is adjacent to the probe, the possibility of diagnosis are lower. In such case, you can visualize such lesion and you can perform your biopsy. Another nodule of the left lower lobe, and again, the echobronchoscope wedged in the periphery of the left lower lobe, and the sample performed demonstrated it was lung cancer, probably adenocarcinoma. Another very small nodule of the right lower lobe. Here is your echobronchoscope wedged in the periphery, the visualization of the nodule, and the diagnosis was a metastasis of melanoma in such case. And look at the number 13. There is a nodule very close to a bulla of emphysema. High risk for pneumothorax if you perform a percutaneous needle aspiration in such case, where we can insert our echobronchoscope in the periphery of the left lower lobe, and we can do diagnosis of such nodule that was lung cancer, adenocarcinoma again. Look at this. This is the first case, to my knowledge, where the echobronchoscope was inserted to this nodule that is close to the diaphragm. and to pericardium. And this is the first image of pericardial sliding observed to an echobronchoscope. Sorry, this was close to the diaphragm, number 14. Number 15 is close to the pericardium, and you can see here the pericardial sliding in this moving. It was possible to sample this lesion that was a metastasis of breast cancer. And you can see the pericardium observed through the linear echobronchoscope. We collected about the first 30 patients that we did with the pulmonary peripheral nodule less than 3 centimeters. The limit of this technique is that it's not possible to sample nodule located in the upper lobes because it's difficult, it's impossible to insert in the periphery the echobronchoscope in the upper lobe. So these 30 patients had a nodule located in the lower lobes bilaterally, and it was possible to visualize with endoscopic ultrasound the nodule in 28 patients, and in this 28 patient diagnosis was obtained in 86.6% of cases, and 92% if only the 28 patients in which the lesion was visualized were considered. No adverse event with this technique. The esophagus, I mentioned it before, is a supplementary way through the thorax, and it is a new way, thanks to the echobronchoscope, is a new way for interventional pulmonology. We can sample lymph node not adjacent to the airways, like station 8 and 9, and we can sample also paraesophageal lung lesion, paraesophageal pleural lesion, liver metastasis, and left adrenal gland metastasis. You can see here a pulmonary lesion that is very close to the esophagus, and we can visualize very easy this lesion inserting our echobronchoscope into the esophagus and make a sample. Here is another lesion. Also, the esophagus can be moved into the mediastinum by bending our echobronchoscope and bringing the esophagus in contact with the lesion, even if there are 1 or 2 centimeters of distance from the lesion and the esophagus. And this is a large mass of the left upper lobe that can be easily visualized through the esophagus. This is a pleural involvement, and you can see through the esophagus how this pleural mass was well visualized. And look at this lesion that is adjacent to the vertebral bone and to the spine, and is PET positive in a patient that already underwent a surgery, upper lobe lobectomy for adenocarcinoma. It's difficult to sample in other way, but there is the esophagus that is close to this lesion, and you can see here the sampling and the visualization and the sampling using endobronchial ultrasound, transesophageal ultrasound bronchoscopy and fine needle aspiration. Unfortunately, it was a recurrence and localization of adenocarcinoma. This was a mesothelioma, a mass, pleural mass, intensively PET positive, and you can see here the needle inserted through the esophagus, the visualization of the pleural mass, and the sample to diagnose a mesothelioma in this case. It's possible, of course, to sample left adrenal gland metastasis. This is the normal appearance, like a bird, of a left adrenal gland, and this is a metastasis, left adrenal gland metastasis, diagnosed using ultrasound transesophageal approach. Well, the possibility also to diagnose vascular lesion. There are several papers that demonstrate that it's possible to make a differential diagnosis between pulmonary embolism and pulmonary artery tumors like sarcoma. You can see here how we can visualize the pulmonary embolism using our HIBUS TBNA and the possibility to have a neoplastic embol close to the tumor, like in this case, this is neoplastic embolism that was close to a pulmonary mass, very well visualized using our echobronchoscope. Well, someone can ask, but it's possible to have also a molecular evaluation of the samples that we have for such pulmonary lesion. There are a lot of papers that demonstrate the value of HIBUS TBNA in the molecular characterization of pulmonary tumor. The most important step is the correct management of the sampling. We routinely used both smeared cytology and core biopsy cell block for histological evaluation. And through a single pass of HIBUS TBNA, you can see here how many tissue, how many core you can obtain. This is a single pass, and the amount of tissue is much more than one single forceps biopsy that you can obtain. So, in conclusion, HIBUS TBNA changed our diagnostic approach to pulmonary tumor and to pulmonary lesion, greatly increasing the sampling possibility of bronchoscopy. Of course, HIBUS TBNA is a very important means for lung cancer staging and for diagnosis of hilar mediastinal lymphadenopathies, but it is also an invaluable instrument for diagnosis of several pathological conditions involving other structure close to the airway and to the esophagus. Most important thing is the correct management of samples that is always necessary to optimize our results. Thank you very much for your attention, and this is the hospital in Milan where now I have the luck and the honor to work. Thank you very much.
Thank you, sir, for your extremely valuable talk. Our next topic for the session is Beyond EBIS for Station 5 and Station 6 by Dr. A.B. Elrais.
Thank you for the invitation and for having me here. I'm gonna go beyond the EBIS and see if what we have now available with the robotic options, especially for those lesions that are talking about the para-aortic lymph nodes, when we have a PET scan that lighting up there. So I'm implementing the use of robotic assisted bronchoscopy for sampling those lymph nodes. We have a short list of patients that we did already, but more important, powering the real-time imaging that work with this technology at the same time to get the images that you can see and confirm that your tool inside those lesions and avoid puncturing any of the major blood vessels. And also, which patients you can use and use this technology on to help. And some of what we learned from doing those cases how we can enhance using this. And at the end, we end with a case demonstration. But really, I'm highlighting that the availability now of the augmented fluoroscopy that help us confirming that we are in the right lesion, adding on that the robotic-assisted bronchoscopy navigation and that augmented together. And that's give us some time, help to know where we are standing and where we are exactly in the lung to avoid the side effect. And this is where we are dealing with this time of the era of what we have in our hands that we can use for this type of lesions. But we're starting with this case that a patient has already diagnosed lower lobe adenocarcinoma ended with left lower lobectomy, continue to be on surveillance, and the radiology report 2 years later after the 3 years after the lobectomy showed mediastinal lesion that concerning for malignancy. As you see in this CT scan, there is a post-surgical changes, and there is anterior mediastinal lesion. And that lesion continued to be called by the radiology concerning for recurrence, sampling recommended. So for this location, what usually we do? We biopsy or we don't biopsy? That's one question. And if we need to biopsy, which way we should go, giving the patient history of CABG before, and also the location of the lesion. So the good thing that just for this lesion was not a metastatic, it was an aneurysm from the CABG anastomosis that he had before, and that was a stent that reflecting there. So just a learning curve for us always that we should not sample everything. So para-aortic lymph nodes are those nodes that sit in the other side of the lung, the trachea that we can reach with EBUS. And usually, really, Chamberlain procedure is the most approach for these lymph nodes. And as you see now on this diagram, that they are sitting on the anterior part of the thorax, and also para-aortic or pulmonary artery, left pulmonary artery, as we know. Some of them can be reached by EOS, but not the case when they are small as well. And from Chamberlain procedure, it's usually doable, which is the right thing, and most of the time is outpatient, but still it's an incision, need admission to the hospital, sometimes stay overnight, but some contraindication, as we know, post-radiation for the chest, previous sternotomy, of course, superior vena cava syndrome and tracheostomy and aneurysm, of course. But if we look at other options of doing it, so looking at using the robot through the airway and making that angle toward the anterior part of the left mediastinum and getting sample with TBNA, that's what we were talking about. And really in our favor, if the patient has a previous surgery or radiation, that makes the sampling more safer from our end, that by reducing the risk of pneumothorax on those cases. So we start the case for robotic bronchoscopy by, in any case, planning, but when we plan those cases, we highlight the lymph node, and really we need to extend any airway going in that direction to get to that area. And we get really understanding of the map and the direction of those locations. And when we have that understanding of the airways, we move to the next step. And the day of the procedure, we spin first to highlight and segment where the lymph node is from the current day. And also we can extend a path for us to know where we are going, which direction. After we drive toward the lesion and we park, we place the needle in the same direction that we have highlighted before. And we do segmentation, as you see. The advantage of having that type of 3D imaging, segmenting the lymph node, not the lymph node only, but we have also the needle and also the scope itself. When we have that segmentation, it gives us understanding in the 3D where is that needle going out from the lung toward the lymph node, and exactly the projection of that needle to the lymph node. And when we have that option, we segment the lymph node, and then we can do measurement to know how far we can go out with the needle to get to the depth that we want to acquire a good sampling without hurting the neighboring major blood vessels. And having that measurement help a lot when we are inside, confirming that we are inside the lymph node. And when we have that already planned, we augment it on fluoroscopy. And you can see here, most of those patients has calcified rings on the aorta, which is help us also know in 3D where we are in relation when we do the augmented fluoroscopy. And that sign, most of the patients help to know in this projection, the AP, where we are. But then also we can change the angle to get the lateral view that allow us to understand where exactly we are in that projection. This procedure mandates a lot of continuous radiation because you need to do the samples really under life. We don't have the radial support because we minimize any kind of extra trauma to the path, and also you are going through the lung toward the mediastinum, which is most of the time the radial will not be able to give you a signal. So since you are depending on radiologists, and we start with centralizing the lesion, this collimation reduces the exposure and the timing of the fluoro. And then we are now, when we are in the same direction, you can see now we can go farther depth with the TBNA to collect the sample. So the steps usually start with always those patients. We didn't have a clear recommendation, but based on what we do before, anything going through the pleura, we start with NSAID 2 grams as prophylactic antibiotics. We do the initial spin to segment the lymph node from the current CAT scan. Then we move to the navigation, and we move toward the lymph node, put the needle, augmented with a fluoroscopy to augment, and we repeat the second spin to confirm we are in the right direction. We use 21 gauge needle just to minimize the size of the puncture in case pneumothorax can happen. Of course, the patient understands from beginning that we have higher risk of pneumothorax with this procedure compared with normal robotic bronchoscopy, but also we are comparing it with Chamberlain procedure that need the patient to be admitted. So they always prefer to go for minimal invasive path. And if you are picking a patient always that they have radiation before or they have open heart surgery, those usually they have more stable mediastinum to have that issue. Maximum samples we go for 5, and really we make sure that we have enough in the cell block. And as I mentioned before, radial EBA is not a tool that we can use in those cases from our limited experience, but I don't know if the future we can. And always we end with chest x-ray to make sure we have no pneumothorax or pneumomediastinum. There is no harm on repeating a third spin at the end because that will be more sensitive for pneumomediastinum and pneumothorax as well. So the 3 cases that done, they have, one of them has a contralateral right lower lobe adenocarcinoma that this light up on PET scan and shows lymphocytes. The other 2 were both ipsilateral nodules. One of them surprisingly ended with cryptogenic organizing pneumonia, not nodule, but the lymph node came back positive for adenocarcinoma. And the first patient was upstaged to N1 due to left upper lobe lung nodule, which is, the patient was non-surgical candidate because of the previous open heart surgery and ended for radiation, but the sampling helped to know the zone of the radiation that needed. So putting this together in the other cases that we did, you can see really using during the mapping when we are doing the segmenting, we put the PET scan image at the same time next to when we are doing the segmentation to make sure we are going really on the lung nodule, the lymph node that we want to sample. Even in these patients, this second case, as you see, developed a lot of atelectasis, but still you can get a good image because the lymph node more anterior and in the mediastinum. Segmenting again the lymph node and confirming you are in the target, and then having that reinforcement of the image always when we see the tool in target as we are going inside it with the most uptake lymph node that we saw. This helps us always knowing where we are and getting the sample. And when we apply the augmented fluoroscopy, in this case, for example, also the AP window was the best for us to get the best image, and also confirming with the TBNA that we are doing exactly the sample where we want the sample to happen without affecting and getting the tissue from that lymph node. So in summary, those minimal invasive sampling using robotic assisted bronchoscopy for station 5 and 6, integration of real-time imaging is very important because this is the only image that gives us a live update where we are inside the lymph node, avoiding the puncture of any major blood vessels. And the augmented fluoroscopy, very essential in maintaining that view and make sure that we did not move away from the target that we are doing and sampling. Same day procedure, selective of the patients, very important because it gives you the idea, especially when you have patients with previous radiation or open heart surgery. But we did cases also without no previous surgery or radiation for that location. However, those other indications for radiation and previous sternotomy, this will be more adequate comparing with using the Chamberlain approach. Thank you for the time and for the invitation.
Thank you, Dr. Alries, for your informative talk. Moving on to the next session, Year in Review in Interventional Pulmonology. I'd like to invite Dr. Tajalil Sagale for the talk.
Thank you very much for the introduction. Thank you. It's an honor to be here. It's a privilege. It's at this great venue. Very impressive, Harry, and thank you for the invitation. So I've been tasked to talk about interventional pulmonology year in review. Impossible task in 15 minutes, I would say. So I'm going to crack on, starting with the disclosures. These are my financial disclosures. You can see there on multiple screens. But I also would like to sort of highlight that I'm a researcher, investigator of a pulmonologist, interventional pulmonologist. So I pick the stuff that I talk about based on my own interests. And I do have my own opinions as well. So wherever you see that signal there, that means that I'm just basically making it up. So take it with a grain of salt. If you agree with it, or if you don't. So starting with the volume of research we have seen in last year, in the last 12 months, if you search interventional pulmonology in PubMed, you get 431 in 2024, and you can see that this logarithmic increase started about 15, 20 years ago, continues despite a bit of a hiccup around COVID time, so it's recovered and it's going on quite strongly. It'd be impossible to talk about 431 studies, but I've done a word cloud, and you can see that bulk of the literature is focused on bronchoscopy and diagnostic bronchoscopy in the context of lung cancer. So that's what I'm going to focus on. I've picked these based on my own interest and what I found interesting. So apologies to the ones that I've missed out. But focusing on nodules, diagnostic and therapeutic. Moving on to Lydia Eba's cryobiopsy. I know it's been talked about already, so I'm going to skip a couple of my slides. And also a few slides on bronchoscopic treatments of COPD as well. And what to look out for in 2025. It's going to be speedy. I'm not going to go into details because I just want to cover a few slides. Obviously, the details are there and you can look them up. I really want to discuss the statement, the consensus statement that came out in March 2024. Obviously, a piece of literature that's very important to discuss, but I want to start by a little bit of introduction, and it's fair to go back to 2022, talking about Vakani's publication on diagnostic yield. Important to highlight that this is a hypothetical cohort of 1,000 patients. It's not a clinical study, it's a simulation study based on what was reported in the benefit study. So pretty much doing some calculations to see, you've seen that already in some of the slides earlier today, that the definition of diagnostic yield pretty much depends on what you consider to be true positive, can significantly affect the diagnostic yield in the same test, the same cohort of patients. It can be variable from 66% if you're very strict and only consider specific benign and specific malignant diagnosis as true positives, all the way to about 89% if you consider other things including follow-up and so on and so forth. Moving on to the actual statement, it came out in March 2024. A group of experts on behalf of ATS and ACCP basically published 15 statements acknowledging the fact that there is variability in reporting outcomes of bronchoscopic lung nodule biopsy trials, which is a fact. They mentioned specifically Acquire versus Navigate, trying to explain why diagnostic yield was different, but also talked about the fact that if you have multiple studies that have been defining diagnostic yield in different ways, it will be impossible in the future to pool that data into a meta-analysis. That's also a fact. But they go even further and mandate the use of this strict definition of yield in studies, which I thought was a bit strange anyway. So if you wonder what is specific benign and what is not specific benign, I can tell you that this is what they have published. Obviously we know about malignancies, but specific benign diagnosis is the list that's there. So even if you have a patient with a pretest probability that this is an inflammatory nodule and you do a biopsy and you've got proof that tool is in the lesion and you do get inflammatory cells, in that scenario, that test is still considered to be non-diagnostic. Credit where it's due. So Vakani actually did another simulation with the team. Again, this was published in 2023, but looking at 1,000 index bronchoscopies, this time we're not talking about same test, same group of patients, different diagnostic yield definitions. We're actually talking about same diagnostic yield definition, same test, but different cohort of patients. You've already seen this in Joe's talk. This highlights a very strong relationship between cancer prevalence in the cohort of your patients affecting the diagnostic yield. So it makes things a bit more complicated. I mean, even if you have strict yield, still can't compare two studies because the cohort could be completely different. Depends on how many cancers you have. It also, I think, explains why we have difference in real-world studies in their yield versus the clinical trials, the prospective ones, and that the reason is because we are very selective in the prospective ones. The pretest probability of cancer is higher, usually around 70–75%. That brings the diagnostic yield higher. But when you're in clinic and lesions and nodules are referred to you and you can biopsy them, you do them, cancer prevalence in those cohorts is usually around 50%. Your diagnostic yield drops. So these are important things to consider. I'm going to move on from that. I'm very passionate about it. I just have to move on in life. So in terms of summary, the definition of yield is variable in studies. We've talked about that. The new consensus statement mandates the strict method of reporting yield, but it's affected by prevalence of malignancy. But it's not a clinical tool, though. It's never been defined or tested or based on any clinical setting. And this brings us to the fact that I think I'm glad to see that we are all saying the same message, that maybe with advancements in technology, when you've got a new tool, you've got to look at it and see, all right, what is this tool supposed to do for me? And what am I expecting from it? And then define an outcome that's relevant instead of relying on accuracy or diagnostic yield, which is a very compound and complex outcome. As an example, I'll show our study that we defined reach and tooling lesion as our outcome, which I think was relevant to that study. The disclaimer goes on the side of that. That's my opinion. All right, moving on. I have picked this one because this is interesting, as we don't see many head-to-head studies these days. So this is head-to-head between shape-sensing robotic-assisted bronchoscopy versus transthoracic needle for GGOs and subsolid lesions. Again, we don't see a lot of GGOs and subsolid studies these days. So that was interesting. The diagnostic yield was reported to be very similar, 85 versus 89. Small group of patients, though. So we've got 38 in one side and 28. You've got to consider the fact that it's retrospective, two-center study. It's Mayo in Florida and Mayo in Rochester. And interestingly, well, it does show that the robotic bronchoscopy procedures are much longer, 72 minutes on average versus 21. Not sure it's because we have the opportunity to do more biopsies with different tools, as you can see in that column a little bit higher up as well. Or is it because we do staging? The study doesn't specify that, but in reality, that's a very strong factor. In terms of complications, you can see there's a trend towards higher pneumothorax rates in the transthoracic one, at the expected reported rate of about 20%. Again, the p-value there is not significant because of the size, I believe. Step by step, going forward on the nodule topic, advanced imaging is probably the most important advancement in technology we have had when it comes to lung nodule biopsy, bronchoscopic lung nodule biopsy in the last few years. And this beautiful Belgian study prospectively randomizes the patients that were referred for biopsy into either EMN with fluoro or EMN with CBCT. Again, small numbers, but they were similar in characteristics. They were mostly solid, so there were some subsolids in there as well. And the prevalence of malignancy in that cohort was about 72%. You can see that adding advanced imaging significantly increases diagnostic yield and diagnostic accuracy. We're talking about 3D in this study, cone beam CT. Reach increases as well, as however, it does contribute to a bit of a longer procedure as well, as you would expect. Another step forward, advanced imaging, when it's combined or integrated with your navigation system. So you've got the navigation system in the previous study, you've got the advanced imaging in the previous study. Now, if you combine them together, make the advanced imaging talk back to your navigation, you can overcome CT to body divergence. And you can see that on the picture there. So this is a study that we performed at Macquarie University Hospital, published earlier last year in 2024. first-in-human trial of Galaxy system, which is an image-integrated robotic-assisted bronchoscopy using DT. We defined our outcomes based on the technology, reach in terms of navigation, that's important, that's relevant to navigation directly. Tooling lesion is relevant to the advanced imaging and its integration. We reported on yield on strict as well, which was 89.5%. Moving on from diagnostics to therapeutics, the literature is thin for many reasons, as was explained before, but this is another study that was actually collaboration between Melbourne and other sites as well. Dan Steinfeld is a friend of mine in Melbourne, his first author there, of course with Felix. First in human safety and feasibility of RFA catheter. Obviously it's been used transthoracically with multiple complications in the past, but this is a novel catheter that cools down externally as well using saline. Lots of lessons learned. This is a very good example of you design a study, you do it, you publish it, and everybody learns. So the first patient was not paralyzed, and as you can see in picture A, the patient had a cough, was coughing, and hot saline moved, and you can see that there is not a lot of overlap. They changed the protocol, they paralyzed every patient, they treated another 7 patients with no significant serious events, and the ablation zone included tumor in all of those cases. However, the overlap was a bit variable between 8 and 72%, so this was a dose escalation study. Interesting study, hope we see more of those larger ones, phase 2s and 3s. I'm going to move on to linear EBUS cryobiopsy very briefly because obviously Jürgen talked about it and we've heard a bit about that as well. But I really like that study that has already been presented. It really confirms what we thought the value of cryobiopsy is, which is in increasing the yield, overall yield, but it has almost no effect on lung cancer cases. In fact, its value is in benign lesions, benign disorders, and also uncommon tumors, as you can see in that graph. I'm going to skip that one. Also, I think this was also mentioned as well. This is a recent study published comparing forceps and cryo, and again, Jürgen talked about that. I'm not going to mention much here. Now, moving on to another topic, I've got, I think, 2 or 3 of these on bronchoscopic treatment of COPD. We know that there's a lot happening, but a lot of them have not been published yet. This was very interesting to me because we've all been referring back to the NET trial and poo-pooing surgery based on those results. It's good to see an updated version of that. Because obviously bronchoscopy and everything else has improved over the last 2 decades. It's just fair to assume that surgery has also moved on and improved. So this was a multi-center, UK-based randomized trial, lung volume reduction surgery versus bronchoscopic lung volume reduction, follow-up at 12 months. You always have the non-responders and then you have the responders, and you can see surgery on the right and bronchoscopy on the left. CAT score, the row below, and residual volume on top. Obviously, the concern with surgery is its short-term complications. The study didn't find any signal there. However, it's fair to also highlight the fact that the size of the study, the power of the study may not be high enough to have a safe conclusion there. Specifically when you compare that to the NET trial, which had more than 1,200 subjects enrolled. But altogether, very interesting and very useful study. It's also good to see the coils coming back. So I'm sure you guys are aware, had them around 15 years ago, 10 years ago, started fading away. Now, this is a new coil, pretty much the same thing. So it's shape memory nitinol device that's placed bronchoscopically But instead of the kind of the bouquet of flowers we used to see with the call, it's a bit more, it's like a bouquet of flowers that someone has crushed. Because they have different 3D orientation, and that induces more lung tension. Aiming to have more reduction in residual volume. These are the adverse events. There are no significant or concerning signals there, which is always good to see. Also, always good to see that the cohort of patients chosen are the relevant ones, and these definitely are. Severely obstructed, severely hyperinflated, with appropriately low DLCO, as you would expect. And these are the results there. Again, a couple of non-responders, and then the responders. In terms of symptoms, you've got the SGRQ there in the middle there, 6-minute walk test here as well. So only a proportion of them reached a minimally significant change or difference. But again, good trial, hope to see more of these, and larger ones as well. So this is my summary slide. Was trying to stick to time. I'm sorry if I've gone over, but that's why it's a bit limited as a review of the year. Obviously, the year was much bigger than these. But I think it's important to sort of, these are my impressions after kind of going through the literature, that there is significant momentum behind early lung cancer diagnosis and the advancements that we have seen, which really the evidence now puts bronchoscopic lung nodule biopsy not just on par, but maybe ahead of traditional methods. But independent and investigator-initiated studies are still rare, and if they are there, that they are very low-powered. Head-to-head studies don't exist, and are very unlikely to ever happen. Now, the talk of the town everywhere you go about, advanced imaging and bronchoscopic lung nodule biopsy is therapeutics, because that's the next step. There's a lot happening, and we know that there are a lot of ablation therapies available clinically and commercially, but in relation to that, the literature is very thin. What to look forward to, hopefully, this move that we have seen in the last few months, maybe the last year, that the technology has moved out of the United States, and now we are seeing that spread in Europe, Asia, and in Australia. Hopefully we can see real-world and independent literature now emerging as well from these sites to contribute to the bulk of the literature. And also, in terms of COPD treatments, bronchoscopic COPD treatments, there are a few things in the pipeline, including the CONVERT trials and APRIO and BTLA that hopefully we'll see in the next year or two. And I would like to thank you for your attention.
Thank you, sir, for your extremely valuable and informative talk. Next, we would like to invite Dr. Michael Pritchett for his talk on evidence-based review on robotic bronchoscopy.
All right, just when you thought we were done talking about trials and looking at graphs and numbers, here this goes. There is an appropriate disclaimer that goes with this talk, but it's been eloquently given by Joe and Taj, which is, how to interpret these studies and different definitions and prospective and things like that. So take all these with a grain of salt, but we'll get to some meta-analyses at the end. Obviously, there's 3 different robotic systems that are currently available in the US, and some of these are available outside the US as well. I won't go into the details about the different systems, but you can take a screenshot of that if you want, because we'll mostly focus on the data. So the advantages, obviously, were that we're going to have vision out into the periphery. We're going to be able to go farther even than thin scopes, that we have precise movements and stability, and that we can integrate with what we already use, radial probe, fluoroscopy, cone beam CT, certainly an advantage for therapeutics, and one that we don't really talk about a lot, which is ergonomics. Since I've used the robot a lot, I don't go home with my arm hurting or anything like that, so it's great. So this started in 2018 when Monarch came out. Here's just a little quick bibliography if you want to screenshot that, and you can look at that on your own. But we'll hit some of the highlights. And again, different definitions of diagnostic yield throughout all of these. This is a more liberal definition here, because there were, in this example, there were 13 cases that were atypical, but those counted as diagnostic. So, but as time went on, we've seen differing definitions. And so it was initially a little bit disappointing for the robots when you had average lesion size of 2.5 centimeters, but your yield was relatively low. And then the benefit trial, this was what we call now an intermediate definition. Again, decent size, but relatively low number of patients. But again, this was kind of the very beginning of the robotic literature. And so we saw for the first time we're starting to get where electromagnetic navigation was. But again, this was a little bit more of a strict definition than was used in Navigate. And then here's one that followed for a year. So we actually are able to get sensitivity for malignancy when you follow those patients for a year, which is the ideal way to do it. The bronchus sign in this one was a little on the high side when you compare that to Navigate. But what we're seeing is those diagnostic yields slowly getting higher and higher, pneumothorax rate getting lower, and moving forward there. Then jump fast forward to this year. So this year was the culmination, or actually last year technically, was the culmination of this big multi-center study called the Target trial that had been going on for a while. And in this study you could use cone beam if you wanted to, but not a lot of sites had that ability. And if you use that very strict definition, the yield turned out to be 61.6. This is still just an abstract, and we're still waiting for the final publication on this, but that's the direction that we're going with that. Then ION came on the scene about a year later, still waiting for the full publication on this. This was also just an abstract. But the exciting things that we start to see in the data is that even with very low percentage of bronchus sign, we're getting diagnostic yields, even with eccentric lesions. And this is with all the robots. Even with an eccentric lesion, when you have the ability to aim up against that airway wall and biopsy, you're getting results where previously you didn't. And remember, these studies are prior to the 1.1 millimeter cryoprobe becoming available. This was a half retrospective, half prospective comparison with TTNA, and you see the diagnostic yield is about the same. No cone beam CT scan was used. The reason that we like to do it, obviously bronchoscopically, is because we can stage the mediastinum in the same procedure. Then the cryobiopsy comes on the scene with the 1.1 millimeter probe, and we're seeing yields now push up to 90% diagnostic yield. And so when we start adding that cryoprobe in, we're going to see our diagnostic yields go up. Again, it's difficult, if not impossible, to compare these studies head-to-head. So it's like Joe's apples and oranges slide. This was probably the largest study that we've had thus far. From the ION side, 500 nodules. This is a group of thoracic surgeons out of Cedars-Sinai in Los Angeles. No cone beam CT. This is more of an intermediate definition of diagnostic yield. But the one thing we're also starting to see in these trials is that our negative predictive value is going up, particularly when you have cone beam CT or tomosynthesis, and you can go to conference afterwards with your benign diagnosis and say, hey, this is my tool in the lesion, and that's how we're going to manage it. And that's why sometimes the strict definition of diagnostic yield is actually too strict. There are truly some lesions that are just inflammation. And when you use the strict definition, you don't get credit for that. But if you look at surgical studies, there are plenty of things that we cut out, and they are just inflammation. So you have to follow those forward. And so sometimes looking at sensitivity for malignancy as you follow forward is important. But this shows what we're seeing in a lot of the robotic data is that and particularly with real-time imaging, your negative predictive value is going up. This is a multi-center prospective study from China looking at the ION robot. Again, high diagnostic yield without cone beam CT, high sensitivity for malignancy, relatively short procedure time. This is 90 patients at 3 centers. And so when you look at this across the landscape, what we're also seeing here, despite meta-analyses that have been published by people who don't even do bronchoscopy that are telling you that you're not getting better, That is not true. We're absolutely getting better. Typically what you see is when you start biopsying smaller and smaller lesions, your diagnostic yield plummets, particularly less than 2 centimeters, but we're really not seeing that. So some of this may be the size of the catheter, and if these are the only comparisons, these are the only 2 studies that I can find when you look at a robotic catheter that's larger compared to a robotic catheter that's smaller, that may limit your ability to reach some of these lesions, at least without causing some trauma. So typically the smaller your catheter can be, the better you might be able to do on average. Again, there's certainly cases with the larger scope you can drive it all the way to the pleura if you want. There's no head-to-head, as Taj pointed out, but there's this one that just was presented last year at AABIP, which is the same center that looked at all their monarch data, compared it with all their ion data when they switched over, and they found a higher yield, a lower pneumothorax rate, a shorter procedure time, less fluoroscopy, and less radiation. The big thing that you have to take into consideration is that the cryoprobe was newer, and that may actually account for the difference that you see between these two, because cryoprobe, as we've seen, is a game changer. So again, not necessarily a fair assessment there. The big change now has been this integration with cone beam CT, and again, all the systems are compatible with cone beam CT, but integration, as Taj pointed out in the last talk, whether it's tomosynthesis or cone beam CT, where that data is actually going into the robot and you're able to make real-time changes and updates, is a big change. And so we can view this data right at our fingertips during the procedure. And so that's ushered in a new era, if you will, of data where we can correct for CT to body divergence and update our target. So when we add cone beam CT scan, we can see that our diagnostic yield can go up, but not only that, but you can also see that our average lesion size gets smaller and smaller. We're getting more accurate with smaller lesions, and here we have 58 lesions. That's more than was in the entire benefit trial, all the way down to 5 millimeters, where our yield is 90% with an incredibly low pneumothorax rate. And we can see this in another publication out of UT Southwest. Again, high diagnostic yield, high negative predictive value, and very low pneumothorax rate. This is the newest abstract that's out called the CONFIRM study with ION's full integration with their cone beam CT. This is with the CEOS platform, but they also have integration with the GE system as well. So using that strict definition, high diagnostic yield, low pneumothorax rate, and high tool and lesion. But what you're seeing, and you're going to see this in lots of different studies, is about a 10% difference between when we get our tool in the lesion and when we get a diagnosis, at least with the strict definition. And previous speakers have talked extensively about the reasons for that. So if you want to compare somewhat apples to apples, if you look at all the strict definitions, then you can see in these various trials, including the Veritas, which was with the Lumicite, and that also included TTNA. So TTNA, when we actually study them on our own terms, may not be quite as good as everybody says. So when you add in real-time imaging, in general, you go up by about 5 to 10%, and those hold true even for very small lesions. And then lastly is the newest one on the block, and Taj talked a little bit about this, and obviously Kyle and Joe are here and have done a lot of the groundbreaking work with this. This was the MATCH study. This is an animal study, so take that for what it's worth, but what they're showing is that we can get tool and lesion 100% of the time with this new system. And then this is what Taj presented, the Frontier study, with, again, using that strict definition when we combine tomosynthesis so we can see tool and lesion. And again, they're tool and lesion 100%, but diagnostic yield about 10 points lower. And there's a variety of reasons for that. Again, when you're using that strict definition, some of these could be inflammatory. You may have not so great pathology. Kyle pointed out a couple examples of that before from Steve Kovac's data as well. And then this slide is courtesy of Joe and some of their data that they have as well, looking at this. You've got 116 nodules in one study, 67 in the other. But in general, you're getting your tool in the lesion in close to 100% of the cases, and your yield is about 10 points less, again, for a variety of reasons as we talked about before. These are abstracts, but waiting on a full manuscript as soon as Joe stops traveling around the country and gets to writing it. All right, so let's talk about some meta-analyses just to close this. There's 3 meta-analyses all published within a month of each other. And we'll go through these quickly. Definitely some differences in here, but in general, you see some similar numbers. So this one had only 10 studies and 725 nodules. You can see the studies that were presented there. And overall pooled diagnostic yield, this was the lowest of the 3 at 80.4%. The differences that you see here are for larger lesions and when you use the cryoprobe. Big difference when you use that cryoprobe. 90% compared to 79%. Interestingly, cone beam CT scan did not make a statistically significant difference there, probably because of the relatively low numbers, but it's difficult to say. This is the second meta-analysis, which is published in JOBIP. This is the largest one, 23 studies, 1,500 nodules. You can see all the studies that were included there. This pooled diagnostic yield was about 82%, and they did break down the difference between shape-sensing robotic at 83.5 and E&B robotic at 76.8. And this is one of the ones that pulled out a few of the studies that specifically looked at sensitivity for malignancy. This is when you follow them longitudinally for a year, and those numbers look pretty good at 87.6%. And very safe procedures, pooled pneumothorax rate of 0.6% in this study. Then the last meta-analysis before I finish was in Annals ATS, 25 studies. Actually, this was the largest, my apologies. 25 studies, 1,900 lesions. You see that there's a disparity of the ones that were included there at the bottom. The vast majority of these that have been published are on shape sensing with 13 studies and 1,500 lesions compared to E&B. So you have to factor that in as well. But overall, this was the highest pooled diagnostic yield for robotics. Altogether, all comers, 84%. Here the yield when you use 3D imaging is 87.6 compared to without 81.8. And then here, if you look at the E&B robotics, pooled yield of 80%, whereas shape sensing is 85%. Not a big statistical significant difference there. So in summary, we've seen improved diagnostic yields. There's no doubt about it. And it's certainly changed the way that we practice for those of us who have that. We have improved accuracy for traditionally challenging lesions that are smaller, don't have a bronchus sign, eccentric view. As Taj pointed out before, there are no prospective head-to-head studies that compare the different systems, but we looked at some of these combination prospective, retrospective single centers. In my opinion, so I'll put Taj's little exclamation point here, the addition of TOMA and cone beam is the key difference in increasing your yield. And I would also argue with an exclamation point there that the bronchus sign doesn't matter anymore. And so again, lastly, we have that gap between getting tool and lesion and getting a diagnosis. And maybe tools will make a difference. Maybe pathology things will make a difference in terms of closing that gap, but I don't ever think that it will be an identical number between tool and lesion and diagnostic yield. That's it. Thank you.
Thank you, Dr. Prashit. Moving on to our next session, new advances and greetings from the Chinese IP Forum. I'd like to invite Dr. Felix Hurt, Dr. Kelvin, Dr. Gustav, and Dr. Titiwat to chair the session. Thank you.
So, good morning. Can you hear us? Can Shanghai hear us? Professor Lee, can you hear us? So we can see him, we can hear him. We cannot hear you. So maybe the technician in the back can help again, because we are ready to go, but we have to hear him.
Can you hear me?
整个手术呢是双腔气管插管全麻下，那么在术前呢做胸腔闭式引流，然后完了以后肺复张，在 CT 引导下呢对这个病灶实施这个消融，根治。那我们这个患者是一个中年女性，48岁，她呢因为发现这个肺部结节呢进行性增大已经有3年了。那这个病人呢，他是一个多发性的，右上肺呢有一个病灶比较大，那接近2公分的混合膜玻璃的一个结节。另外呢，右下肺呢它也有2个结节，一个呢大概有8到9个毫米，还有一个可能7到8个毫米。所以今天下午呢，我们刚才就给他实施了一次性的3个结节的根治性消融，整个手术还是比较顺利。我们等会儿呢也能看到他这个病灶经过消融以后。病灶的一些变化，整个手术时间呢，我们大概2个小时左右，中间应该衔接的还是比较紧凑的。好，谢谢。
With all of you. For the definition of a PALCA procedure, we have several specific. Sorry, can you put the video? Or I can share the screen. I'll just share the screen. Okay. So for the sorry, can you play the video from the start? Yeah, yes, it's good. Okay, great. For the definition of PALCA procedure, we have specific components of this procedure. First, we use double lumen endobronchial intubation and use general anesthesia. And we use fluoroscopy-assisted drainage system. And for the patient's population, we generally wanted to recruit patients with GGO less than 2 centimeter, and the consolidation tumor ratio is less than 25% as shown in this figure. The consolidation area and the diameter of the GGO tumor was less than 25%. And another indication is some patients who are not be able to tolerate the procedure or tolerate the surgery, or they refuse to do the open surgery. We still recommend them to enroll in our trial. And another is patients with multiple primary peripheral NSCLC, who also can refer to us to do this interventional bronchoscope. And for the contraindications, for those patients with multiple comorbidities such as pulmonary hypertension, aortic dissection, myocardial infarction, stroke, severe organ dysfunctions, they're not can be able to tolerate the general anesthesia. And so some patients had a moderate to severe adhesion of pleura because we're using the pleuroscopy assisted maneuvers, so that might affect us to do the procedure. And also some patient has a severe potential for bleeding, which has less, platelet count is less than 50, or severe coagulopathy. And other contraindications such as severe thoracic or spinal deformities, they cannot be able to intubate, uncontrolled pulmonary infection, and some patients had cardiac pacemaker placement or other relative contraindications, including radiofrequency ablation. For the preoperative preparations, lab tests including CBC, coagulations, cardiac and liver functions, infections as well, blood glucose as well. And also other examinations such as EKG, echocardiogram, lung function test, or other relative examinations. We strongly recommend to do the enhanced chest CT scan and the three-dimensional reconstruction of the lesion before the ablation procedure, because it can help us to observe the size and the location, and also the relationship between these adjacent important organs such as large vessels, spine, or heart as well. It can help us to precisely locate the lesion for the next ablation. And also informed consent obtaining as well. Before the general anesthesia, fasting for 12 hours. And sometimes we needed the skin preparation and veneer access as well. So this is the whole protocols of this procedure. We strongly recommend to use the hybrid CT room for this procedure. And this is the surgical supplies, including the double lumen trachea tube, thoracoscope, and this is the anesthesia. After the anesthesia, we place the double lumen intubation. We generally position the patient based on the lesion location. We wanted to put the affected side upward, which can help us to more easily get into the lesion. Again, disinfection. And place the drips. Then we firstly put the fluoroscope After the skin is dilated, we place the trocar. By this point, we generally created the contralateral ventilation by using the double lumen intubation. And then we can use the scope to observe the thoracic space. And at the same time, if we wanted to observe the water content of the line, if it is a watery line, that means a greater absorption of the ablation energy. Otherwise, if the line is less watery, commonly seen in patients of COPD, smokers, or emphysema, etc., that might suggest a less effective absorption of the ablation energy. The trocar is designed by our team, which could be easily teared and removed. Then the drainage chest tube was placed, and the previous collapsed line was reinflated. Next is the ablation surgery. This is a marker that facilitates the location of lesion. And this is a pre-op scan. And for this specific patient, we can see that she has multiple lesions on the right lines. And for this particular case, there are multiple vessels surrounding the lesions. Thus, we choose to use a blunt needle, but within a shaft to get through the tissue instead. I will show you later the picture of this blunt needle. As soon as the needle was precisely placed into the lesion, then we can connect the wire and then start the ablation. One particular thing we wanted to emphasize is the placement of the needle. We want to place it right in the center of the lesion, which means that we can use the least effort or least energy to ablate and use the least time, and also means least complications or benefits most for the patient. And for the microwave energy, we generally start as 30 watts with 3 minutes. Then we can evaluate the ablation reaction area. If the reaction area completely covers the lesion, ideally the reaction area would exit the primary nodule over 0.5 to 1 centimeter, which we can think as satisfactory management. We also recommend to repeat 2 to 3 minutes if this is not satisfactory. And this is the second lesion. This is the third one. Sometimes the needle is not very easy to stabilize. We can use some instruments such as a forceps. Stabilize it. For the time frame, it usually takes 1 to 1.5 hours for the whole procedure from anesthesia to fully recover. Now we spend generally 30 to 40 minutes for each single nodule. And then we can assess all these multiple lesions after the ablation. We can observe the inflammation reaction and also any exudation or necrosis or any other potential complications as well. This is the third lesion. We generally make the follow-up on the, so we generally repeat the CT scan on the next day post-operation. And immediately after ablation, we can observe the ablation reaction. We can see that if the reaction area can fully cover the primary nodule, that means the satisfactory management. And this is the second lesion. We can see that besides the ablation reaction, there is obvious necrosis within the area. And also the primary nodule became condensed or shrinked as a white dot showing on the CT scan. And this is the third lesion. Thanks for watching the video. In the next, we would like to share several cases we have done in the past few years regarding these PELCA procedures, and also different experience we have accumulated. So for the first case is the lady we have just saw on the video. This is the primary lesions CT scan done before the procedure. You can see that on the right lungs there are several different GGO, and this is the caption during the procedure. You can saw that the needle get very precisely located within the center of the lesion, and the lower panel shows the immediately assessment after the ablation. You can see that this ablation reaction area is fully covered the primary nodule, and which means the satisfactory management. And this is the second ablation. And for this kind of lesion surrounded by different vessels, we recommended to use a blunt needle where we have created. I'll show you the pictures later. And this is a comparison on the first day after procedure and a 1 month follow-up and the primary lesions. We can see that on the first day after procedure, there is a very significant inflammatory and necrosis within the reaction area. And on the 1 month follow-up, we can see that almost the second and the third lesion had completely resolved, and the first one is had some fibrotic tissue left, and no obvious complications were observed. And then compare with the primary lesions, they have very successfully managed. And this is another case showing the nodule next to the vessels. We are using this blunt ablation needles with the shaft instead. This is the comparison for this patient. After the ablation, we can see that the primary nodule is fully covered by the ablation reaction area. This is another type of lesions which get very close to the chest wall. What we have done is using the fluoroscopy-assisted drainage system to create an artificial pneumothorax, which can help us to more easier get access into the lesion because of the collapsed line, as shown in the feature in this CT scan. And this is the after the ablation assessment. We can see that the ablation energy reaction area and with some necrosis and exudation within the area. And also, this is another type of lesion. We can see that the primary lesion GGO was present on the upper panel, and after the ablation procedure, as shown in the right lower panel, the primary nodule became more condensed or shrinked as a white dot. That means that indicates successfully managed. This is another case when we can follow up of this patient. We can see that there is obvious inflammation area and with some necrosis and exudation within it. And in the center of this area is the collapsed lesion. This is another type of lesion next to the pericardium. And after the ablation, we can see that the primary nodule became condensed and with a surrounding halo. Another pericardial GGO, we have, for this type of GGO next to the pericardium, we created the artificial pneumothorax, which can help us to prevent the potential complication, or we can control the complications such as pneumothorax. And this is a 1 week follow-up of this patient. We can see that some fibrotic and fibrotic tissue. This is another patient. We have, this is the primary lesion of that. And after the ablation, on the first week follow-up, the patient present as a cough and a sputum production with us, and the CT scan shows the massive exudative and also some cavity within the lesion. We had this patient on management and also used antibiotics to treat the infections. And on the 3 months follow-up, the lesion completely resolved. And we think that the reason for the cavitation is that maybe this nodule was connected to the segmental bronchus. As soon as we are doing the ablation, all these necrotic tissues and also local inflammatory reactions, immune cells, and also some necrotic tissues and exudative can get access into the bronchus, which can facilitate the cavitation. But we have met several patients with this cavitation after the procedure. But generally, after proper management and during the after 2 to 3 months follow-up, all these patients can be recovered fully. This is a comparison on the 3 months follow-up compared with the primary nodule lesion. You can see that all the primary nodule became fibrotic and fully recovered. This is another cavity patient. This is another case. We had a follow-up on the 1.5 year. You can see that the primary lesion was replaced by the fibrotic tissue. And the patient didn't complain any cough or sputum or any chest pain, etc. This is also another follow-up of 5 months. We can see that the primary lesion was replaced by the fibrotic tissue. This is also another lesion with surrounded by the vessels. For this type of patients, we strongly recommend use this blunt needle to do the ablation. We also have some lesions next to the spine. You can see that after the ablation on the 1 month follow-up, the lesion, we can see the reaction area had fully covered the primary nodule and also the inflammation and the necrosis within the lesion. So we would like to share some summary of our experience. We have been accumulated almost 1,000 cases in the past 5 years of this procedure. We have also met several particular patients with different locations, such as the chest wall, vessels, and the pericardium, spine as well. We have created different strategies in managing of this type of lesion, such as using the blunt needle instead, and also create a artificial pneumothorax to facilitate the access. And also during the operation, we recommended to do the CT scan assessment immediately after the ablation. If the ablation ablation reaction area can fully cover the primary nodule, that means it's satisfactory management. And also we can observe that the primary nodule became shrink and or condensed. That means successfully or satisfactory management. And we also recommend to repeat the 2 to 3 minutes if the management is not satisfactory. So usually, generally on the second day, we repeat the chest CT scan again to evaluate the inflammation or necrosis or exudation within the area. And after more than 5 years, this procedure has become very mature in our setting. We have almost 90% of early-stage lung cancer patients, as soon as they have met our criteria, they can do this minimally invasive ablation therapies. And during the follow-up, we generally recommend to a follow-up visit on the first month, 3 months, half a year, and 1 year, and each year later. And among patients, we have a follow-up for 5 years. There are almost no recurrence of GGO. And also, we recommended to reassessment during the follow-up and to repeat the ablation, what we call the rescue procedures if this is not satisfactory. And for some complications, such as the cavity or infection patients, because we think that might be caused by some anatomic issues that we just mentioned, or some overreaction or overabsorption of the ablation energy. But actually, based on our previous experience, these type of complications stays relative stable and relative safe. We have multiple patients had a cavitation after the procedure, but by the proper management and the antibiotics management, all these cavities can resolve gradually. And we haven't found any severe complications after the procedure. And we think that one of the most important key to achieve the successful management is the precise location of the lesion. Like we just mentioned, that we have to put the needle right into the center of the lesion. That means we can use the least energy, least time, with most benefit and least complications. So we wanted to share our experience and recommend other institutions or physicians who would like to perform this procedure. And for institutions, they just start up these techniques, or they are not very familiar within this procedure or ablation energy stuff. We think that strongly recommended to reassess the CT scan after ablation to evaluate the satisfactory, and to repeat the ablation one at a time after the procedure. So this is based on our experience. Thanks for listening. Do you have any questions?
Thank you, ma'am. Yeah. Any questions from our chairpersons for discussion?
Thank you, Professor Lee and the team. Are there any questions from the audience? Okay, if not, then we've got a few questions. I guess, well, maybe I'll start. How do you select your patient to have this instead of a wedge resection for a nodule near the spine or the chest wall when they're very superficial, or just simple transthoracic ablation if the lesion is deep?
Sorry, can you repeat the question?
How do you choose patients for this procedure versus wedge resection if the lesion is superficial, or transthoracic ablation if the lesion is deep? Or better to ask you, how do you select the patient for this procedure?
我们选择这个病人呢，主要是选择这个以磨玻璃病灶为主，然后病灶呢，小于2公分，实行成分占比小于25%。
For the patient population selection, we generally wanted to enroll the patients with GGO less than 2 centimeter, and the consolidation over tumor rate less than 25%, which generally means less metastasis.
Okay, thank you. Yeah.
We have a question.
Thank you for a great presentation. I'll keep my question short, just because obviously we're translating. What is the value of putting a trocar with a chest tube before the procedure, since you're doing everything percutaneous?
病人在操作过程当中呢，他可能会出现一个是局部的出血，另外还有一个就是气胸。因为放了这个引流管之后呢，这样它肺复张以后，我们在穿刺过程当中就没有这个气胸对手术的干扰。
For general the ablation procedures, some common complications such as bleeding or pneumothorax, that we wanted to create an artificial pneumothorax to help us to prevent these complications. I don't know if we have stayed clear.
Okay, next question. Have you ever wedged the lesion after the procedure to confirm that your procedure basically abrade all the tumor and show no viable tumor cells?
Okay. 那因为这一类的膜玻璃结节持续存在的膜玻璃结节呢，通过人工智能的诊断，它的准确性可以达到呢95%。
We are using a artificial intelligence system to evaluate the GGO, and the specificity is over 95%. So we choose this type of patients to do the PALCA procedure instead to do the biopsy and pathology examination.
Okay, thanks a lot for your great presentation. All questions are answered, and we will moving forward now to the second center. We will move to Professor Xiu Li in Guangzhou, who will show us the laser technology for benign tracheal stenosis.
Hi, hello, can you hear me, please?
Yeah, we can hear you. Welcome.
Okay, thank you, and hi, the chairman and dear colleagues, dear India colleagues. It's my pleasure, great pleasure to let me share my. Can you see the screen?
Yeah, we can see the screen.
Yeah, okay. Dear India colleagues, and it's my great pleasure to share my some cases here in our hospital. First case is the patient stenosis, tracheal stenosis with the contact laser. This patient is a female CT4. He was with the soreness of breast for 1 month, and there was a history of the malignant lung tumor. So we did the bronchoscopy, see there was the severe stenosis of the upper trachea, and we also did the biopsy, and the pathologist shows there's the lymphoepithelioma-like carcinoma. So the initial diagnosis, the tracheal severe nosis with the lymphopithelioma-like carcinoma. So here's the CT image. We can see here the very severe stenosis at the upper trachea. and then since this tracheal stenosis caused by the malignancy, so we use the laser with the contact laser to delete the tumor tissue. With the general HICC, and then we use the laser probe with the contact mode, and then point by point to delete the ablation the tissue. And here we can see the tumor tissue was vapor by the laser. And here you can see there are no obvious the carbon or necrosis here. The V was very clear. The diameter of the stenosis was about 4 milliliter in diameter, and with the length of 2 centimeter. So we can see we can almost continuous to ablation the tumor. No many carbon in the on the caster. The V was very clear. So here we can see right now it's almost 5 minutes, just 5 minutes, and the cavity was enlarged, and then we with the balloon dilation. Okay. Here we can see the diameter is about 10 millimeter in diameter, and then we insert the mental stent with the Boston Scientific. and then we have the remove adjustment the place. See, we can see the stenosis was the soreness was relieved. So here's the case with the contact laser. And combined with the balloon and mental stent. As we know, the laser classification by media is solid laser, gas laser, and semiconductor laser, and by the mode of the action, we can divide with the non-contact laser and contact laser. So for this case, we use the contact laser. For the character of the contact laser, as we know, is cutting precise up to 0.2 millimeter, and highly precise laser probe, and it's safe, as we know. For the other laser, it's very high powerful. But with the contact laser, with the lateral damage less and less than 0.5 meter, and controllable in cutting rate and depth, and it's also very effective and reduce and so it's price safe and effective. As for these patients, we use the 15 watts for the laser ablation. And there's another the case two is the for diagnosis with the nodule. We use the robotic bronchoscopy and cryobiopsy. Here we can see the CT image. There's a nodule at the right middle side, and then we registration with the robot. And the collaboration. And then under the guidance of the robot, we can get to the nodule base. And here we can see the picture. We control the robot to the nodule. And here we can see there's it's very close and close to the nodule. And after we get to the nodule, and then we use the ultrasound to make sure there's the lesion. There's the place of the lesion. Here we can see the lesion is over here. And after make sure the lesion with ultrasound, and then we measure the length with the forceps and with the cryobiopsy, probe. And then insert the cryo probe to the lesion and have a cryobiopsy. It's about 7 seconds, and then we take the, as we know, this is the 1.1 diameter probe. So we have the 6 to 7 seconds of the cryo, and then take the tissue. Here we can see the cryo biopsy tissue, and then have the rows. Here we can see the malignant cell there. So this is the case with the robotic bronchoscopy and combined with the cryobiopsy. For this case, we use the robot we are using the Chinese-made Polaris bronchoscopy navigation robot. This is the Chinese-made robotic system. It's now available commercially, like recently. Here's another case I would like to have the brief introduced. Here's the vocal. This patient after the surgery, the car accident, he got the vocal cord and subglottic stenosis. Here we can see the vocal here, and the stenosis very severe. And then we put the T-tip but over the vocal. And after 1 year later, we can see here's the vocal, and the lumen is open and remain open. And there's another case is the let me see, it's diagnosed as the pulmonary obstructive infection and also the tracheal obstructive infection. So as we see here, the tracheal collapse here and the right main bronchus, and then we put the bare L-shaped mental stent. Here we can see here here is the trachea, and here's the here is at the right main bronchus. And after continuing anti-fungus infection treatment for 3 months, you can see here the stent is with the contact is smooth and no granulomas here. So this patient is recently he also follow up. So far he have lived for 5 years. And another patient is the 43-year-old man with the diabetes induced pneumonia. The tracheal intubation and respiratory ventilation was performed in another hospital for 10 days and then discharged. But 1 month after discharge, he got the shortness of the breath and bronchoscopy showed that the tracheal stenosis. And at the other hospital, we can see the multiple balloon dilation in the other hospital and stenosis again. Here we can see the CT image we can see here's the stenosis very severe at the upper trachea. Here we can see just below the vocal, the stenosis very severe. It's for the diameter is about 3 milliliter, and it's about 2.5 centimeter in length. And then we, as a routine procedure, we use the laser and balloon, but 1 week later, the stenosis narrow again, and then we use the balloon and mental stent. And 1 week later, we remove the mental stent and put the silicone stent with the diameter of 12 milliliter. But 1 month later, the stenosis again, and then we change another stent with the combined stem. Use the lower part is the 12 diameter, and the upper part is the 10 centimeter. And then here we can see 2 months later, the stenosis, the stem was stable. So for this kind of the very upper tracheal stenosis, we recommend that use the short and small mental silicone Dumont stent is the choice, and the effective rate is up to the 85%. Thank you for your attention.
Yeah, thanks a lot. Great cases. Are there any questions from the audience? If not, Shiri, the new robotic system you showed me, how many cases you performed already? And do you also use cone beam CT during the case?
Yes, so far, thanks, Chris. So far in our hospital, we did almost 100 cases with the robotic. And for diagnosis, we routinely use the ultrasound for make sure the position. But for the treatment, for the ablation, we combine with the cone beam CT. But for the diagnosis, we just use the ultrasound, the EBUS GS.
Thank you for a great presentation. What is the benefit that you see from the contact laser over the non-contact laser for tracheal stenosis? And the second question is, do you worry about subglottic stenosis with contact laser and the possibility of vocal cord injury?
Yeah, I think for the contact laser, it's safer and it's efficacy. You know, for the contact laser, you can very precise to make the catheter to the nodule, and then you can control your catheter. If you would like to make deeper, you can have a much power. If you like to the slide, you can just slide contact. So I think it's very safe, and also it's very powerful. And the V is very clear. Not like the other APC, the V is not so clear. I think it's the advantage. I'm not sure. I am not sure the second question. What is the second question?
By doing contact laser so close to vocal cords, have you seen any injuries? And then after that, I've seen also a short silicone stent in the upper trachea.
Yeah. Yes. for the very high stenosis of the trachea, we use the small diameter stem, but usually we are not over the vocal, so it's just below 3 to 5.5 milliliter below the vocal. So far it's safer. It's safe.
So how often do you see stent migration in the subglottic stenosis?
Yeah, this is a good question. So at the very beginning, the migration is quite often, but and then now we are getting more and more experience. The migration is less than 20%. The main technique is that not to dilation too large, so not to dilation too large before you're putting the stent.
So, Professor Lee, thanks a lot. Great presentation.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you, Dr. Shuli and dear chairpersons. Just an announcement for my colleagues and my seniors. Those who are interested in physically experiencing the fluoroscope, you can visit the FTM stall and you can see it in the display. Moving on to our next session is Interventional Pulmonology and Sarcoidosis. I'd invite Dr. Alia for the talk, and also the chairpersons, Dr. Manoj Goyal, Ericalis Tuberculosis, Dr. Ellis, and Dr. Kozi Zwang, if you guys are present in the hall at the moment. The chairpersons, Dr. Manoj, Dr. Ericalis, Dr. Elise Roseman, and Kozi Zwang.
So, welcome Dr. Elias. We have a country where we have a great mimic of sarcoidosis, that is tuberculosis. So it's really a difficult problem for us to differentiate between sarcoidosis and tuberculosis. And we have something that can increase the yield of sarcoidosis by pulmonary interventions. That would be a great, for especially the countries like India where tuberculosis is endemic. And we may in fact be able to diagnose more of tuberculosis more accurately by doing these interventions. We know a couple of interventions like, EBUS guided FNSC where the yield could be as high as 80%, but if you add cryobiopsy to it, it may go up to 90%. But I look forward to your talk very keenly to learn more about improving the diagnostic yield with pulmonary interventions in case of sarcoidosis and maybe in tuberculosis. Thank you very much.
Thank you so much, and thank you so much again for the invitation for such a nice meeting. That's a great privilege to me. And I'll try to save our time, and I will try to be as fabulous and rapid as one of the persons from the car movie, The Fabulous Hans and Hornet. So I will not mention the conflicts of interest. There will not be any conflicts of that. And I want to start from a story of one woman which has, for 3 years, a fatigue and shortness of breath and a constant fever, and for 2 months she has a slow progressing numbness of the limbs, and a brain MRI showed multiple foci. So up to the chest CT she had a lymphadenopathy, up to the again the same chest CT in the pulmonary window you see perilymphatic dissemination, and she has the positive lymphatic nodes of it with a peripheral one. So the bronchoscopy for suspected sarcoidosis, it's always the two sides of one coin. We can make a biopsy from the pulmonary tissue, or we can focus on the mediastinal lesions. For the endo and transbronchial approach, we can use a bronchial lavage, endobronchial biopsy, transbronchial biopsy, or endo or transbronchial cryobiopsy. So the mediastinal approach, which is also applicable for sure for most of these patients with the mediastinal involvement, consists of conventional TBNA ultrasound with the cryobiopsy, or a rigid TBNA using a spray-cut needle. So what did we do with our patient, a young female? So she was admitted to the Central Tuberculosis Research Institute in Moscow in a brilliant forest. So the clinical data were the CBC is normal, no any definitive problems with pulmonary function test, a part of borderline lowering of the LCO, and no any signs of a huge pulmonary hypertension. So we planned a general anesthesia with a rigid barrel, with a rigid bronchoscopy, and high definition bronchoscopy with all possible biopsies, most of the possible biopsies, with from the bronchial valve lavage, endobronchial biopsy, transbronchial lung cryobiopsy, and EBUS TBNA. Is it too much for the patient? Let's look on that. So the specimen procession included bile cell count, all the cytopathology, and culturing for sure for MBT. So what can we see in patients with sarcoidosis? We can see such a picture. For example, here in the right upper lobe, we can expect multiple foci resembling the cobblestoning picture. So this how it looks like when you have a definitive diagnosis which can be established probably just on the endoscopic picture. The frequency varies. There are different lesion types from cobblestoning to the plaques. And there are also non-specific changes of vessel ectasia and widening of primary or secondary carinas. So the endobronchial abnormalities in sarcoidosis has a huge difference, and if you will look at the slide, you will see that it varies from 6 to 4% in Japan to more than 50 in Western Europe and in Eastern Europe also. So what did we see in our story? Unfortunately for the patient, we didn't see much. There was a normal main carina, moderate widening of the right upper lobe. This is actually her photo, endoscopic photo. No any vascular changes, some mucus plugs, and no sign of endobronchial lesions. So then we performed the bronchial valve lavage, and you see here how it's done. We instill and flush the warm isotonic solution. This is really a controversial area, not only in sarcoidosis, but for the most of ILDs, because the cellular pattern is not specific enough, and the immunological testing is not routinely used. So it isn't sufficient to diagnose the specific type of any ILD, including sarcoid, if used alone, but in some cases, the abnormal findings can support a specific diagnosis. So for positive things, for bronchial valve lavage, it's cheap, fast, and safe, and it's the best media for culturing, especially in the countries with a high burden of TB. But the cons, it's nothing not specific, and the normal cell count doesn't exclude interstitial lung disease. So what did we retrieve in the patient in our story? So it's not surprisingly a part of the last part. It's the 47% of eosinophils, probably not even seen, really rarely seen eosinophilic component in any type of sarcoidosis patients. All the cultures, all the fungal cultures and so on, including MBTs and non-tuberculosis mycobacteria, were negative. Then the patient has undergone endobronchial biopsy, and you see how it looks like when you perform an endobronchial biopsy. You can perform it under visual control, and if you see no any abnormality, then you perform 6 biopsies, triple series for 2 specimens from each site. It is mentioned here. If any abnormality is seen, you make 4 biopsies from the area of interest, and then 2 specimens from contralateral carina. So what is a positive for endobronchial? It's really cheap and safe. It's more than 90% yield of specific lesion like a cobblestoning is seen. It's much more safe than transbronchial lung biopsy and cryo. But if you don't see any lesion in a bronchial tree, then probably your biopsy will be much less effective. So what do we see in our story? So the EBB results, the pathology is shown here, didn't show anything specific supporting the diagnosis of TB. So then a transbronchial lung biopsy comes, We have done it without any fluoroscopy control. It is acceptable. So the TBLB can be performed without or with fluoroscopy under local or general anesthesia, usually 3 to 5 specimens achieved, mostly from the right middle lobe, and the larger forceps you need, the better yield you will get. So the average 70% yield in all patients with sarcoid, lower than you have a chronic disease. It's safer than cryo, but the pneumothorax rates and the bleeding rates are still existing for sure. So in our story, the TBLB results have shown that we reached the pulmonary parenchyma, and there is a septal fibrosis in several fields. There is a lymphoid infiltration, but again, no granulomas we are looking for. So the transbronchial lung biopsy was done also in these patients in the same session, and you see here the main game changer here. This is a Fogarty balloon. You got to be ready to use the Fogarty balloon in case of unprecedented bleeding. Otherwise, you can perform a transbronchial lung biopsy endobronchially. It is just shown just to show how the ice ball is fixed. And the size of the specimens is really huge. TBLC can be performed only with guidance. That doesn't matter what guidance would it be. This would be a fluoroscopy or ultrasound or manual branching or virtual navigation. Under general anesthesia, it is recommended. We prefer it to do in 100% of cases under rigid bronchoscopy, and a Fogarty balloon is always in touch. So usually 3 to 5 specimens achieved, mostly from the right middle lobe. And for the positive things for the transbronchial lung cryobiopsy in sarcoidosis, probably this is the best pathology you can retrieve, up to 90% yield after several publications. But the pneumothorax rate is definitely higher than forceps, and the bleeding rate is also higher. We were lucky enough to receive any huge complications despite our crazy things we've done with the patients, so much biopsies in one session. But again, if you will look at the direct comparison, we have now the data set of almost 200 patients with sarcoidosis who have undergone simultaneously 3 to 4 transbronchial lung biopsy, forceps biopsy, and 3 to 4 specimens with the cryo in the same session. And you will see that the efficacy of transbronchial lung biopsy and transbronchial cryo biopsy is not 90%, it's not even 70%, it's lower. But most of these patients, they have a prolonged course of disease and fibrotic changes. So what the transbronchial cryobiopsy has shown to us, again, nothing. So we have retrieved a pulmonary parenchyma, again, a septal fibrosis and a perivascular inflammation. So last but not the least, the EBUS TBNA was performed. So the EBUS scope can be inserted into the trachea, then the EBUS procedure is called EBUS, and if you stick the EBUS scope inside the esophagus, it is called EBUS FNA. It can be part of a local anesthesia or sedation, and usually we perform 3 to 4 series, mostly in a subchoroidal lesion. And I think that we can start how it looks like. No any ways with elastography or contrast or whatever, just how it looks when it performed, so to say, a conventional. Now it's a de facto the standard. So the pros is that the 95% yield, up to 95% yield you can achieve in sarcoidosis, it's really safe, but the tissue processing problems can arise, and the cost, for sure, the cost is always an issue. So if you will look at the current guidelines to the diagnosis and detection of sarcoidosis for the international guidelines, the latest one were published in February 2020. In patients with whom high clinical suspicion of sarcoidosis is existing, there is a strong recommendation not to sample lymph nodes. For patients with the asymptomatic bilateral hilar lymphadenopathy, there are no any recommendations to perform a biopsy or not to perform. And the third, only for the patients where the multidisciplinary discussion or the pulmonologist alone made a decision that he needs a verification from the lymphatic node, it is a strong suggestion that the endobronchial ultrasound has a favor, is a better to perform less invasive biopsy rather than surgery. The Possible game changer in this field is a mediastinal cryobiopsy when you use an eboscope and the newer generation of the thin cryoprobes is inserted inside the working channel, and then you perform a cryobiopsy of mediastinum. So up to the recent publications, the total efficacy is as high as 92%. It's extremely high for neoplasia, but for the sarcoidosis you see, it's lower. So they're excellent in plastic diseases, and still it's under discussion in benign diseases, again, comparing the costs. So our data for the cryobiopsy in our institution, we performed it under general anesthesia, and we performed it under elastography control. We have a 45 patient, and the pathology yield is 89%. It is not 95, but it's really high. So the local data about the EBUS in diagnostics of sarcoidosis, it's almost 700 of patients enrolled, and you see that the smear is still effective. It's around 80%. The cell block is 60. There are no any definitive difference between EBUS or EUSB approach, and the smear is definitely better than cell block in terms of diagnostic yield. But if your cool toys are out of reach and you don't have cryo, if you don't have EBUS, but you got a lot of patients like this, you can still get back into 1970s and perform a 16-gauge true cut biopsy. We have an experience with these needles with the 16-gauge, 2-centimeter length true core tissue, and the pathology is 90% and the smear is 85. And it's cheaper than cryo. But finally, our story from EBUS to BNA was successive. We retrieved a granuloma, but again, a huge and enormous increase in eosinophils in the bronchial valve lavage count moved us get back to the patient. And there is a kitten here because when we decided to dig deeper and make a precise assessment of medical history, the woman took care of a homeless kitten with multiple scratches from this kit, and the kitten died to unknown illness. So we are supposed that she has probably a Bartonella, and finally the final diagnosis was not a sarcoidosis but chronic cat scratch fever for this patient. So do we need a best combination of the biopsies, or do we need to perform only an EBUS or cryo or whatever? This is still the question. So in case if we use a single method, you see there's the yield of bronchial valve lavage up to definition is still debatable. Does it really definitive, or does it really enough to establish the diagnosis of sarcoidosis? For sure it's not enough, but sometimes it can make change. So there are a plethora of different diagnostic modalities, and you see here the difference in the numbers of the yield. And the different combinations yield for sure. And what is the best? Comparing the bronchial valve lavage plus transbronchial lung biopsy, or do the rigid to BNA plus endobronchial cryobiopsy? This is still a discussionable question because it definitely depends not only on the country but also on the efficacy and the social status. So my conclusion, up to the end of this presentation, just be relaxed and breathe deeply, and please enjoy the moment of your work. Thank you so much for your attention.
Thank you, Dr. Alia.
Excellent presentation. Thank you very much. Any question from the audience? To be honest, I have never seen endobronchial sarcoidosis like the case you presented us before. I would like to ask you if you use rapid on-site evaluation ROSE when you perform EBUS or TBLC, if you use touch imprint cytology to secure your diagnosis during the procedure.
You mean, thanks for a question. Have I correctly understood that in extremely huge endobronchial invasion, can we use a bronchoscopy not only as diagnostic but for the treatment for these patients? Have I correctly understood that?
Sorry, I can't hear from you because something with the sound, but could you repeat your, what?
So when we see such a huge and enormous endobronchial invasion in sarcoidosis patients, we don't treat these huge endoscopically visible findings because they will definitely go away after 1 month of steroid therapy.
Okay.
This is not needed to.
Okay,
We just biopsy. We do not treat. We do not place
Okay.
stents or doing nothing with this.
Okay. Okay. Thank you.
Dr. Elias, do you find any importance of doing elastography in these patients? Do you think the elastography would improve the diagnostic yield?
Really a tricky question. Actually, there were some publications from India, from Madan Group. So the elastography for detection, is it sarcoid or not, for sure, is not useful. It cannot reliably differentiate the TB from sarcoid, but it can definitely differentiate the better position to make a biopsy, the more soft or more stick area. This is not proven yet, but I hope it will be proven in the near future.
Any question from the audience? Thank you, Elias, for such a entertaining and excellent lecture. We learned a lot from this. Thank you so much for coming to India all the way. And with this, we close this session and hand over to the organizers. Thank you.
Thank you so much. Thank you.
Thank you, Dr. Alia and dear chairpersons. We now break for lunch. Also, we will have a live transmission of EBIS cases from the hospital. So if you can quickly grab your lunch and get back to your seats, we'll be starting the live cases shortly. Thank you. The live cases begin now.
Clear, and then we'll go live. Clear now? Are we getting echo here? It's clear. Should we start? Okay. Good afternoon, everyone. Welcome to the live demonstration of the cases. Today, welcome to Dr. Hari and Dr. Preeti's Yashoda's amazing bronchology center. And we'll be demonstrating EBUS and EOS together. Today in OT, we have Dr. Jagdish, Dr. Hemant, and Dr. Ankur assisting in the procedure. We have a pathologist, Dr. Sarika Madam, helping us with rapid onset evaluation. And fortunately, we have Dr. Roberto, who will be demonstrating the Vivo scope as well. We are accompanied by our amazing pathologist and anesthesiologist, Dr. Abdul and Dr. Malesh. And Sister Swarupa is the trained endoscopy nurse who will be assisting during the procedure. So let's start with the white light bronchoscopy. During EBUS, what we do usually, on the screen you can see some US landmarks which we will discuss when we start the USB FNM. So let's start with the EBUS. Can we get it on a screen, please? Okay. So the airway has to be secured. So EBUS can be done with simple bite blocker and nasal prongs and oxygenation. Here for demonstration, we have total intravenous anesthesia. If you do multiple node punctures, then better to use a TIVA, total intravenous anesthesia. Otherwise, the procedure can be done under a simple sedation. So patient is 26-year-old gentleman, has a history of fever and weight loss of around 15 kgs for last 3 months. He has difficulty in swallowing, and that's why he went to a gastroenterologist. The difficulty in swallowing has improved. They did an upper GI endoscopy 1 month back, and there was no definitive abnormality. This patient underwent a contrast CT scan, IV contrast plus oral, and there was no fistula or any esophageal abnormality, but they found multiple mediastinal lymph nodes. Multiple mediastinal lymph node stations. Can we reduce that volume, please? It's echoing here. Okay, so the slide shows you have station 4R, right paratracheal. You can see that aortic arch, and by the side of that there is a para-aortic lymph node also. When you come down, next slide please, we have precarinal as well as the subcarinal, and there is a low subcarinal, or we can call it as a paraesophageal lymph node as well. Next slide. You can see that extension of the node. Next slide. And there's nothing in the abdomen as such. And the oral contrast doesn't show any leakage or any fissure. So the EBUS, what we'll do is we'll do a white light bronchoscopy first, followed by EBUS. Can you get a lignocaine for lubrication purpose? So lignocaine jelly is applied to the scope, and we are going to do a white light bronchoscopy inspection. This is mandatory to rule out any obvious can you just light it? Oh. Yeah. I hope the visuals are clear. This is the vocal cord. The IGL is nicely sitting on the vocal cord. If you're doing inner conscious sedation, then better we put a diluted lignocaine on the vocal cords to anesthetize them so that patient is more comfortable. And then you go in and check with a white light bronchoscopy. This is the posterior wall. You can see the cartilage. We reach to the carina. This is the carina. You can see the carina is not sharp here. It's a blunt or obtuse carina. So let's see the upper lobe bronchus, right main bronchus, and here is the upper lobe bronchus, anterior segment, apical and posterior segment, nothing endobronchially. We go further into the bronchus intermedius, and you can see middle lobe bronchus, lower lobe superior segment, and few basal segments as well. We can see some mucosal abnormality, but I think it's clearing with suction, so they are secretions only. On the left side also, there are a lot of mucus secretions. So the white light bronchoscopy helps you to clear these secretions and look for any occult endobronchial lesions which will be missed on the CT scan. So once you clear the airway, you come out, and then we will shift to EBUS TBNA. Dr. Bhanu is also there helping us during the procedure. She is a trained intervention pulmonologist. Suction, please. Okay. So we are going to use a Fuji EB530 US scope. The beauty of the scope, it has the 20-degree forward view, and it has a narrow diameter, 6.4 millimeter. So it is very, it can be used for both EBUS and US. You can use any scope, but I'm more familiar and I have used it multiple times. So from the same eye gel, we push our EBUS scope. That's the vocal cord. Can you see the vocal cords? Epiglottis followed by cords. And the 20-degree view, if you have 35 or 45-degree view, you'll be able to see only anterior commission. With the 20-degree view, you'll be able to see the vocal cords as that of the white light bronchoscopy. And we are navigating into the airway. The first station, what we are going to look at is station 7, because the CT scan shows a nice necrotic station 7. I hope it's seen on the screen clearly. There's a big subcarinal lymph node. Can you freeze the image? Can you measure it, please? Measure. Then set, and come here, from here. Set, and go up till the, come down. Yeah, it is around 28 millimeters lymph node. Let me unfreeze, please. Let me just show the lymph node margins. It's a quite big lymph node. It is heterogeneous. There is no central hilar sign. You can see the margins are well defined here, but there is no central hilar sign. And there are a lot of anechoic or hypoechoic areas, which suggests there is possibility of necrosis as it is seen in the CT scan. So this is station 7 below the subcarinal. Once you come little bit up from the carina, rotate your scope towards the right side at 2 o'clock. And can you see this? Okay. We have the azygous blood vessels followed by a superior vena cava here. Okay, that's superior vena cava. And here at the junction, you have a 4R lymph node as well. Very nicely defined. Again, well-defined heterogeneous density, no central hilar sign. Yeah, please freeze it, measure it. That's it, short axis, 16 millimeter, unfreeze it, please. So we have to trace the superior vena cava up. Can you see the underlying blood vessel? Can you put a color Doppler, please, Dr. Ankur? You can see the superior vena cava. We trace the superior vena cava up. Where the superior vena cava ends, that's the junction of 2R location. Can you stop the Doppler, please? Here is the brachycephalic artery. Okay, so the nodes located below that are the 2R, and up to the, so we have a huge 4R extending from the 4R to the 2R location. So that's these two nodes we will attempt to sample here. If you want to look at the hilar lymph nodes on the right side, you just enter into the right main bronchus, look at the right carina 1, RC1, attach your scope there, and can you see this? This is a well-defined, another heterogeneous density node, but not much areas of necrosis here. That's the 11R superior. When you go down near the middle of bronchus, around 12 o'clock, you may find another node, which is the 11R inferior. And when you go down further, you'll start seeing the peripheral zone. Another node, which is located below the azygos, is station 10R. Okay, that's the azygos. Below that, you'll be able to find 10R. In this patient, it is not enlarged. To see left-sided node, we just enter into the, you can see carina again. We just enter into the left main bronchus and rotate your scope and try to elicit this Mickey Mouse sign. Can you see these two vessels? The vessel towards the right side is the aorta. The left side is pulmonary artery, and the 4L is located. Unfreeze the image, and can you put a Doppler, please? Doppler, color Doppler. So we have a aortic arch proximally here. We have the pulmonary artery distal, and this is the 4L lymph node. Doppler off, please. To go to the left hilar, we just navigate the scope further distally. At left carina 2, you will be able to identify the 11L lymph node. It's vaguely defined here, not well-defined margin. There's a branch of pulmonary artery below that. And station 10L is into the below the pulmonary artery, along the left main bronchus towards the lateral side. So let's do an EBUS TBNA. I'll show you 2L as well. When you trace the aorta, when you come proximally, the first branches takes off, sometimes subclavian or brachycephalic artery. So here we are able to see a brachycephalic here, and this is the location for your 12. You can see there is a node located, so that's a 12. So let's go into the subcarinal window and let's get a needle in place. Dr. Jagdish is helping us during the needle. You can see this is the Boston Scientific 22 gauge needle where the adapter is already in place. The needle has to be checked that needle is not outside the sheath so that your working channel is protected. And then we go inside. And fix the needle. Needle has to be locked. Then you verify your sheath endoluminally. The sheath is adjusted here. There's a sheath slider. Okay. Let's adjust the sheath. Yeah, take a new needle. Cap is properly fixed. Let's take another needle. Okay, needle is tightened. Needle hub is fixed. Can you just help in adjusting the sheath? Unlock the sheath slider. We have Olympus needle here. Okay. Some technical issue with the sheath on this needle. The metal hub goes to the working channel. Yeah. You have another needle system here, Olympus needle if you have. Give us a minute, some issues with the needle. Can you check the sheath whether it is sliding here? Okay, sure, come. It's properly fitting, yeah, going in. That will adjust again. Is not sliding here. No, madam. Okay, let me adjust the sheath outside. Meanwhile, okay. Yeah, sure. Come. It should be just seen. With the 20 degrees scope, you'll be able to see the sheath properly. Sheath protects your working channel. And then focus the node again. Check the Doppler, please. Check a non-vascular area for the first puncture, at least. Yeah. So request your assistant to hold the scope at the mouth end. The stylet should be withdrawn a little bit so that you have a sharp end for puncture. And you are going to adjust the depth up to 3 centimeters here with the needle slider lock. And then the needle is slided gently. You can, because the cartilage there, you can use a little bit of force. The needle goes in. You can see that needle has gone beautifully in. That's the needle track. The stylet is moved to dislodge the debris. Remove the Doppler, please. You stop to dislodge the debris, and then you take the stillet out. Slow pull technique is usually we use, followed by next passes with the suction. So the needle is moved in the lymph node from cortex to cortex, because the germinal centers are subcapsular. And you can use a first pass we will do without suction, and we see what is the material, and accordingly we use the suction for the next pass. Suction, no suction, stilate, no stilate is a matter of discussion. No major difference in the diagnostic yield. Sometimes the bleed comes with the suction. However, with the lymphomas and sarcoidosis, we prefer to use a suction. It's a necrotic area. So after 15 to 20 revolutions, we take out the needle up, and then you lock the needle, please. Needle lock. Sheath has to be reconfirmed. 2 operators confirm the sheath again, and then we take out the sheath. Yeah, take it out. And this material will be sent for rapid onset evaluation for the rolls. And we'll show you another puncture from the same station. Another needle, please. Thank you, Sister Swarupa. Let's go in. Here we are going to use little bit of suction. Let us show you some 2 or 3 punctures. So needle hub is fixed onto the adapter, and then we release the sheath. Let's see the sheath comes out simply. Can you please adjust the sheath? Yeah, now you do it. No, it has to be locked here. Yeah, do it. Some issue with the seat adjuster. Needle is fixed. Yeah. Slightly, sheath should be seen, sheath is locked. Let's do another puncture. Okay, and we'll target a different area in the node. Can you hold at the mouth end, please? Sheath was well seen before the puncture. And let's adjust at 3 centimeter. The stillet is pulled out, and we do a gentle puncture again. You can see the needle very nicely in. Another slow pull followed by a suction. You must keep a flush ready at the end of the procedure. So needle moves from cortex to cortex, 15 to 20 revolutions. Let's get the suction syringe. Yeah. How was the material in the first pass? Good material. Let's give this material for Dr. Ronaldo. Let's try to say whether we can get a core. Needle tip should be always visible. We have a left atrium beating below that. We will do a little bit of fanning in the node. Fanning sometimes adds to the yield of the material. Okay. Suction off. Suction disconnect. Remove the syringe. Remove the syringe. Okay. Needle up. Needle has to be locked. Yeah. Zero the needle so that needle completely comes into the sheath. You can see the sheath, and then you take out the sheath. Unlock. Unlock here. And take it out. We are good endobronchially, no major ooze. When you focus on the preparation, remove that bottle from the place. You don't have Olympus needle, huh? Because what is happening? Then he doesn't work now. Clean kar denge. Give it to me. Hold the scope, please. Hurry. Yes, sir. Yeah, we'll go to the US. So we'll show you the staining as well as the vivoscope. So cameraman, please focus at the pathology site. And onwards, we will show you an USB FNA. So let us change the iGel to ET tubes for better comfort of the patient. So endobronchially, you have to reconfirm there is no ooze. You can do a check white light bronchoscopy. Here the optics are excellent. So we know the puncture site is good. You know, the node is fine. The endoluminal, there is no ooze. Airway is clean and we are coming out. Anesthetist to take over, please. And please explain the steps of staining as well.
Now, I have to get a feedback if they hear me or not. Can you hear me now? Hello?
We can hear you, sir.
Okay. Okay, so we are here. Can you hold this, please? So we put the content of the needle directly on the special matrix, the cytomatrix, which is a polymeric matrix, which is simply retaining the sample, also small tissue fragments. And now we start with the staining procedure, a little bit of 70% ethanol, around 10 seconds. Then we have one first dye, it's actually in orange. It's binding to a DNA, that's why you will see the nucleus and the nuclear details around 20 seconds. And then we do another dye, which is reassembling eosine. So the first one was reassembling methoxylene. So this is fast green, which will reveal more of the cytoplasma and the extracellular matrix component. Also around 20 seconds. Then we redo the procedure to have a more homogeneous staining. So what is very important here while I'm doing this is that I'm not smearing, I'm not touching, I'm not interfering with this material, which will be completely reused again after vivoscope processing to do your normal histopathological analysis, also immunohistochemistry, and also molecular analysis. So the same tissue that you will see here, repeat, can be completely reused. We are now ready to mount the sample. So the last passage is always aligned to remove the excess of material. And then we transfer to our, what we call a sandwich method. So to their glass slide with magnets, ready to close it. And if you come up, then so we put it into the confocal microscope scanner, the head, and now you should see the video output, not the camera anymore. So could you please switch the video output, please, from the vivoscope? Okay. So you should also have it not like this, but anyway. So you see on the right-hand side here, you see a macro view of our sample on the special matrix. Now we start the acquisition. So as I said again, so the tissue is not smeared, it's fully preserved, and now we are at the surface of the glass. And I'm just will image the surface of of the specimen. So I will select the area where the tissue is, and then we will launch the acquisition. So now the acquisition started. So you see many fields of view are put together to generate a mosaic image, what we call. So you see already some material. Here you see, up here you see the cytomatrix or the special polymeric matrix that is interacting and trapping tissue. And here you start to see here a lot of sample. Yeah? So once it's done, of course, the pathologist, the cytopathologist doesn't have to be on site. They can also immediately have these images and zoom in and zoom out to evaluate and make some annotation and give an adequacy check and maybe also preliminary diagnosis. Again here, I'd like to emphasize this, but you see that the material is retaining its architecture. So there are histological features in here because it's not smeared. So now it's almost done, and then pathologists will comment on these images.
क्या हुआ? नहीं, क्या रनिंग हो रहा होगा? क्या है इसमें एनएस में? विटामिन का, B12.
Okay.
Hello? Hello? Hello?
Yes, ma'am.
The slides, image is not focused. It's seen there? Okay. So for the rapid on-site examination, cytospheres are provided to the pathologist, that is me. And we have done rapid staining with Toledan blue stain, which is commonly used for rapid on-site examination. And what I could see on the smear is it is adequate smear because I could see the pathological findings. There is suppuration with necrotic debris in the background. At the same time, I could see clusters of cells accumulating at different foci, and these contain epithelioid cells collection. So the collection of epithelioid cells is granuloma. So this is a suppurative granulomatous inflammation. It is necrotizing granulomatous inflammation with suppuration. So that suggests infective etiology. And if you compare with the history, the patient has a history of fever, loss of weight, and also on radiology, the necrosis is identified. So the cytospheres very much correlate with the radiological and the clinical findings. It is suggesting infectious etiology, which could be commonly tuberculosis, for which can be further confirmed with special stains and microbiological investigations. At the same time, the material is also processed in Vivascope, and that also shows a good amount of material. Let me see the higher magnification of this. Yeah. So what we are seeing by and large is the lymphoid cells, and then we'll just go zoom out. Let me see the, yeah. Just move. Yeah. Can you focus here? Yeah. Yeah. So we can see some pale areas. So these are containing, you can see the karyorectic debris. So these are the necrotic foci. Okay. And if you see still smaller cells, so this is the paler area which is containing, you can see the karyorectic debris, the bluish debris. This is the nuclear debris that we are seeing. And here scattered we can see epithelioid cells. So this, in correlation with cytology, where I could also see epithelioid cell collection, this very much suggests the collection of epithelioid cells, that is granulomatous focus, with necrotic debris in the background, suggesting necrotizing granulomatous inflammation. Yep. Let me just see other. Can I just drag it? No? Okay. Okay. Yeah.
And then you can try.
Yeah. So here in this particular case, if you see the suppuration is dominating, that is why the neutrophils are seen more clearly than the epithelioid cells. And the epithelioid cells are seen more scattered. So let us go to the previous focus. So again. So here also we see the epithelioid cells, but the elongated nuclei, smaller nuclei, these are the epithelioid cells. And here the suppuration is dominating. So we are seeing more of debris, more of neutrophils and scattered, loosely scattered epithelioid cells in this focus.
So the amazing revolution on rapid onset evaluation which is happening and giving us excellent diagnostic. It's suspected case of tuberculosis looking at the clinical history and radiology. And the rapid onset evaluation is simple EBUS TB 2 punctures only confirm the diagnosis for us. In India, we'll send the material for microbiological investigation like gene expert AFB culture, where we take the suction or EBUS TB samples into for saline for the microbiological investigation. So let me show you the USB FNA. Here we are going to use the same Fujifilm scope, and we are going to put the scope into the esophagus. Patient again lying in supine position. We don't change the position of the patient as which is done for gastroenterology. They do a left lateral position, we do it in supine. I'll try to show you minimalist approach to identify the landmarks and see, the adenal is not enlarged in this patient, so I don't know whether we'll be able to visualize it properly, but we will attempt to visualize the adenal as well. So this is 6.4 millimeter scope, very smooth, very simple for the patient. Before USB FNA, you should always ask the history of any difficulty in swallowing, any history of hematomasis, any history of peptic ulcers. If the patient is chronic liver disease, history of esophageal varices, better we give these cases to a gastroenterology EUS scope rather than R scope. But in lung cancer staging, when you have radiology suggestive of lower mediastinal lymph node, you then we do EBUS followed by EUS. We generally do EBUS first followed by EUS so that you don't contaminate the airway with esophageal material. So here for the demonstration purpose, patient is intubated here. However, you can do with a simple nasal prom oxygenation, minimum midazolam, propofol, ketamine, or you can use minimum dose of propofol. And this is a bite blocker in place so that patient wakes up accidentally, he doesn't bite. We are going to slide along the tongue. And you can see the tube in place. Let me just clear the secretions first. That's the tube through the vocal cords. So what we are going behind the vocal cords. From the left side, the entry into esophagus is very smooth, very gentle. You can do it under vision as well as we can do if you very smoothly like Ryle's tube like insertion. Suppose during the insertion you feel any resistance, then you can use a simple flush, a saline or air flush. So give me an air flush here, please. Simple air flush can open your esophageal lumen. You can see esophageal lumen nicely with the 10-degree forward view. And then you can advance your scope further without any difficulty. The landmarks here, what we use, we are trying to reach to the gastroesophageal junction till we identify the liver, okay? So can you see this structure? Can you reduce the depth, please? Zoom out. Now in esophagus, the first structure we identify is the left lobe of the liver. So you can see here, my transducer is pointing at 12 o'clock. You can see this suction valve. The transducer is also pointing at the same location. So I'm looking anteriorly at the 12 o'clock, and you can see a left lobe of the liver. You can see few hepatic veins and infra vena cava turning into infra vena cava. So when I pull the scope proximally, it drains into inferior vena cava into the right atrium. Now in esophagus, there are no endoluminal landmarks as that of the EBUS. So we stop at 3 locations, and I want your attention here. We stop at liver, we stop at the left atrium, and then aortopulmonary window, or your Mickey Mouse sign. These are the 3 landmarks we look at to identify the nodes around them. Now, if you get lost in the mediastinum, please come to the liver or left atrium as your point 0, and then from here onwards you start screening. So we are at the left lobe of liver, and you can see there are nice veins draining into the inferior vena cava. When you come forward, you'll be able to see right atrium. From right atrium, when you come proximal, you'll be able to see a left atrium. So let me zoom on the screen now. Zoom please, excellent, that much. So here, inferior vena cava going into the right atrium. The junction of inferior vena cava going into right atrium, exactly at the diaphragm, is paraesophageal or a station, or that is station 8 or station 9. There's a controversy on the labeling. It doesn't matter if it's 8 or 9 because they are inferior mediastinal N2 nodes for a particular side of the cancer. So from here, we come up, and can you see this? This is, on the left side you have the right atrium, on the right side you have left atrium, and that is the interatrial septum. How to identify that? Can you stop the Doppler please? How to identify left atrium? You can just rotate your scope little anti-clockwise, and you can see there is an aortic outlet. So that's the aortic wall. The wall which is doing a namaste-like thing is the aortic wall. And when you rotate further, and when you go down, you'll be able to see the mitral wall down. Can you see this? That's the wall which is flapping like a flying bird. That's the left atrium, then mitral wall, and then the left ventricle below that. When you rotate it slightly, you'll see the left ventricle out with the aortic wall, and below that, sometimes you'll be able to find the pulmonary trunk as well. Okay? So left atrium is clear. From left atrium in the same axis of the left atrium, that is right atrium, interatrial septum, left atrium. When you come up, you start identifying this location. That's the subcarinal window. It is located between the left atrium and the right pulmonary artery. So let me just show you a right pulmonary artery as well. Okay? So that's the right pulmonary artery here, and that's the left atrium. And this location is subcarinal lymph node. Beyond this, we are going to come to aortopulmonary window. So slightly up, that is upward movement, rotation, you can see the tracheal cartilages with reverberation artifact of the air, and you rotate towards the left side around the 9 o'clock, and you start identifying this aortic arch and a pulmonary artery, the famous Mickey Mouse sign. I hope it is clear here. The right side of the screen is showing you an aortic arch. Then there is a station 4L here, and then we have left main pulmonary artery below that. From aortic arch, when you come little upward, you will start seeing the branches of the aorta. Okay? So this is the aortic arch, and we will try to show you station 2L here. So that's the branch of the aorta which is coming out. Let me just illustrate the Mickey Mouse sign again. And here, we start seeing the subclavian artery, and here the location is 2L. Can you zoom on the screen, please? Zoom again, show the node clearly. That's the node. Okay? Then, when you come up further, you may rotate the scope little bit towards the right. Then you see brachiocephalic arteries. You can see some venous confluence in front of that at the bottom of the screen. And then the 3A is located prevascular zone. And this is a nice 2L lymph node located in this area. Okay? So I'll show you one more USB FNA from the station 7 where we are stopping. Okay, excellent. We'll do the procedure here, and we are handing over to the auditorium. Thank you.
Thank you so much to the team for that wonderful presentation and demonstration from the OT, and this excellent step-by-step demonstration of the entire procedure with great insights into the tips and the tricks of the trade, and that we learned a lot from your demonstration. Moving on, If the last session was an exercise and demonstration of how things can go wonderfully well for a procedure pre-planned, the next session will look into things that just do not go as per your plan. To conduct this session in the operating room failures and disasters when pulmonologists do their best, may I please call upon the chairpersons to lead the discussion. Dr. Sami Onyanka, Dr. Yaqub Al-Mahruqi, and Sunil Kumar K. Please welcome the chairpersons of the discussion. The first case scenario will be discussed by Dr. Tinku Joseph, sir. Over to you, sir. Thank you.
I think this crowd doesn't need an introduction to Dr. Tinku. I think he's a person who started interventional pulmonology in a big way from South India. I think probably to enumerate the complications what we encounter, one mistake of this can be a lifetime scars in our lifetime actually. As a beginners, I want you to be more cautious. Whatever videos, what the expert like Tinku shows actually, has to be taken with a lot of understanding in terms of how to handle this thing. So the safety of the patient is a top priority, followed by safety of the device is also equally important task. Over to you, Tinku.
A very good afternoon, ladies and gentlemen. At the outset, let me thank Dr. Hari and Preeti and the wonderful team of BRONCHUS 2025 for giving me this opportunity to speak a few words and show some interesting cases regarding the potential complications which an interventional pulmonologist can face when you deal with central airway lesions in the operation theatre. So I'm not going to focus about each and every aspects of interventional pulmonology. To be precise, I'll be showing a couple of cases on airway stenting and what all possible issues you can face when you put a stent into an airway. So the title I have kept for this presentation is Horror Stent. Now let's see an interesting case. So here we have a 25-year-old lady who had a history of post-intubation tracheal stenosis. Patient underwent balloon bronchoplasty. It failed, and then subsequently patient underwent a tracheal reconstruction surgery. Then, couple of months later, patient presented with a history of cough, shortness of breath, and stridor. What next? So there is tracheal stenosis. Patient underwent post-balloon bronchoplasty. It failed. The next step was to refer the patient to a thoracic surgeon. He did a tracheal reconstruction surgery. Again, it failed. So we had an MDT discussion regarding what are the possible options which we can consider for this patient. And then the plan was to consider deploying a silicone stent since the patient is significantly symptomatic. Now let's see how this procedure was done. So the patient underwent silicone stenting. So what has happened here? So question is to the panelist. Is it a perfect stent? So what has happened is, I deployed the stent, then did a bronchoscopy. I couldn't trace the distal end of the stent. So the stent has actually gone through the posterior tracheal wall into the posterior mediastinum. So now the question is, what next? A 24-year-old lady, you have deployed a stent, a silicon stent, and it has gone into the posterior mediastinum. You can see only the proximal aspect of the stent. What next is the question. So immediately I called my thoracic surgeon, head and neck surgeon. I didn't have an answer regarding what exactly has to be done for this patient, because one option which I had in my mind was to pull out the stent, but I don't know where the distal end of the stent is, what could be the potential complication which I have to face when I pull back the stent. So the thoracic surgeon came. Head and neck surgeon also was kept as a backup. I thought maybe I should call the ECMO services also if something goes wrong. So all backup was ready, and then the surgeon said, you pull out the stent. Nothing is going to happen because esophagus is there behind. So we managed to pull back the stent. And then subsequently the same stent was pulled back and it was used to cover the communication. So now you can see the stent is back inside the tracheal lumen, and it is well, the fistulous communication is well covered. So the point which I want to highlight from this case is, whenever you are dealing with a tracheal stenosis, especially in surgical cases, you have to be extremely careful, because patient has already underwent 2 procedures, and after the tracheal reconstruction surgery, patient had a false tract in the posterior tracheal wall. So when I attempted to deploy the stent has actually gone through the false tract in the posterior tracheal wall, and fortunately, we were able to pull back the stent and seal the fistulous communication. So this is the initial picture, and this is after the procedure. Quickly moving on to another interesting case. This is of a 22-year-old lady presented with history of shortness of breath since 1 year. Patient was apparently treated as a case of asthma and not responding to standard treatment. Subsequently underwent a CT, and CT showed an intraluminal growth involving the tracheal lumen. So here you can see there is a broad-based lesion involving the posterior lateral wall of the trachea, extending almost 3 centimeters distal to the vocal cords, all the way up to the carina, and involving the left main bronchus as well. So this case, we did a biopsy, and it came as adenoid cystic malignancy. So the plan was, so this is the initial plan which we had in mind. First option is to consider stent. The options which we had is to put a straight tracheal stent or a Y silicon stent. Option number 2 which we had is to consider a reconstructive surgery, and option number 3 is palliative. But patient was hardly 22-year-old. We never wanted to refer this patient to a palliative clinic. But unfortunately, the lumen within the trachea was not sufficient enough to consider a silicon Y stent. So that's why we were forced to deploy a fully covered metallic stent. So the patient underwent a metallic stent, and then this is the follow-up bronchoscopic video. Here you can see there is a lot of mucus retention within the stent, and the distal end of the stent there is presence of granulation tissue bar tumor ingrowth. We did a biopsy, it was not a tumor ingrowth, it was granulation tissue. In the meantime, patient had underwent bronchoscopy multiple times, and then later on patient came back again, and at that point of time the fifth bronchoscopy showed. So now this is the fifth bronchoscopy which patient had gone in. So if you carefully see, there is at multiple points the metallic stent is fractured, and with significant ingrowth of the tumorous tissue at the distal end of the stent. So now we are in a tricky situation. We have a young lady with adenoid cystic malignancy, tracheal stent in situ for almost close to 10 months. Unfortunately, the stent has fractured at multiple points. Now we have very few limitations. We again went back and discussed this case in our multidisciplinary board. The options which we had at this point of time is to consider removing the stent under ECMO support, but already the stent has fractured at multiple points and the patient was not keen for that. So we considered a procedure called as autologous tracheal transplant. So these are the steps of autologous tracheal transplant. At first, a silicone stent will be placed on the forearm, and then using skin graft and patient's costal cartilage, and a trachea will be, a neotrachea or a neocarina will be created on the forearm. So this is a neotrachea on the forearm, and this is the subsequent bronchoscopy which we are doing after 1 month. Just to ensure that the graft is healthy, we will take multiple biopsies from the neotrachea which is there on the forearm, just to ensure that the trachea is healthy. And after 1 month, this neotrachea was transplanted to the patient. So this is the resected trachea. You can see at multiple points the stent is fractured and eroding through the tracheal lumen, and the neotrachea has been transplanted to the patient. So the most important point which I want to communicate with you guys is regarding whenever you take a decision to deploy a metallic stent, you always have to deal with its complications. Most of us tend to show fantastic images of before stenting and after stenting, but the real complication starts to arise 1 week after stenting. Mucus retention, halitosis, granulation tissue formation, stent fracture are all potential complications which you can face when you deploy a metallic stent. The last case, 65-year-old gentleman with history of progressive shortness of breath, cough and stridor, diagnosed case of CA esophagus with tracheal involvement. Patient underwent SEMS from another center, followed by CT and RT. What is this? So patient was referred to us with stridor. When we did the bronchoscopy, we found some pieces like this within the tracheal lumen, and this was all within the trachea. So now let's see what was done for this patient. So this is the initial images of the trachea, and this patient underwent this SEMS fully covered self-expanding metallic stenting from another center, and exactly 2.5 months later, patient came back with stridor. patient came to the hospital, we did a bronchoscopy. So this bronchoscopic images and videos, we have to keep in mind these are the issues which you have to deal with when you stent a patient. You can see that is the coating of the fully covered metallic stent has been broken at multiple points. Extensive mucus retention. Almost the stent is completely blocked. The stent is fractured at multiple points. Subsequently, the plan was made to take out this metallic stent because it is fractured at multiple points. There is no point in retaining the stent, and patient is having spider also. So you can see at multi-level the stent is fractured, and it has created a false crack within the tracheal lumen. Now the major challenge is regarding how to take the stent out. So one option is to place the patient on an ECMO support and consider removing the stent, because at times, again, just like the previous case, this stent might erode through the trachea and can lead to a serious complication. But when we did the CT scan, CT showed that the tracheal loop, the tracheal walls were intact. There was no through and through perforation. So that's why this procedure was done without ECMO support. So using a rigid forceps. So most of the stent companies tends to market that above the stent as well as below the stent there might be a loop. So most of the companies will be telling you that this loop is kept so that in case if you want to retrieve a stent, you can catch the loop, twist it, and the stent will come out. So this video is going to give you clear-cut information that such loops are absolutely useless. Most of the times, when you catch the loop, nothing is going to happen. The loop only is going to come out. So here I'm catching the loop and I'm twisting it. So half of the stent has come out and the other half is still in the tracheal lumen. Then again, the broken stent was removed in piecemeal. So it's an extremely time-consuming procedure, and you have to ensure that the airway is not been compromised, and also keep the backup of chest tube, because at times you can cause pneumomediastinum or a pneumothorax when you attempt to remove a metallic stent. So finally we managed to remove the entire broken metallic stent. Unfortunately, there was no residual tracheal stenosis. So patient didn't have much of stridor and subsequently was extubated and was referred back to the oncologist. So this is a stent which was retrieved. You can see that it is broken at multiple points. So I would like to conclude this talk on airway complications by these following points. First and foremost, never ever trust the airway. You can always beat, even it's a simple case also, you might end up facing major complications. Partial obstruction can become a total obstruction with little stimulus or little warning. Difficulties cannot always be prevented. Choose your cases wisely. I would say the best stent is a stent which is not placed. Before considering any form of therapeutic bronchoscopy, always ask these 3 questions to yourself as well as to your team members. First and foremost, is the patient's dyspnea due to a central airway obstruction or not? At times, the patient might be dyspneic due to an extrapulmonary pathology. Rule out extrapulmonary pathology, because if the patient's dyspnea is due to pulmonary embolism, you're not going to achieve anything by debulking a tumor or putting an airway stent. Point number 2, is the lung beyond obstruction viable or not? If there is a left or a right mainstem bronchus lesion, and if the underlying lung is completely destroyed or damaged, you are not going to achieve anything by debulking such a lesion. It's going to be absolute wastage of resources. Point number 3, is surgery a viable option or not? If surgery is a viable option, there is no point in competing with your thoracic surgeon. You have to keep the thoracic surgeon, your interventional radiologist, as well as your anesthetist in the loop. Fight to avoid unnecessary arguments with them. If surgery is a viable option, always refer those patients to your thoracic surgeon. So this is our team which has been supporting me for all the procedures since past like 8 to 9 years. Thanks a lot for patient listening.
Thank you so much for that enlightening lecture, sir. Thank you very much for making it real that beyond the excitement of performing procedures, there's something that's very real that can go very wrong very fast. If I might ask a very quick question about the first case that you discussed, it was a young lady, and all that was required in the end after multiple sessions with the MDT was repositioning of the stent so that the posterior defect was covered. Did we follow up on the closure of the defect, sir?
Sorry, I'm not able to.
I just wanted to know, sir, in the first case that you discussed, did we follow up on the closure of the defect, the fistulous connection?
Closure of?
The defect, the posterior wall defect that was covered by the stent repositioning.
So the case of that young lady with, in which the stent went into the posterior mediastinum, we kept the patient on regular follow-up. For every 2 months, we called back the patient, and compared to your subglottic stents. So fortunately, this was like a deformity which was there around 3 to 4 centimeters distal to the vocal cords. So the mid-tracheal stenosis tends to do well. The mid-tracheal stents tends to do well compared to your subglottic or very proximal stents. So fortunately, this patient didn't have any complications. It's been almost close to 1 year. We did subsequent CT, the wound is healed, but then I had a plan to take out the stent. It's been almost close to 1 year, but patient didn't have any major post-stenting complications. So the patient also asked me, should I take, is it mandatory to take out the stent? I don't have any symptoms. I also thought maybe it's better to retain the stent because I'm not sure regarding what is going to be the after effect after pulling back the stent. So I thought to retain the stent for another 6 months, and maybe at a later date I'll consider removal. But such patients, be it any stent, metallic or silicon, the most important point is that these patients have to be kept under follow-up. And also, you have to discuss with the patient and their relatives regarding what all are the potential complications. Stent is not going to create any wonders. The post-stenting phase, you might have to come back, follow up with the doctor due to various issues.
Thank you so much, sir.
Thank you.
Any other questions?
Like, if once you deploy a stent, actually, how often you call for a follow-up bronchoscopies?
Follow-up.
And the care of a post-transplant patient, post-stented patients.
I'm sorry, there is a lot of echo. I'm not able to.
Post-stented patient, what is the protocol, what do you follow at your center?
Post-tracheal reconstruction.
Post-stenting of a patient.
Post-stenting follow-up.
Post-stenting of the patient for any central airway obstruction, what is the protocol, what you follow in your center? And what are the medications, what you, any nebulizations, anything what you follow post-stenting care?
So I generally prefer to avoid a stent as much as possible. Only if it has got a clear-cut indication, we consider deploying a stent. The most important point, follow-up is required, but you have to tell, clear-cut communication has to be there with the patient and the relatives, because the major issue which you can face is retention of secretion, halitosis, frequent requirement of bronchoscopies, granulation tissue formation. So what we practice in our center is that once you deploy a stent, those patients has to come back for a follow-up. Initially, after stenting, 2 weeks after the stent, then thereafter 1 month later, and if you feel things are going pretty well for at least 6 months, then I will do a subsequent CT. If you are deploying a silicone stent for a post-intubation stenosis, the dictum is that once you deploy a stent, you have to retain the stent for at least 9 months to 12 months, because only then you will be able to get at least 80% success. If you are deploying a stent and if you are forced to remove the stent within 1 or 2 months, there is always a chance that the trachea might collapse again and the patient will have to undergo a surgery.
Thank you. Can we have just one last question before we move on to the next session, please?
Yes, Saurabh.
Audible to you, I hope?
Yeah.
The thing is that last year we did around 6 metallic stentings for malignant tracheal obstructions or bronchial obstructions. The thing is that since the metallic stents have so many issues, the patients need to be followed up. They have halitosis, recurrent LRTIs, and they need nebulizations and things like that, granulation tissue buildup. So are we slowly now coming to a point where now we believe in India, what we get is the advanced malignancies only, especially at our center. So are we slowly at a point of time we will be abandoning metallic stenting for these malignant stenosis altogether because of the inherent issues or because of the poor prognosis of the advanced malignancy itself?
Okay, so your question is regarding whether we are slowly moving away from metallic stents to silicone stents
Definitely,
or not.
definitely. For malignant stent.
Due to complications. So the major issue what we are facing currently in India is regarding the quality of metallic stents which are available. There are lots of companies which are manufacturing and supplying self-expanding metallic stents, be it partially covered or fully covered. But the major issue is that we deploy the stent, everything looks fantastic in the beginning, but most of this stent causes a lot of complications like stent fracture. At times the coating over the stent might get detached. So it's very difficult to get quality metallic stents currently in the Indian market. There are a couple of companies which are manufacturing and supplying to the India. Except 1 or 2 companies, rest all which we have used, the quality is pretty bad. So slowly, once you have adequate skill set, I would say that 90% of the cases you can manage with a silicone stent compared to a metallic stent. There are clear-cut indications when you want to deploy a metallic stent. Only in such conditions consider deploying a metallic stent. In all other conditions, try to consider a silicone stent, or if the patient is affordable enough, you can consider a biodegradable stent also. But the most important point is that if it's a benign pathology, you should 100% you have to avoid a metallic stent in a benign pathology.
Okay, thank you.
Thank you.
Yeah, last question actually. Like when you deploy a stent actually, for your first case, would have gone for a hitch stitch, for that mid-tracheal stenosis. If at all, if you are very sure on that first time when you deploy a stent, would have gone for a hitch stitch that would have avoided this displacement of the stent.
So your question is regarding placing hitch stitch for silicone stent. Yes. Okay. So the first case which I showed, it was a mid-tracheal stenosis. And so in a mid-tracheal stenosis, ideally it's practically impossible to put a hitch stitch. And second point is, if you choose a fairly good size of a silicone stent, you may not require to put a stitch in each and every condition. Because the general dictum is that use a slightly larger stent compared to the airway lumen, then the chance of migration is less. Hitch stitch we generally reserve for the upper stents, like if the distance from the vocal cord is like around 1.5 to 2 centimeter and you're placing a subglottic stent, the chances of migration of a subglottic stent is much more. So you can consider placing a hitch stitch in the beginning, but hitch stitch has got its own complications because at times the patient may not be taking care of that area properly. You might deal with infection. At times the stitch might break and the stent might go down. So if you take a decision to put a stitch, you have to be selective with the cases. You can use stitch for proximal stents only if you feel that the chances of migration is very high. Otherwise, try to avoid a stitch as much as possible.
Thank you so much, sir. It was a wonderful discussion, and I'm sure a lot of people have had their questions answered. Thank you so much for your lecture, sir.
Okay,
Thank you. May I request the chairpersons to please continue to be seated there. Now that we've had a look at how things can go very, very wrong, there are literally sometimes when there's a stroke of luck that literally saves your skin in the OT. To give a small talk on the great escapes in the operating room when God literally saved my day, it gives me great pleasure to announce our very own Dr. Preeti Vidyasagar.
A very good afternoon to one and all. So we keep talking about our success stories before procedure, after procedure and everything, and now we have come to a level where we are accepting and acknowledging failures in OT. So let us see how God saved my day. This is a 66-year-old female, diabetic, hypertensive, known case of chronic kidney disease. She was admitted outside at a local hospital for fluid overload. She was intubated, recovered, and she was discharged. She came to our center for hemodialysis, and then the nephrologist did a CT scan to evaluate her breathlessness, and this is what he saw. And he referred us for EBUS because the report said that there are necrotic lymph nodes in the mediastinum. At this point of time, I request for a show of hands at the audience and also comments from the chairpersons. How many of you would make a pass, EBUS pass in this lymph node? Chronic kidney disease, tuberculosis is definitely a possibility. Anyone who would say that definitely I would make a pass? I can see some of you shaking your heads like this. Okay. So it's very important to follow stepwise protocol. So we started with the white light bronchoscopy here. So white light bronchoscopy always before EBUS. We can see that the posterior wall is erythematous, pathological. It is not very usual. Any experience from anyone with similar kind of findings? So as this part of the bronchial tree looked abnormal, we started screening for the lymph nodes with EBUS. And again, stepwise protocol, we always need to put Doppler before making a pass into the lymph node. Even though it looked like a coagulation necrosis sign, we can see the swirl inside. And when we put the Doppler, we could see that there was vascularity inside. So at this point of time, we also have to decide at one point when not to do procedure also, even though patient is intubated and we have already started. So we abandoned the procedure. And then after discussion with the nephrologist, we went ahead with contrast CT. This is how the contrast CT looked like. Any comments? So this was right brachiocephalic artery with multiple partially thrombosed aneurysm. So we can see here that there is aneurysmal dilatation. So after this, we were more curious regarding the findings and also why aneurysm in this patient. We took a detailed history and multiple pricks were made while central line insertion in the ICU in the outside hospital. So we feel the aneurysmal dilatation is because of the multiple pricks and a false track that was created that led to the aneurysmal dilatation of the vessels there. So literally God saved our day because we didn't pass and we went through stepwise protocol, white light bronchoscopy and also putting Doppler before passing the lymph node. Any similar experiences or any comments from the chairpersons?
I think the case is really, really good because it highlights the importance of contrast media when doing CT scans. It highlights the importance of contrast media when doing CT scans. There's several reports in Germany as well of lesions that looked like tumors, but it ended up being a vessel malformation. Unfortunately, their colleagues did the biopsy thinking it is a tumor, but it ended up having a large bleeding complication, which was managed with surgery. But this highlights that as well, that before doing any biopsy, depending on the kidney function as well, it's still very important to always have a contrast media CT before doing a punctures, because vessel malformation is a very, very common finding in CT scans, which otherwise get missed. Has anyone had an accidental vessel puncture in the audience? No risk, no fun, apparently. What do you say?
Yeah, I think to keep up one more watch about Delorphis anomalies is also one more thing actually. We just see that mucosal hyperemia can be part of a Delorphis anomaly also, where we enthusiastic to do a biopsy that can also have a nightmares in terms of excruciating bleeding, all this stuff could be a possibility. That is also a word of caution which has to be kept in mind. I think Doppler is also one more helpful tool to put in a needle, before needle actually. Doppler is also a good practice to do. As you rightly mentioned, that contrast CT is always a thing when you are in a DISE, when somebody who's having a chronic kidney disease with platelet dysfunction is always going to be a nightmare actually when they start bleeding. So precautions, stick to the basics is a need of the hour actually, what this case enumerates.
So like the chairpersons rightly said, CKD platelet dysfunction also, and again stressing upon the stepwise checklist of the procedures. So I'll leave it to imagination of all of you, what would have happened if we had made the pass. Thank you.
Thank you.
Thank you so much, ma'am. That was indeed a scary lesson. But going back to the basics, you can't skip any steps on the way just because you want to get it done. And sometimes, maybe most of the times, it's better to err on the side of caution. May I thank the chairpersons for hosting this wonderful session. And we move on to our next discussion on EBUS FNA versus EBUS crionodal. For this, may I invite Dr. Eric Daniel to take the stage, please.
All right, very good day, everyone. First of all, on behalf of me, myself, and also the team from Indonesia, let's give a round of big applause to Dr. Kishan, Yashoda Hospital, and BRONCHUS 2025 for this great event. Let's give them a round of applause. Yes, excellent. All right, so my name is Eric. This is my third time in BRONCHUS. So I learned a lot actually, Preeti, from your slides. So that's why I think it's very, very important for us to actually understand the basics, how we should do EBUS CBNA, and whether we should perform cryo biopsy on every mediastinal lymphadenopathy in patients with lung cancer. So let's start. So as the introduction, since the emergence of EBUS CBNA by Professor Yasafuku and so many professors who actually attend events, we learned that we actually can maximize the results of the biopsy itself by doing simply a minimally invasive procedure. Even we can do this procedure to our outpatients. It can also give us a real-time image of the ultrasound, which is provided by the scope itself. And again, this is a very standard, basic lung cancer staging procedure. And there, since RB launched their new cryoprobe, which is the 1.1 cryoprobe. So now we understand there's a new terminology, which actually, I think, if I'm not mistaken, it was first introduced by our dear friend here, Dr. Kishan. It's transbronchial crionodal biopsy. So what is TBCNB? So TBCNB is an advanced technique that actually use cryobiopsy probe instead of use your conventional needle aspirations while doing EBUS. Again, so what's the advantage of this cryobiopsy instead of using the conventional or traditional EBUS needle? First, it will give you a much larger tissue samples. And I'm very, very sure that we can agree that size is matter when it comes to histopathological assessment. So again, it will improve your diagnostic yield, especially for benign condition and tumors that require a subtyping. So before this discussion, before this presentation, I get a lot of questions. So Eric, when should we actually consider to do TBCNB? In what situation? So based on a lot of publications about TBCNB, so yes, we can actually consider to use this for benign condition. Again, in the context of lung cancer, it will increase the diagnostic yield, especially when we want to run a molecular testing like EGFR, PD-L1, ALK, so on and so forth. Again, it will increase the possibility of our patients to get targeted therapy, especially in patients with non-small cell lung carcinoma. So this is quite very, very clear for every one of us to read, so I don't need to read one by one on every point. But again, the EBUS TBCNB is actually can perform, we can use our flexible bronchoscope. We still need the EBUS scope to guide us. But again, we need to remove the specimen and block. The optimal freezing time, as I discussed with Sammy and one of our friends, Dr. Ko, he published a paper about the freezing time, and it's around 4 seconds. And before this, actually, the cryo was widely used to diagnose IPF or DPLD. So other indications of the cryobiopsy, we use this quite a lot for peripheral pulmonary lesions, right? Under fluoroscopy guidance or con-beam CT. So this is the pictures of EBUS CBNA. Now they will come with slim EBUS. And then this is the image that you will get from the ultrasound. And then, as I mentioned before, we use 1.1 cryoprobe to actually do TBCNB. So I'm sure everyone are familiar enough with this procedure. So this is one of the procedure, and this is when I'm still very, very young, probably 10 years ago. So this is the conventional EBUS CBNA, right? So you pass the needle after you locate using your ultrasound, and then you do the jabbing with slow pull method. Again, with slow pull method, you wish to increase or you wish to get more specimens in terms of volumes, of course, and also the size of the specimen. Again, the aim is to get this specimen adequate enough to run for immunohistochemistry and molecular testing, as what suggested by European Society of Medical Oncology. So how we perform EBUS TBCNB? So again, we use EBUS scope still. We still need to locate the enlargement of mediastinal lymphadenopathy. And then after that, we can use the 1.1 mm cryoprobe. But in many centers, also in my centers, we use 21 gauge needle. Some other centers use 19 gauge needle, which is slightly bigger. But again, so after you pass the 21 gauge needle or 19 gauge needle, and then you smoothly use the needle track and introduce your 1.1 cryoprobe to the lymph node, right? And then you will get this very beautiful specimen just within 3 or 4 second freezing activations. So again, the gold standard from meta-analysis, so we have 14 studies. The results is the diagnostic yield actually for EBUS TBNA is actually very, very good. So it falls between 84 to 92%, and the sensitivity is actually 91%, while the complications rate for EBUS TBNA is actually very, very low, and majority of the complications actually very minor. I never experienced any major complications doing EBUS for the past 15 years. So although from this publication back in 2020, the authors didn't conclude if EBUS actually safe and accurate, but again, EBUS procedure is very operator dependent. It's up to the operator, the man behind the gun, right? So again, we need more high quality studies and more prospective studies. But so if we compare with chest CT or PET scan, I think one of the caveats is we still need to understand, especially in India, Indonesia, in my country, we're still battling with tuberculosis. So one of the caveats is if you saw or if you witness any enlargements of the lymph node, do not ever take into your consideration that you don't need to sample that station. No, you shouldn't. You still need to sample the lymph nodes, right? So again, EBUS-TBNA has a better sensitivity and specificity, also diagnostic accuracy. The negative predictive value is actually about 91%. As suggested by HICC, that select EBUS-TBNA is the best initial test, especially in patients with N2 or N3 diseases, which is contralateral, right? So again, yes, it's good to have PET-CT, but to sample the mediastinal lymphadenopathy is actually very, very important. So result clinically suspicious nodes should be followed with surgical sampling if the result was not very good. So this is just quite a reminder for us about the role of rapid on-site cytology examination, of ROSE. As suggested by chest, in patients with suspected malignant disease undergoing EBUS-TBNA, we suggest, or chest actually suggests, to utilize rapid on-site evaluation over usual care. Again, this is a conditional recommendations with very low certainty of evidence because it's up to the pathologist to read. It's very subjective. Again, using ROSE, it will not increase the diagnostic yield of the EBUS. I mentioned before, it's up to the man behind the gun. Second, from the meta-analysis, we also understand there's no significant difference in terms of diagnostic yield, procedure time, or how many passes that you need to sample the lymph nodes. It will or it might reduce your number of aspirations, but again, back to the ACCP recommendations, ROSE is actually not mandatory. I'm quite privileged to have ROSE on my center, but again, I still need about 3, at minimum 3, but the suggested actually 4 needle passes on every enlarged lymph node. So this is a very nice and beautifully written paper from Hari. So Hari published this at Respirology Case Reports back in 2021. So this is a novel approach of transbronchial needle, transbronchial prior node biopsy. So as compared to the EBUS-TBNA, this is actually, we don't need any additional incisions. Again, you can just use the needle track that you created using the EBUS-TBNA 19 gauge needle or 21 gauge needle, and you can get larger specimen, you get better quality in terms of biopsy specimen, real-time ultrasound, and very minimal complications. So this is just an overview of other studies that actually talk about EBUS-TBNA and EBUS-TBCNB. The last publication is actually from our very own friends from Malaysia, Ian Su. So Ian published a paper less than a year ago about EBUS-TBCNB. So EBUS-TBCNB found was quite superior in terms of diagnosing rare malignancies and also benign conditions that actually probably missed while we sampling using the conventional EBUS-TBNA. Right, how about NGS? I mentioned earlier that one of the aim of us doing EBUS-TBNA, we want to get more adequate sample in terms of molecular testing so that the next genome sequencing for the patient specimen can be done. So if you look at the table here, the tumor cell area and tumor content, the p-value is very significant. So there's a significant difference between samples using TBCNB technique as compared to TBNA, right? So what does it mean? So higher tumor cells concentration means more reliable for genetic analysis. Again, EBUS-TBNA sample, sometimes we get more blood contamination. I will show you in the next few slides. And then most of the sample are crushed. But again, do we need that? Take into our consideration? I will show you after this. So again, we can still use the 21 gauge needle, which I'm sure everyone have 21 gauge needle here. In Indonesia, we don't have the 19-gauge needle yet. But if you want to compare the optimal needle sizes, on the left is actually the conventional needle size, which is 21 and 22 gauge needle, and on the right one is a 19 gauge needle. So again, there's no significant difference in terms of diagnostic yield, specimen adequacy. But again, if you use the 21 gauge needle, yes, we need fewer passes using 21 gauge needle as compared to 22 gauge needle. And also for benign disease, because larger needle, then we can get better specimen, especially for benign. So 21 is much more superior as compared to 22 gauge needle. And also for 19 gauge needle, there's only one study that showed improved diagnostic yield in 19 gauge needle, while another study actually showed no difference. And I just want to move on with my own research. So this is my research together with Konstantina Kontogiani, back when we were still doing our PhD. So this is, if I'm not mistaken, one of the largest EBUS-TBNA research, especially on the size of the needle, which we compare the 19 gauge needle and 21 gauge needle. So if you can see here, we actually use both 19 gauge needle, sample on the same station, and do the histopathology examination. There's no significant difference in terms of Mayer score, diagnostic yield, or even complications rate. But again, to use 19 gauge needle, especially for patients with lymphoma, it will give you much more cells. The cells is much more complete, and it's not crusted as compared to the 21 gauge needle. So again, the conclusion from our study shows that the flex 19 gauge EBUS-TBNA needle was actually safely used in this study. There's no significant difference in terms of diagnostic yields, but the efficacy is actually quite similar, as I mentioned earlier. Again, talking about the needle passes and freezing time for transbronchial needle cryobiopsy. So optimal specimen size, we can reach about 4 to 6 millimeters. We need about 4 passes, 2 to 3, about 85%. 4 passes did not significantly improve. So if you want to do more than 3, it will not significantly improve the diagnostic yield while you perform TBC and LB. And then the freezing time is about 4 seconds. So again, this is a very beautiful image from Dr. Ko. So how about the safety profile? There's no significant difference if we want to compare with EBUS-TBNA, to be honest. Again, from this publication back in 2017, EBUS-TBNA is actually quite a safe procedure and is widely used everywhere to diagnose patients with lung cancer. How about the TBCNB and TBNA? Complications rate, there's no significant difference, probably a bit more higher in terms of the bleeding risk if we use cryo as compared to TBNA. But again, it's very much controlled. And then about the bleeding for the safety profile for the TBCNB is about 4.9%. And also for the pneumothoraces, again, the rate after TBCNB is about 9.5%, and it's still manageable, it's still acceptable. So I think I almost reached to the end of my presentation. So this is the summary of the 2 hours of my talk, right? So I summarized to this table, right? So if you want to have a snapshot, go ahead. So let's move. Okay, so let's move on. So again, I'm just going to leave you with no conclusion, but I'm going to give you a statement saying that, well, I guess when you can aspirate the truth. So EBUS-TBNA takes the mystery out of lung cancer staging, definitely yes, giving us a real-time, high-definition insights with minimal invasion. Your precision, efficiency is important. Your needle's touch, because lung cancer diagnosis deserve nothing less. Thank you very much.
Thank you, sir. Having now discussed between the EBUS-TBNA and the cryonodal, we will now proceed for a recorded demonstration of the mediastinal cryobiopsy.
microphone just to talk over. Okay. So Harry asked me to show a demonstration of the mediastinal cryobiopsy. I wanted to make it a little bit interesting and found one of our older videos of how we used to do, or how we do the transesophageal cryobiopsy. So it's a really short video to catch you guys on the time. So this is how it starts. The first part is we insert the EBUS scope in the esophagus, and we start using the sonographic orientation. The aorta is the key to know where you are at, the aorta and the liver. So the first thing you have to do is know where you're at, because you don't want to upstage a lymph node or upstage a tumor. In this case, it was a patient with a PET positive lymph node station 8. And the difference between the transbronchial and transesophageal cryobiopsy is you don't have that much vision. So that's why I like to go deep into the stomach fold so that I can see the needle. And what you would do is basically the normal steps. You take the first transesophageal biopsy to get the TBNA or to get the sample. Usually with the endobronchial method, you can just do one puncture, that's more than enough. With the esophagus, it's a little bit different. You always need a second biopsy to create the way. So now we're doing the so-called arisa polaris method to make the biopsy channel. So I've already given the sample off to the nurse. And if you can see towards the right of to left of the screen, we're doing it under sonographic guidance, macroscopic image. We don't rely on seeing the hole that the needle made in order to get the cryo. But looking at the sonographic image, we see exactly where we made the puncture with the needle. And that's the key aspect from this arisa polaris method. And under sonographic guidance, we slowly insert the cryo probe. It's going to be in about 10 seconds. There we go. Into the lymph node. It's important to always have the cryo probe at a little bit distal to where the end of the lymph node is so that you don't freeze through. We activate for about 4 seconds and we take the biopsy. Usually 2 biopsies are more than enough when you're doing cryo, but you can take more than 2 in order to get more material for NGS. It was a patient with adenocarcinoma in the end, and the biopsy was viable for molecular testing. So you can switch to my presentation. Perfect. So my name is Samuel Nyancha. I'm from Germany. And the plan was to have a discussion on how to do mediastinal cryobiopsy. Harry is going to talk about the high-frequency needle knife. I'm just going to talk about the normal needle and why I favor that. Before I start, some conflicts of interest. There's a bunch of names over there. If you're not on the list, you can contact me later so that we can come a conflict of interest. I'm not really going to talk too much about the history of mediastinal cryobiopsy because we had different talks the entire day. Jürgen Hetzel had a really good talk showing the different papers, showing how the diagnostic yield is. Eric just talked about it, but just to sum it up and why we do it, we do it because we have larger samples, we have preserved tissue architecture, and of course we have accurate results. Several papers have been published, the largest one being from the Asian-German group from Heidelberg, which has shown that it's a relatively safe technique with a high diagnostic yield. One new paper, Daniela, you were part of it, is a multi-center European center paper that we got accepted 2 days ago on the topic of lymphoproliferative diseases, where we've seen a high diagnostic yield in lymphoma when doing mediastinal cryobiopsy. So when we're talking about the challenges that you'd have with mediastinal cryobiopsy, you have to think about 3 things: the cost effectiveness, the learning curve, and the reproducibility or the feasibility. So how much will the procedure cost me? How easy is it to learn? And how can I easily repeat it, and how safe is it? So we've seen different talks, we've heard different things, and mainly the 2 major needles being used are the 22 gauge crown tip needle and the 19 gauge needle. And I know that's one of the arguments that I get why people say we can't do it with the needle because these needles are expensive. But to be honest, using the needle is the cheaper version, because when you use the needle, you only have lower equipment cost. You only need the eboscope, which you need either way. You need the disposable cryoprobe, and of course the TBNA, which is pretty much standard. With the cautery method, you need a generator, and of course you need the high-frequency needle knives, which are not available in Europe as we speak. So to go into this argument about needles being expensive, I took a little bit of time and made a really small rundown on the needle prices that we have, especially in Germany. So the standard F&A needles are about 100 to 130 euros, depending on where you buy it. The F&B needles, being the ones with the side port, with the shark tip or with the crown tip, go for about 140 to 180. When you're going to the larger bore needles, that's when the prices get a little bit higher. So you can, in my hospital, we have very advanced equipment. I know we've heard talks about robotics, but what I use, it's called a hands-free voice-activated bronchoscopy. It's very new, it's reusable, but basically that's just me standing next to my fellow barking orders while she's doing bronchoscopy. So this is my hands-free bronchoscopy. So this is one of our fellows who is training in pulmonology. She has about experience of 30 EBUS interventions with me, not doing them herself. But here she's learning doing how she can do the rigid bronchoscopy, and she's doing now the EBUS with the Arisa Polaris method. Unfortunately, you can't see the time, but it's the similar situation to me, in that after doing the biopsy, in about a minute or even less, she will be able to get the cryoprobe into the lymph node. And we're talking about someone who hasn't seen or hasn't performed 50 EBUS interventions on her own. So I'm going to highlight this again. We're not using the set in about a minute of work, and for a beginner. So we secure the cryoprobe as we always do. We like to leave the top open and hold the bronchoscope at the bottom so that we have a control when we're pulling out the probe. And as you can see, she has a very good sample. So the method is also advantageous in that you can teach it to even junior doctors. So when we're talking about the feasibility and reproducibility, the safety profile is very good. When you look at the literature out there, the only cases of complications were pneumothorax, were the cases with the high-frequency needle knife. We only have one major case of bleeding when using the needle. But this case, I think it's more about where the colleague froze and not the needle itself. I already showed you the transesophageal cryobiopsy. We wrote a paper last year about it with our first 30 cases. The follow-up paper with 80 cases is coming out this year. So there's been a lot of data there showing that just using the needle is safe compared to using the high-frequency needle knife. And to demonstrate this, I'm going to talk about a patient that I had last week. It was a patient who was referred to us for EBUS, a patient with bilateral pleural effusion, mediastinal lymphadenopathy. She had necrotic lymph nodes, so we were planning to do an EBUS cryobiopsy. Unfortunately, the patient crashed out before we could start with the EBUS, or before we could get her into the endoscopy room. She ended up getting intubated, and this is our ICU. So that's why you see intensive station. So seeing as the patient is intubated with an FeO2 from 80%, we still had to make the decision, is this a patient who we want to keep on the ICU? Are we going to do a tracheotomy? Are we going to go through the whole process of ICU medication? Or are we going to do an EBUS? So this is me with my nurse rolling up into the ICU station. As you can see, we have different medical applications. She's intubated, and this is me just doing the EBUS. And like I said, we don't have to bring a lot of equipment with us. All we need is a needle, a little bit of patience, and of course, an EBUS system. So again, notice the time. It says 5:15, but it was 3:15. So this is basically how we do it. We create the tract with the needle. You can see some ultrasound traces of the tract here, the black line. And then I'm going to hand out the needle, and then we're going to perform 3 cryobiopsies. We're able to do 3 cryobiopsies in about 2 minutes, and it ended up confirming the diagnosis of small cell lung cancer, which was for us important because we could end up deciding how we can treat the patient in the end. We didn't want to prolong the ICU station, so we started to do a palliation. In this case, it would be difficult for me to use cautery system because the patient had a high FeO2. So with a high FeO2, I would not be able to use a cautery system, but with the normal EBUS, or with the normal TBNA method, you can do it at any time. Just gonna skip. In our hospital, we don't have rows, we have, I call it nose, so it's nurse on-site evaluation. So I take a puncture and the nurse tells me it's a good biopsy or not, and that is the advantage of the needle method. I'm having a complementary system to the TBNA method, meaning I can choose to do the cryobiopsy or not. I do the TBNA, the nurse says that the sample is good enough, then I'll stop at that. When she says it's not good enough, I'll do the cryobiopsy. If I ended up using a cautery system, I have to do the cryobiopsy because the cautery knife does not give me a biopsy. So this is also a way that the needle-based method becomes an efficient tool because you don't have to always use cryobiopsy. You can decide whether or not to have it as a step up or leave it at that. And with that, I just want to summarize my talk. I'm in favor of the needle because it has a high safety profile, it's cost effective, and also has a very good learning curve. Thank you.
Thank you so much, sir. Are there any questions? Your video. So now we move on to the next demonstration of the cryonodal biopsy. I take immense pleasure in calling Dr. Hari Kishan sir onto the stage, and he will be demonstrating how his technique to do the same procedure does not involve the needle.
So thanks, Sammy, for that presentation. We thought we will have a debate in the beginning. So the point is like whether you use a needle or you use a knife, how you enter that matters really. The operator matters in this procedure, that's what I feel. Even if I'm very familiar using the knife, but sometimes I fail. We all discuss on the success, but I will share how we do our procedure of mediastinal lymph node cryobiopsy. So we started doing the biopsy procedure using the needle. We prefer 19G for the tract creation. And then we moved on to no needle technique. Like we stopped using EBUS TBNA needles in our hospital, and then we use the knife and then do all the sampling of the nodes. But here I will show the technique first, and then later we will discuss on what are the chances of failure when I'm using the knife also. Can you play the video? So we have this special knife. This is made in India. And there is a discussion point that to use an electrosurgical knife, you need a lot of training, and it's an advanced procedure. But doing a mediastinal lymph node cryobiopsy means already you are doing a lot of EBUS procedures. So you're already having some equipment in your hospital. So our procedure is like we just use the ultrasound image and then put the knife in there. And then see the knife entering the lymph node, and then make an incision, and then do the cutting. And the negative side of this technique, that also we will discuss now. So the moment you use electrosurgical knife technique, now you see there is a white dot formation that happens, which may not happen when you use the needle technique. So this is one thing that happens when you don't use the needle. But here now you see I push my sheath of the needle, the knife, and then expand the tract. So sometimes I also think that Sammy also might have some cases where there are failures, like even you use a needle, still you can't pass the cryoprobe. So 155 cases of our experience using no needle, using the knife tract creation. We have 4 cases where when we tried to use the knife as the first mode, we failed entering the lymph node, even with the knife, when you do the cutting. Then we had to use some needles and then to make the tract creation. There are 2 patients where even when we combined both the procedures, we were not able to enter the lymph node. So that depends on the texture of the material of the lymph node. So this happens, and we don't have any papers discussing these complications in the literature, like where you fail to enter inside the lymph node. And then we just see the lymph node, and then so the point is not regarding the cost of the procedure, the time you save when you do this procedure using the knife, because it saves a lot of cost, not only the direct cost, but when you imagine you have a direct tissue coming out without using anything else. Needle, again, you have to make slides, and then the recurrent cost of using the rows and all these things, again, that adds up to the cost. So that is why we prefer using this method where we just make a tract creation. We complete 155 cases now, and then we have 4 failures, as I mentioned, where we failed to create the tract. And then we can make an imprints of this and then send it for slide cytology. So these are my points. It's not a discussion like whether we can use a knife or a needle, but sometimes there are challenges even with both these techniques, like you may not be able to enter the lymph node even with this. So we have this % of patients whom we were not able to enter with the cryoprobe, even when we use the knife or the needle. So that's our technique of mediastinal lymph node cryobiopsy. Cost factors we don't discuss here because we don't have those needles what Sammy is using. We only have the 21G. Even our publication showed that even with this simple 21G, we are able to create the tract. Yes, and it's not a procedure that is meant for all patients. So selected patients. So these are my points favoring the knife technique. So even I was a big fan of needle initially, but later we moved on to the knife, considering the ease of the procedure. So it makes us very easy to complete the cryobiopsy procedure when you do using the knife. Sam, you have any comments? There are arguments that we are using equipment that are not mentioned for pulmonology use, especially these knives, but in India we have easily available knives. It's not the GI knives, these are pulmonary knives what we have.
I think you said it well. It's use what's available to you and make sure that you do it safely. The discussion, or I mentioned it in the paper, in the talk, there's a paper about hematomediastinum, but if you look at the picture in the paper, the cryoprobe was at the end of the lymph node. So it's not really the method that you use, but rather what you use. And what I liked about your talk is you had the Doppler the entire time. Because that's an important part. The Doppler test before the cryobiopsy is always important. How you get in is, right now, not important, but that you get in. I think that's the most important thing.
Thank you.
Thank you so much, sir. That was a wonderful discussion, and I'm sure we have a lot to learn with the newer techniques that are coming up, which are going to give us greater diagnostic yields and make procedures easier, less time consuming, and more cost effective. We now move on to the next session. May I introduce Dr. Ronald Ferrado for the lecture on talc fluoridesis for MPEF.
Good afternoon, everyone. I'm Dr. Ronald Fajardo, and I'm from Manila, Philippines. And first of all, I'd like to thank the organizing committee of BRONCHUS 2025, of course, for giving me an opportunity to talk about this topic. And I'd like to congratulate in advance Dr. Harry here and his team, of course, for organizing a very big IP conference. So it's just getting bigger every year and for every year that that passes. So let's give a big hand to Dr. Harry here. Thank you. So this is my CV, and just like to disclose that I'm currently, of course, the lung mass clinic head of our hospital, and these are the hospitals wherein I rotate to. So I have nothing to disclose. Just to give a brief outline of my discussion, so I'd be discussing the management of malignant pleural effusion with the use of talc fluoridesis, and likewise I'm going to compare talc fluoridesis with indwelling catheter. just before we go to the nitty-gritty details of our discussion, I'll just give a brief history of talc pudraj. So this was initially done by Dr. Noel Bethune almost a century ago, and he introduced the use of talc pudraj after doing a lobectomy or a surgery. And then the first documented use of talc for the treatment of malignant pleural effusion was done last 1958. This is a timeline of the important studies that were done in the use of talc pleurodesis as well as indwelling pleural catheter. Right? So these are major studies that were done for the past 10 years, past decade. And we can see here that there is really a great discussion or even a debate on the advantages as well as disadvantages of using talc as compared with indwelling pleural catheter. So before we go to the discussion of the different studies, let's go back to the basics. So let's again just a brief review of the mechanism of action on the use of talc as a pleurodesis agent. Okay, so it creates an inflammatory response, of course, to encourage the symphysis of the parietal and visceral pleura, and this eliminates the potential space caused or created by the effusion. And animal models have demonstrated that talc creates, of course, inflammation, edema, cellular proliferation, and even dose-dependent fibrosis. It likewise have a local, not just a local, but it also has some systemic side effects. Human models likewise have shown that there is a serum and pleural fluid level increase in leukocytes, neutrophils, macrophages, lactate dehydrogenase, and even CRP. So these are, pro-inflammatory reactants, and levels indicate that talc induces a significant increase. So because of this pro-inflammatory reaction, the most common side effect of using talc is chest pain and fever. And there is, because of the systemic side effect, there is a lower incidence of systemic inflammatory response syndrome, or even rare cases of acute respiratory distress syndrome, or ARDS. And there is also even a discussion on the possibility of it causing some gynecologic malignant diseases. So why are we using talc for pleurodesis? So we have here a Cochrane review of 36 RCTs showing a significant number of participants. And it showed there that it is the most efficacious chemical that is used for pleurodesis, and it is the least likely to result in recurrence of pleural effusion. And in most centers or most institutions, it is likewise also the most affordable. We have here a table showing the efficacy of using different chemicals in achieving sclerosis or even pleurodesis. And it was shown here that talc has a risk ratio of only 0.99 as a means of having the need for reintervention in the use of or the recurrence of pleural effusion as compared with mitoxantrone or tetracycline. In the lower part of the table, we can see here that we also have the risk ratio in the comparison of mitoxantrone and tetracycline as a means of mortality or adverse effects in the use of talc, and we can see that it is less than 1 or at 0.53, meaning that it is relatively safe. So another table here is a forest plot shows that talc is relatively also effective in achieving pleurodesis, or in the rate of having a recurrent in the use of reintervention in the use of possible recurrence of the pleural effusion. And you can see here that the risk ratio is at 0.99 as compared with metoxantrone and tetracycline, which is more than 1. Further forest plots here shows a 1:1 comparison of talc with other chemicals in the use of fluorideses such as bleomycin and other chemicals, and we can see here that the talc performs better in terms of achieving fluorideses or as being as a sclerosing agent. Here is another forest plot showing the adverse effects or the mortality of patients undergoing talc fluorideses, and it can be seen that the risk ratio is significantly lower at 0.53 as compared with metoxantrone and tetracycline and other chemicals. So we can see here that talc is significantly safe as compared with the other chemicals. So how does talc powder, which brings us to the next clinical question, so how does talc powder migrate systematically? So it might be because of lymphatic absorption and because of the inflammation that was caused by the instillation of this chemical. There would be changes in the alveolar capillary membrane causing an increase in permeability, and afterwards it is systemically absorbed and distributed in the body. Which brings us to the next question. Does size matter? Well, there are studies that are comparing the size of talc. So this study showed that they tried comparing one with a smaller and one with a bigger size, and they found out that small particles of talc leads to a more robust systemic inflammatory response, and that the smaller particle also causes deposits in the periphery or in the other organs such as the liver and kidneys. We have here another RCT or randomized trial, again comparing the different sizes of talc, and it was found in this study that the smaller the talc particles, it showed worse alveolar arterial or AA gradient. There was likewise a reduction of the partial pressure of oxygen in the alveoli or the PaO2, and there are more incidences of fever and increased serum C-reactive protein. And there is another prospective cohort study wherein they only used large particle talc with a measurement of more than 24.5 micrometer, and they had 0 incidence of ARDS or adverse effect. Another clinical question is, does dose matter? So there is this animal model studies wherein they compared, again, the smaller and the bigger particles in talc, and they also compared the dose, and they found out that that the smaller size of talc showed a dose-dependent deposition in the other organs as compared with the larger particle talc, which didn't have or less in the deposition in the peripheral organs. So it is recommended actually in the British Thoracic Society Pleural Disease Guidelines. It was mentioned in the 2010, and it was likewise also mentioned in the 2018 ATS guidelines that they are recommending that the amount of 4 to 5 grams of talc fluorideses be used for the management of malignant pleural effusion. However, there was no mention as to the size of the talc. However, this is my personal opinion based on the review of the studies that were presented, shows that we can use a graded talc with at least greater than 31 micrometers as to prevent those adverse reactions. So knowing this and doing all those recommendations, talc is still relatively effective and very safe if it is done in the, or if you get the right amount, or you use the right talc product. So I'm showing you here another study comparing talc pudraj and talc slurry fluorideses, and this study actually showed that there is no significant difference between the two, and that there is, the quality of life comparison is not significant, and as well as even the length of hospital stay, it is also not significant. However, when they compared for the need for reintervention or the pleurodesis rates, the forest plot showed a slightly increase in the need for reintervention in the case of talc slurry as compared with talc pudraj. But statistically, this was not significant. Now, I'm just going to give a short, face-to-face comparison between pleurodesis rates, comparing talc pleurodesis as compared with indwelling pleural catheter. And we have here a meta-analysis of 2 studies, and it showed that in comparison with regards to the risk ratio, we have a forest plot that in cases of events or the need for reintervention, there's an increase in the talc pleurodesis as compared with the indwelling pleural catheter. And for further pleural intervention, it favors the IPC. Another study here is the NVALT 14, wherein there's a significant number of population wherein they compared the IPC and the talc pleurodesis, and it showed that there is less need for reintervention for the talc pleurodesis arm as compared with the indwelling pleural catheter arm in the first 4 months after the intervention. However, after the 4th month, there's already no significant difference between the two. So integrating everything, talc pleurodesis is actually an effective and cost-efficient method in the management of malignant pleural effusion. But still, of course, the decision between or choosing between the two would depend primarily on patient preference. And secondarily would be the availability of physicians with the expertise of doing it, the availability of equipment, as well as the talc substrate. Thank you very much for listening.
Thank you so much, sir. If there are no questions from the audience, we move ahead with the next session. That is the IPC in the MPEF by Dr. Rakesh Panchal.
Good afternoon, everyone. I'd like to thank Dr. Hari Kishan and the Yashoda group for the kind invitation. It's absolutely wonderful to be back in Hyderabad again. So in the next 15-20 minutes, I'm going to give you an update on indwelling pleural catheters in pleural effusion. Dr. Fajada has already set the scene quite nicely for me, and there may be a little bit of repetition to start with. So I've got no disclosures or conflicts of interest. So I'm going to talk a little bit about the issues influencing malignant pleural effusion management, optimizing pleurodesis, and then indwelling pleural catheters. So the burden of pleural diseases is rising across the world. We know it's got an abysmal survival. We're doing a lot more radiology, so we're identifying pleural effusions early. People are living longer, and obviously lung cancer screening is on the horizon, so we're going to be seeing more pleural disease. There's been a plethora of studies, as you can see, over the last 10 years on pleural diseases, which is really interesting and has set the scene. I'm going to talk a little bit about these today. So what's the ideal treatment for a malignant pleural effusion? You want to improve breathlessness, quality of life, be minimally invasive, and reduce the length of time in hospital. And the only options we've got are to drain the fluid and seal the pleural cavity. And Dr. Fajada has just mentioned that pleurodesis. So we want to identify who's going to benefit from drainage, who's going to get fluid reoccurrence, who has got a non-expandable or trapped lung, who will benefit from an indwelling pleural catheter versus talc pleurodesis via chest drain, minimize days in hospital, and ensure what's best value for money, because the health economy, depending on where you practice, is important. So there are a number of guidelines now in management of malignant pleural effusion, and the British Thoracic Society guidelines were updated 2 years ago. The ATS recommends an IPC first line if a patient has a re-expandable lung versus chest drain or talc. And certainly if they've got a trapped lung, then you should go for an indwelling pleural catheter first. And the BTS guidelines are the same. If the patient has a trapped lung, go for an IPC or do a therapeutic aspiration. But if they have an expandable lung, you can do talc pleurodesis via a chest drain or offer them an IPC. It's about patient choice. So pleurodesis requires tight apposition between the viscera and parietal pleura, and it leads to inflammation and decrease in pleural fibrinolytic activity. So what's the best definitive treatment for a malignant pleural effusion? Well, you've got chemical pleurodesis, talc pleurodesis, surgery, and indwelling pleural catheters. And Dr. Fajardo has already spoken about the first couple of these. So chemical pleurodesis, we know from this Cochrane review that talc remains the most effective pleurodesis agent. And on this nodal plot, you can see there's been more studies. So the larger the blue circle, the more studies which show evidence for that particular product. So you can see that talc has the most evidence for success. How about what are the determinants of pleurodesis success? So I don't know if some of you, when I was a junior, they used to say, don't give patients non-steroidal anti-inflammatories because it'll reduce the efficacy of pleurodesis. And chest drain size. We use a lot of pigtail or Seldinger chest drains, and are they equally effective at giving talc? So the Time 1 trial was a 2x2 randomized study, randomizing patients to either a 24 French or a 12 French drain, and they were given either non-steroidal anti-inflammatories or opioids. And they looked at their pain scores and pleurodesis success rate at a month and 3 months. They found out that there was no difference with NSAIDs or an opioid, and that perhaps the larger drain was more painful, but perhaps maybe potentially a little bit more effective in pleurodesis. So if you're going to do pleurodesis, you can give NSAIDs. There's no reason not to give them. I know in many parts of the world iodine is used and the exact mode of action is not clear. And there is a theoretical risk of iodine toxicity, but on some small-scale studies, the efficacy is quite good, but obviously these are small studies which are prone to publication bias. So again, Dr. Fajardo mentioned this. Should we do talc poudrage via thoracoscopy or talc slurry? So there's been 2 studies now, the Dressler paper from 2005 and the TAP study in JAMA, which show that if you have a malignant pleural effusion, whether you do thoracoscopic talc poudrage or talc slurry via a chest drain, there's no real difference. So the recommendations are you can use talc slurry or talc poudrage. I personally would say that if you're going to do a thoracoscopy in an undiagnosed pleural effusion where you think malignancy is likely, do your thoracoscopy, get the diagnosis, get the biopsy, and give talc at that time. If a patient already is known to have a malignant pleural effusion, and they need it draining and pleurodesing, I would probably just put a chest drain in and give them talc. I wouldn't do a thoracoscopic talc poudrage where the diagnosis is already known. How about surgery? So we've got VATS, talc poudrage, pleurectomy, or pleural ablation. So the MESO-VAT study was a randomized controlled trial looking at partial pleurectomy versus talc pleurodesis in mesothelioma patients, and they found out that there was no difference. So surgical pleurectomy as a pleurodesis for malignant pleural effusion is probably not warranted. There's higher risk of complications, higher risk of hospital stay, and air leak. And the AMPLE-3 trial, which is led by Gary Lee, which is a Southeast Asian Australasian study, I think has just closed, and they are looking at indwelling pleural catheter and talc versus VATS surgery as a for pleurodesis. So it'll be interesting to see what those results show. So is an indwelling pleural catheter better than talc slurry pleurodesis? Dr. Fajardo alluded to this just recently. So indwelling pleural catheters have been available in India since 2016, and they've been around for over 25 years. They're silicon-based tunneled catheters with a profibrotic cuff and a one-way valve, which allows vacuum-based fluid to be collected. There are obviously pros and cons. It can be done as a day case procedure. It doesn't require a hospital stay. It empowers the patient. They're in charge of draining their fluid at home, and it avoids repeated procedures. But obviously there are complications. You can, about having maintaining an unrestricted lifestyle. There's the aesthetic appearance of it. Not everybody wants a piece of plastic in their chest. And naturally there is a cost, not just of the catheter, but the ongoing drainage. So how about using indwelling pleural catheters as first-line management of a malignant pleural effusion? So there's been two studies, the TIME-2 trial and the AMPLE trial. The TIME-2 was a British study published in JAMA, and the AMPLE was done by Gary Lee's group. And they both randomized patients to either talc slurry via a chest drain or an indwelling pleural catheter first line. And obviously, IPCs was associated with a reduced length of stay, but there's no significant difference in breathlessness or complications. How about in non-expandable or trapped lung? So if the X-ray shows less than 25%, well, if there's greater than 25% of the lung is not opposed, you may suspect someone has a trapped lung. So an IPC is certainly the first treatment you should give in a suspected trapped lung. But it's difficult to tell if someone has a trapped lung. You can see in this X-ray on the right that we put a chest drain in this patient, and you can see the lung did not re-expand. We had no option but to take the drain out and put an IPC in. So you might have told that there are some clues in this X-ray. There's no mediastinal shift. The fluid is tracking all the way apically, so you might think this patient has a trapped lung. But we're quite poor at predicting it. The jury is out on pleural manometry. There are people who are proponents of it and those who support it, but it's still not widely practiced. When you put a chest drain in a patient, in a lung which re-expands, the pressure drops very gradually, as you can see on this green line, as opposed to when you have a trapped lung with a large negative pressure where the pressure drops much more rapidly. And this was evaluated in the pre-edit study where they had this manometer which was attached to this aspiration catheter, and they looked at the pleural elastance. If the pleural elastance drop was more than about 15 centimeters of water, patient probably had a trapped lung, but if it was less than 15 centimeters of water, they probably had an expandable lung, and they gave them drain and talc pleurodesis, as you can see here. How about ultrasound? Does that help us predict who may have a trapped lung? So you can see in the middle there is B mode ultrasound, which we use in the majority, and M mode. So if the patient has a reversed hockey stick sign to their lung, they may have a trapped lung. And when you put M mode ultrasound on, you can see normally in a normal lung, the cardiac impulse is transmitted through the lung, giving this sinusoidal sign, which is lost in a trapped lung. Similarly, on B mode, if you see a fishtail sign to the lung, then the lung may re-expand. So if we put an indwelling pleural catheter in a patient with a malignant pleural effusion, if we give talc via the IPC, will it lead to successful pleurodesis? So this was a landmark paper in the New England Journal done by Rahul Bhatnagar's group. So they had patients with a malignant pleural effusion. They drained them on alternate days for 10 days, and then they randomized them, if there was no trapped lung, to saline or sterile talc and followed them up. And they found out that if you gave talc via the IPC following a period of aggressive drainage, you could increase the successful pleurodesis rate twofold. Next question. So again, is IPC better than talc slurry? So if we look at the TAP study, where they gave talc slurry versus talc poudrage, and then IPC via talc, you can see on the right, sorry, I think my slides are not keeping up. Apologies. In the IPC and talc group, at about 7 weeks, the pleurodesis success rate was 55%. Whereas if you gave talc slurry, the pleurodesis success rate at about 7 to 8 weeks was about 80%. So perhaps there is some evidence to say that talc slurry pleurodesis via a drain may still be the best option overall. So I know we've got IPCs out there, we can give talc via the IPC, and people think chest drain and talc slurry, which is the traditional way of doing pleurodesis, is out. It's not the case. There are a number of IPC guidelines out now from the chest group, AABIP as well. So in summary, IPCs, they can be used as first-line therapy and in patients with a recurrent pleural effusion, so I think you need to give the option to patients. You can certainly use them in trapped lung, and you can use manometry and M-mode ultrasound and B-mode ultrasound to predict if someone has a trapped lung. If you give talc via an IPC, you will increase your pleurodesis rate, success rate twofold. You can use an IPC post-thoracoscopy, so you can do a thoracoscopy, put an IPC and give talc and get the patient out. It's a one-stop shop. There's no need for any repeated procedures. I'm afraid drug-eluting IPCs are out. We are not catching up with our cardiology colleagues anytime soon. So this was a study, the SWIFT study looked at silver nitrate impregnated IPCs, and whether silver nitrate is a successful pleurodesis agent, but this study looking at normal IPC versus silver nitrate impregnated IPCs was negative. You can use IPCs in non-malignant effusions as well. And this is really exciting. IPC gives you a conduit or an access to the pleural cavity, particularly in mesothelioma. And we've been involved in a phase 1 study in the UK in our center, looking at an agent which we can give intrapleurally for mesothelioma. And an IPC doesn't mean indwelling pleural catheter, but indwelling peritoneal catheter as well. As I said, combined approaches. Chuck Reddy's group in the US looked at thoracoscopic talc poudrage, so thoracoscopy, biopsy, talc poudrage, and IPC. Excuse me. And this was evaluated in the TACTIC trial, which was presented at the Winter BTS in London just in December. So in this study, patients were randomized to thoracoscopy, talc, and IPC versus just thoracoscopy and talc. It's across 11 sites. We participated in this. And it was a study where there was no difference in length of stay, breathlessness scores, or chest pain. And they found that if you are performing a thoracoscopy and you're going to put an IPC in, perhaps it's worth giving talc as well. So in summary, sterile talc remains the most effective pleurodesis agent. Talc slurry via a chest drain is still efficient. Maybe a large bore drain might be helpful. You can give NSAIDs. There's no difference in talc pleurodesis success rate, whether you give it thoracoscopically or via a chest drain. Ultrasound can be a predictor of pleurodesis success. IPCs can be given first line, and you can administer talc via the IPC. You should certainly use it for trapped lung. And if you're doing a rapid pleurodesis protocol, perhaps there's no difference in putting an IPC in a thoracoscopy and talc versus doing it alone. But if you are going to put an IPC in a thoracoscopy, give talc. Thank you.
Thank you, sir. If there are any questions, we'll be happy to take them at this time. Thank you, sir. Now we move on from the pleura to the tracheal stenosis. May I call upon on stage Dr. Efsun, who will be giving a talk on benign tracheal stenosis and bronchoscopy as a first line of management.
Good afternoon, dear colleagues. First of all, I would like to thank the organizing committee for their kind invitation. It's both a privilege and an honor to be among you today. Secondly, I want to thank all of you staying till this time of the day. Let me begin with defining what a benign tracheal stenosis is. It's mostly described as the obstruction of the tracheal lumen due to benign causes, over 50%. When we have a look at the etiology, mechanical causes such as iatrogenic traumas, functional disorders, external compressions of neighboring organs, infections, some autoimmune diseases, and benign tumors can lead to benign tracheal stenosis. If no etiology is identified, then it's named as idiopathic, and the most common cause is, as you all know, post-intubation tracheal stenosis. If we come to the question, who will manage the benign tracheal stenosis, is this the job of an interventional pulmonologist, a thoracic surgeon, or others? It is still an enigma. But one paradigm is the common aim is always reducing, trying to reduce the mortality and morbidity and provide a normal functioning airway as a multidisciplinary team. No matter who will manage the patient, the first step is to determine whether the case is emergent or non-emergent. In the event of an emergent case, you will most likely perform a rigid bronchoscopy. But if it is a non-emergent case, then you can perform a flexible or rigid bronchoscopy depending on your choice. At the same time, you must review the accompanying comorbidities very carefully, as well as etiology, severity, location, and type of the stenosis, suitability for the surgery, and resources available at your center. Bronchoscopic treatment modalities help maintaining airway patency. Over 50% results in symptom relief, functional recovery, infection control, and buy time for surgery. And these procedures assist in increasing a patient's quality of life and survival. As everything starts with seeing, diagnosis starts with imaging. While chest X-rays have limited limited role in the diagnosis, computerized tomography provides information about the stenosis, shows neighboring structures, and helps the physician plan the treatment with its 2D and 3D options. Bronchoscopic procedures play the leading role in the diagnosis with their ability to provide direct observation of the vocal cords, airway mucosa, characteristics of the stenosis, and treatment results. Same as the chest X-rays, pulmonary function tests have a limited role in diagnosis, but they are sometimes very helpful, especially in patients whose clinical course and past history of symptoms are not followed very well. There are 3 current types of bronchoscopic treatment modalities used for the management of benign tracheal stenosis, including the mechanical methods of dilatation, resection, and airway stenting, and also the thermal methods of cryo and ablation, and some applications submucosal or topical way. With the mechanical methods, rigid tube itself, balloons, bougies, incision scissors, drills, and airway stands of different shapes, different lengths, and different materials can be used. Mechanical dilatation requires you to be very careful while pushing the rigid tube forward in circular movements, but very gentle at the same time. Airway stents have an important place among all these treatments, but as a last resort. They help to palliate and cure the inoperable patients, and they can be used as a bridge therapy for selected patients awaiting surgery. Cryo methods include cryotherapy and cryoextraction, while ablative methods include laser, electrocautery, and argon plasma coagulation. For benign tracheal stenosis, cryo ranks first among all these thermal methods. It's freezing methods which helps to remove the tissue with its fast adhesive effect, and sometimes it results in coagulation necrosis with its delayed onset of action. I'm not going to stay too long on ablative methods since they can be potential scar-causing effect since they are this effect. But it is for post-intubation tracheal stenosis, but they have a priority for benign tracheal tumors. If we have a look at them in terms of advantages and disadvantages, to use a laser, the physician must be highly skilled and experienced because of its high cost and high risk of giving damage to deeper tissue levels. And the advantages of electrocautery are its low cost and being able to cut the tissue without the risk of hemorrhage. And for argon plasma coagulation, it's low cost and it's less damage to tissues. And submucosal or topical applications of mitomycin C or corticosteroids are mainly used for maintaining airway patency as a complementary method. Of course, these complications are accompanied, these procedures are accompanied by some low-rate complications. The early complications are hemorrhage, endobronchial burns, tracheal perforation, respiratory insufficiency, and late complications are recurrence, asphyxia, tracheoesophageal fistula, and stent-related complications. Secretion retention, granulation tissue formation, and migration are the most common complications of airway stents. Now, I would like to share some cases with you from my clinic. My first case is a 60-year-old female who was investigated for dyspnea and referred to us from an eastern part of Turkey for a rigid bronchoscopy. She had a history of ICU admission for COVID-19, and also she had ischemic heart disease, chronic renal failure, and mitral valve replacement surgery. Here on the thorax CT, you can observe that trachea narrows and then returns to its normal size in the progressive CT sections. This is her first rigid bronchoscopy. The tracheal stenosis was 2 centimeters approximately from the vocal cords and had a length of 2 centimeters, but was considered as inoperable due to her comorbidities and bad general condition. After that dilation, she presented again with the same symptom 1 month later, and this time she had a recurrent in her both thorax CT and the rigid bronchoscopy. This time it was worse, as you see. After dilating the stenotic segment, we saw that lots of secretion were standing behind. After repeated dilations with increasing sizes of rigid tubes, this time we inserted an airway stent, a silicone airway stent to her. And 18 months after that stent insertion, one day she came with us with a chronic cough. This is her thorax CT, which revealed migration of the stenosis. You know that the complications of airway stents are annoying situations for clinicians, but this time it was the sign of good news because the cause of stent migration was the improvement of the stenosis. Here you can see the migrated stent. We removed it, and stenosis was cured, and applied some cryotherapy to the newly developed granulation tissue and terminated the procedure. She is still under follow-up in the city where she lives. Now, I want to spend a few words and spend a little time on post-intubation tracheal stenosis since it's a life-threatening iatrogenic complication. It became more common in the recent years due to the increased number of intensive care beds, endotracheal intubation, and awareness of chest physicians. There are mainly 2 types of stenosis, web-like and complex type. In web-like stenosis, the cartilages are preserved and the affected tracheal segment is under 1 centimeter in length. But in complex stenosis, the cartilages are deformed, the malacia may be present, and the affected tracheal segment is longer than 1 centimeter. This is the suggested algorithm for post-intubation tracheal stenosis, which we follow in our clinic's daily practice. After assessing the patient in terms of emergency, the second step is to determine the type of the stenosis. If it is a web-like stenosis, we dissect and dilate the stenotic segment and then follow the patient. If the recurrence occurs more than 3 times, then we plan a stenting or refer the patient to the surgery. If it is a complex type stenosis, our thoracic surgeons participate our procedure as consultants. We dilate the stenotic segment and refer the patient to the thoracic surgery department. Or we plan a stent implantation. But in the recent years, although the type of the stenosis is complex, we give bronchoscopy a few chances and follow this path. My second case is a 68-year-old male who did not benefit from the prescribed bronchodilators. And this is his thorax CT scan, where you can easily see the soft tissue obstructing the tracheal lumen. During the rigid bronchoscopy, a pedunculated lesion originating from the left lateral wall was observed, and also secretion retention. After exploring the lesion with our catheter, it was cauterized by a snare, which is a spatial electrocautery, which helps the physician to cut the pedunculated lesions with a low risk of hemorrhage. And then it was removed by the cryoprobe, as you see. And the procedure was terminated by applying argon plasma coagulation and cryotherapy to the lesion's roots. And the pathology result was fibrolipoma. My third case is a female who had dyspnea, and a flexible bronchoscopy was planned for her frequent hospitalizations due to recurrent lower respiratory tract infections following a thorax CT. The thorax CT showed us tracheal wall irregularities obstructing the tracheal lumen. Here. And the bronchoscopy revealed multiple tough nodules in the tracheobronchial system that could not be sampled. A consultation from our interventional pulmonology team was requested during the flexible bronchoscopy, and this was a typical appearance of tracheobronchopathia osteochondroplastica, so we planned a rigid bronchoscopy. This is her first rigid bronchoscopy session. Here you can see multiple nodules originating from the tracheobronchial system, especially the trachea. In the session, most of our time spent coagulating these lesions and performing mild resections when possible. Here, I'm applying argon. And then the pathology result was reported as tracheobronchopathia osteochondroplastica, which is compatible with our bronchoscopic pre-diagnosis. And this is the second session, which is planned for the removal of necrotic softened lesions, which we have previously coagulated. And my last case is a young male with dyspnea and hoarseness, which was existing for 8 months and increased in the two last weeks. He was hospitalized in the level 2 ICU unit for positive pressure support. And And it was learned that he was started on corticosteroids for ear edema, erythema, and sensitivity 2 weeks ago. Here, at the beginning, nothing seems to be very unusual except for a limited tracheal stenotic segment and then malacia in the distal parts of the bronchial system. And this is his rigid bronchoscopy. Starting just below the vocal cords, throughout the entire trachea and bronchi, no cartilages were visible. And also a severe malacia was accompanying this appearance. After taking some biopsies from the trachea and making mild resections, a Y-stent was implanted, and by the help of this stent, he was able to breathe without the positive pressure support, and he was discharged from the ICU. This is a relapsing polychondritis case. Here you can see the saddle nose and the regressed auricular inflammation in the patient face. This is the thorax CT scan taken after the procedure. As a conclusion, and as an interventional pulmonologist, I can say that bronchoscopic treatment modalities for benign tracheal stenosis are minimal, semi-invasive, repeatable procedures with low complication rates, and they provide therapeutic and time-saving benefits for the patients. And this is my bronchology and interventional pulmonology clinic, which is the largest referral center in Turkey, in which over 7,000 bronchoscopies and 700 rigid bronchoscopies per year are performed. And in addition to those procedures, in our clinic, we host many colleagues from my own country and foreign countries, for educational purposes here. And these are some of my memories whom I had a chance to meet before. Stefano, Hervé, Venerino, Harry, Grigoris, and this is my never-changing squad. Thanks for your attention.
Thank you, ma'am. We move on to the last session. This is on aerosphere technology, and may I call upon Dr. Visveswaran to take the stage, please.
Good evening, everyone. So this is going to be a company-sponsored talk on one of the latest devices introduced by AstraZeneca. So it's all about aerosphere. So we'll try to keep it as crisp and short as possible. So we'll be covering all about the aerosphere technology under these headings. So first of all, what is the need for an effective drug delivery system? We all know that the drugs that we inhale should get deposited in both the large and the small airways. As you can see from the table here, you have various types of receptors, with the beta adrenoceptors or the muscarinic and the ICS. So everything has a particular way of getting deposited, and that's how these medicines act. So you need a device which is a composite which can effectively maintain the drug deposition at multiple levels depending upon the disease process that is being treated for. But however, if we see the drug delivery system, it also depends upon the size of the particle. So any particle which is more than 5 micrometer in diameter generally gets impacted in the oropharynx and do not reach the airways, whereas the particles which varies between 1 to 5 micrometer gets deposited in the airway, and that is what we refer to as the respirable range of the inhalational molecules. However, we do have something called as an extra fine particles which are less than 1 micrometer, which goes from the airways into the bloodstream and through your alveoli. However, the conventional pressure MDI devices have got a lung deposition of only 10 to 20% of the delivered dose. And as you can see from here, the diagram here, only 10 to 20% gets deposited, which makes many of these inhalers insufficient. And to overcome this, we come up with the spacers and the other devices. However, apart from the physical nature of the molecule, even your poor patient handling technique is a real-time issue when it comes to the PMDI devices. So these challenges are overcome with the help of the effective delivery system. One another problem when it comes to your conventional PMDI is that most of this drug particle gets agglomerated and sedimented, which makes the delivery of these drugs inefficient, especially when it comes to the airways. So there are both the patient-related factors as well as the formulation-related challenges, which makes the deposition of the drug irregular, especially when it comes to the treatment of asthma and COPD. So that is where the latest innovation by the AstraZeneca is with respect to the Aerosphere inhaler.
Aerosphere.
So when it comes to the Aerosphere inhaler, you got a drug crystal, which can be the triple drug combination which they are introducing, whereas a drug A, drug B, and drug C, which is then placed over a phospholipid porous particle, and it reaches an effective median airway diameter, which is almost like 3 micrometer, which forms under the respirable range. And this phospholipid is nothing but a nanostructure which has got a good colloidal capacity, and it has got an amphiphilic corrugated surface, which makes the drug crystal get adhered to this nanoparticle. And since it is of 3 micrometer in diameter, it can lead to effective airway deposition, and thereby leading to an increase in your symptom control in terms of using this device. So as you can see from here, the difference between the conventional PMDI as well as the Aerosphere technology is that even at a resting state, the sedimentation and the agglomeration is much lesser when an Aerosphere-based technology is used in comparison to the conventional PMDI. So people have tried to understand the deposition of the particles inside the airway using certain advanced techniques. So, and another important aspect when it comes to the deposition of the drug is that it also depends upon the dosage of the drug that is being administered, the different inspiratory flow rates, which becomes very crucial, especially when you're dealing in cases of advanced forms of asthma and COPD, and what is the combination of the drug that is being used also plays an important role in ensuring a deposition of the drug. So this is one of the studies which is presented by the AstraZeneca in the ATS May 2023 edition to assess the deposition of the 2 fixed doses triple drug therapy into the smaller airways using the functional respiratory imaging. This is how a functional respiratory imaging looks like. You get a 3D reconstruction of the airway using your CT scan, and then you give the inhalational medications and you try to understand where is the deposition of the drug. And this is the abstract which has been presented at the ATS. And as per the abstract details, what you can observe is that the budesonide, glycopyridinium, and formoterol combination showed a greater lung deposition than the fluticasone, umeclinidium, vilanetrol combination. And this has been proven with the help of the functional respiratory imaging, showing that the AstraZeneca patented molecule had a 2 times greater total lung deposition in comparison to the other form of drug delivery system. Apart from that, the ICS component, which plays a very important role in the serious exacerbations of asthma and COPD, also tend to have a 4 times greater lung deposition to the smaller airways in comparison to the counterpart. So there has been a consistent drug delivery with the help of the Aerosphere inhaler, and this plays an important role in all the 3 stimulation scenarios where the PMDI really fails, which is in the insufficient shaking, in the delay from the shake to the actuation and the first to the last actuation scenario. And as you can see from the various graphical representations here, the inhalational with the help of the aerosphere resulted in a consistent drug delivery regardless of the shake intake, consistent drug delivery even as if there is a small delay between the shake to the actuation, and consistent drug delivery from first to the last dose. And the aerosphere inhaler provided consistent drug delivery regardless of the shaking intake, from delay to the shake to the actual actuation, and from the first to the last actuation. And it also resulted in a consistent delivery for the triple formulation across the life of the canister. So to conclude, the effective delivery drugs must be deposited consistently throughout the lung to target both the large and the small airways. The functional imaging can detect the regional changes in the airway geometry, and it is more sensitive than the standard test to determine improvements in both large and small airway after treatment with inhaled drugs. The co-suspension delivery technology and formulation adopted by the aerosphere inhaler comprises of innovative aerodynamic phospholipid porous particle with a high fine fraction, which is more than 55% with monotherapies, dual combinations and triple combinations, and it provides effective delivery to large and the small airways, contains a stable homogeneous suspension in a canister to deliver a consistent dose from first to the last actuation, and it is tolerant to some patient errors. The gamma scintigraphy studies showed that the pulmonary drug deposition was high with the aerosphere inhaler, and the functional imaging showed that the drugs delivered with the aerosphere increased the airway volume in both large and small airways and decreased resistance in comparison to the baseline volumes. So it is an innovation formulation allowing for a consistent drug dosing and whole lung coverage, and it is based upon scientific principles of aerodynamic particles, effective delivery to large and small airways, and right dose and every dose. Thank you.
Thank you, sir. That concludes the lectures that we have planned for you today in this hall. May I request all the participants to kindly move to Hall 2, where we will be hosting another chapter of an event that is very close to the Yashoda family, that is Women in IP. I request you all to please join us there. Following that, we will come back here and meet for the quiz. I repeat, please move to Hall 2 for the Women in IP event.
through the skies, we get glimpses of the largest healthcare system in Hyderabad, our very own Yashoda hospitals. Spread across the city's 4 corners with 4 units. When you hear me announce Yashoda, look out the windows, and no matter where you're seated, you'll spot excellence in healthcare. Lastly, while you're on the ground zone in Hyderabad, take a moment to explore the city's rich heritage. Visit Charminar, marvel at the Golconda Fort, and don't forget to shop for those iconic bangles and pearls that give the city of pearls its name. As we prepare for takeoff, I request all participants to kindly fasten your seatbelts and stay seated during the lecture sessions. Movement is only permitted during the scheduled breaks announced by myself or the instructors during tea or lunch breaks. Once again, on behalf of BRONCHUS 2025, I thank you for joining us on this journey of knowledge and discovery. Sit back, relax, and get ready to experience bronchoscopy.
Courses designed to fulfill your needs in current-day practice. We are lucky to have some of the greatest bronchoscopists of their times with us on board to educate us with their vast experience in the field of interventional pulmonology. The journey is divided into didactics and hands-on interactive training modules to provide a great learning experience for the next 24 hours. You are free to move around once the program starts. However, we advise you to fasten your seatbelts and limit your movement while the lectures are going on. You may experience some turbulence when Professor Kyle Hogarth comes on the stage to debate with Dr. Pallav on robotic bronchoscopy. Do not leave your seats until you hear the command tea break or lunch break from the captain or our lead instructors. If you want to experience on board virtual reality education, do not miss Lorenzo Corbetta's lecture on augmented and virtual reality and bronchoscopy education. To reduce the risk of DVT, you are all requested to participate in the 2K run on Sunday morning, starting at 6 a.m. local time. The onboard entertainment features artists We Three of Us and her and the band D.H. Hun. You are advised to look at the windows when the captain announces Yashoda. When we fly across the largest healthcare system in Hyderabad, no matter you are seated right or left. We are all over with 4 hospitals spread over the 4 corners of the city. Do not forget to experience the authentic taste of Nizami cuisine and Hyderabadi biryani. We are also serving the famous Irani chai and Karachi biscuits on board. Last but not the least, don't forget to shop bangles and pearls, for which the city is named after as the City of Pearls. You can also experience the heritage of Golconda, Charminar, and other historic places while you are in the city of Hyderabad. Lead instructors get seated for takeoff and all the participants to fasten your seatbelts as we begin our ascent to the journey of bronchoscopy for the next 24 hours. Welcome on board BRONCHUS 2025 and experience bronchoscopy like never before.
Are you ready? This is gonna be legendary. 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 legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary. legendary. Are you ready? This is gonna be legendary. treatment area. Are you ready? This is gonna be legendary. legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary. This is gonna be legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary. Are you ready? This is gonna be legendary.
they make it sort of funny, no?
No, you go and ask somebody like this.
Achha, do we need to invite the teams?
Yes, yes. But I think they will tell us when to start.
Okay.
But the teams, right?
One.
Hurry. Each team has got 2 members or 3?
Because some have 2 members.
Some have 3.
Hello,
mic check.
Mic check. But how will they come on the stage for round? There'll be 2, 3 standing at the same time. Okay.
They'll be all there.
Okay.
It's fine. So we'll start off with
Nihal,
then I'll just say my name is Melvin. I'm from Samajra Hospital. You're Samir.
Yes.
And we are
And
your-
Kedar.
And then Kedar, and then we are your
quiz masters
for tonight.
But they have to see whether it's working or not.
That we don't know.
Where is the application guy?
No, the application guy is
One iPad, table 4 iPad, table 4 iPad. Quiz backend team, we need the iPad for table 4 here. Backend team, we need the iPad for table 4 here. On stage.
Dear Captain Dr. Harry Kishan, welcoming you aboard BRONCHUS 2025 with Yashoda Hospitals. A warm thank you for choosing to embark on this bronchoscopy journey with us here in the heart of Hyderabad, the city of pearls. Before we begin, a quick update on the weather. Conditions are clear with a pleasant temperature of 26 degrees Celsius. Perfect weather for learning and exploration with no turbulence expected on this educational flight. In case of an emergency, please call 105910 for immediate assistance. We are set for a journey lasting a total of 36 hours, where we'll explore the highs and lows of current-day bronchoscopy practices. Your lead instructor, Dr. Preeti Vidyasagar, along with some of the finest minds in the interventional pulmonology from across the country, will guide you through customized sessions designed to meet the needs of modern-day practice. We're privileged to have on board the legendary Professor Kyle Hogarth, who will join forces with Dr. Pallov for an exciting debate on robotic bronchoscopy. Expect a bit of intellectual turbulence during this lecture, but rest assured, we'll navigate it smoothly. Now let's walk through the key highlights of our journey. The itinerary is split into didactic lectures and hands-on interactive training modules to offer a rich learning experience. On your left-hand side, we have the exhibition center showcasing cutting-edge technologies and futuristic advancements in bronchoscopy. Don't forget to explore it during your free time. And for a taste of innovation, make sure to attend Lorenzo Corbetta's session on augmented and virtual reality in bronchoscopy incubation. We will also keep you active to reduce the risk of DVT. We encourage all passengers to participate in a 2K run on Sunday morning at 6 a.m. For your in-flight entertainment, we've arranged performances by the talented band We Three of Us and Her and the band Drew. Hungry? Don't miss out on the authentic Islamic cuisine, including the famous Hyderabad biryani, Irani chai, and Karachi biscuits. As we cruise through the skies, you'll get glimpses of the largest healthcare system in Hyderabad, our very own Yashoda hospitals, spread across the city's four corners with 4 units. When you hear me announce Yashoda, look out the windows, and no matter where you're seated, you will spot excellence in healthcare. Lastly, while you're on the downtime in Hyderabad, take a moment to explore the city's rich heritage. Visit Charminar, marvel at the Golconda Fort, and don't forget to shop for those iconic bangles and pearls that give the city of pearls its name. I request all participants to kindly fasten their seatbelts and stay seated during the lecture sessions. Movement is only permitted during scheduled breaks announced by myself or the instructors during tea or lunch breaks. Once again, on behalf of BRONCHUS 2025, I thank you for joining us on this journey of knowledge and discovery. Sit back, relax, and get ready to experience bronchoscopy like never before.
Hello, Bhuvan. All set.
Sergeant, sir. Sergeant, sir.
Responding.
Check. Yeah. Yeah, so that's the alarm. Can we have the team players, please? Can we have the teams on the stage?
This is them for sound check, Sergeant.
Yeah, we need sound check. Technical team, Sergeant. Mike.
Mike's not. Yep. Okay.
So we'll be starting in the next 2 minutes. Can we have the audience? Are you ready?
That's cute.
03 and 01. Mic check. We need a mic check for the teams.
Yes. Mic check.
Only 03 and 01. 03. We need a mic check for the audience, Dr. Kedar.
Mic check.
So just in case you have your friends in the room standing outside, it's the right time to call them inside because we are going to start the quiz.
Choose a question. You just choose by the category and number of points. Right then they will flash the question, right? But the question is open for everybody. Just everybody takes turn to choose, but everybody will. So you just have to press the buzzer.
Will we see the question here?
Sorry. Will we see the question there? Yeah. The question is right here.
Question. Yeah. Once they tap the big buzzer, then
Should we wait for the question to finish before you press the buzz? Or we can...
There are only 3 seconds, and
Okay.
after that, you have to
Okay.
Can we have the mic check from the teams? Mic check from the teams. Mic check from the teams, please. Quiz teams on the stage. Quiz teams from the stage. Hello?
Check.
Can we have the mic check from
Hello.
the teams
Check.
on
Hello.
the
Check.
stage?
Check. Hello. Hello.
So, very good evening. We are starting with the games. Okay guys, don't worry, this is not the Squid Games. That was just a joke. So, marhaba, namaste, ni hao, guten tag, ciao, and welcome all.
My name is Melvin, and I'm from Singapore General Hospital.
I'm Dr. Samir, I'm from Nagpur, India, and we have Dr. Kedar from Bangalore. We are your quiz masters.
Okay, welcome everybody. How's everyone doing? Good? Can I hear some screams and shouts? Hello? Okay, awesome. All right. So thank you all for joining us for the inaugural Bronchus Challenge 2025. All right. And for those people still streaming in, please take your seats quickly because we're going to begin very soon. So in a few moments, get ready to witness the intellectual clash, okay, unprecedented intellectual clash of brains and reflexes as our promising, brightest, budding interventional pulmonologists compete tonight. So just to give you a little bit of background, the idea of this challenge came from none other than His Holiness Dr. Hari Kishan. Okay, and I think this guy, in my opinion, is relentless, right, in trying to outdo himself with each subsequent edition of Bronchus. Do you all agree? If you agree, please give him a big hand. Okay, so tonight we are thoroughly thrilled to have with us a fantastic bunch of participants hailing from 5 countries, and they are Team India. Hey, home ground. Team Philippines, Team Malaysia, Team Indonesia, and Team Thailand. All right.
Okay, so see, there's one basic rule. We are not going to start unless you guys make a loud noise. So I have the right side of the auditorium. Can I have a huge woo? Not great. Left side.
No.
Right side. Okay, let's wait for some more time, and I'll ask the team members to introduce yourself in a very short way. So first we have Team India.
Okay, just give us a name, position, and institution of training. Okay, just a quick one.
Hi, my name is Anita, Dr. Anita Menon. I'm doing fellowship in interventional pulmonology in Amrita Hospital, Kochi.
Hello, I am Dr. Pallav Bhattacharya from Amrita, Kochi.
Thank you. And next we have Team Indonesia.
Hello, my name is Ray. I'm from Cipto Mangunkusumo Hospital, Jakarta.
Hello, good evening, everybody. I'm Jimmy from Indonesia. I'm from Central Java, Semarang, Karedi Hospital. Thank you.
We have Team Philippines.
I'm Gail Ramos Lee. I'm from the Lung Center of the Philippines.
Hello, good evening. I'm Dr. Noel Gomez from Lung Center of the Philippines.
We have Team Malaysia.
I'm Ye. I'm from Hospital Al-Osta in Kedah, Malaysia.
Good evening, everyone. I'm Dr. Charmisha, doing my fellowship in Interventional Pulmonology, Yashoda, Somajiguda, Hyderabad.
Team Thailand.
Good evening. I'm Apisala from Siras Hospital, Thailand, IP Fellow.
Yes, good evening. I'm Miss Kunchamai, Dr. Kunchamai from King Chulalongkorn Memorial Hospital, Thailand.
Can we have a huge round of applause, please?
All right, so we encourage all participants to have fun, interact, and then engage in healthy competition. And for the rest of us, we'll take advantage of this opportunity to upgrade our knowledge together as a community, okay? And before we begin the challenge, I'm just going to go through some house rules, okay? Number one, please ensure that your handphones are put to silent mode and your mouth zip, all right? So please do not shout out or like give any answers, all right, or any hints. And then each round, there will be 3 rounds to the quiz, and each round will consist of 25 questions that will be categorized into 5 teams, Japanese style, okay? And each team will take turns to choose a question that will be open to all to answer with the buzzer, all right? So when the question is flashed, there will be you have 3 seconds to read the question before the buzzer gets activated. Got it? Okay? And then please hold your answers until either of us ask you to tell us the answer, okay? Remember, accuracy and speed are key, right? So please think and move fast, right? And answer wisely, okay? In the event that the first team gets the answer wrong, then the second fastest team will be given a chance to answer, all right? But there will be a maximum of only 2 wrong attempts, after which we'll review the answer to save time, okay? So as we progress through the rounds, I'll like everyone in the audience to support and cheer for your favorite team, okay? And let's keep the energy high. I know everyone's tired at the end of the day, okay? And the atmosphere electrifying in the hall throughout the quiz, okay? So I think we will get the game started. So may the odds be ever in your favor. Okay, now for the first round, you can see that there are 5 teams: authors, discoveries, personalities, quotes, spotters. So Team India, you just have to tell us which question that you want to choose. So tell us the category, the team, as well as number of points.
Author.
Author, how many points?
T300.
Oh, T300, okay. Shoban. Yeah, it's pretty fine. Yeah, correct. Shoban, where is the question? Authors 300. Please pay attention. Okay? There will be like, you will have 3 seconds, all right?
Yeah, we press it. We press.
Yeah, so the buzzer's open for all. You need to press the buzzer.
Okay, I'm going to make it simple. Just one author, okay?
So Dr. Ko.
Is the buzzer working? Technical team, buzzer working?
Answer here or
I don't know.
Discoveries T100.
100?
Yes. Yes.
Okay. T100 discoveries? Okay, Team Malaysia. Yep, Malaysia.
Radial EBUS.
Radio EBUS, wrong. Okay, Team Philippines.
Convex EBUS. Convex EBUS.
Yeah. No, not. I think this is a Dumont stand, right? Jean-Francois Dumont. Yeah, okay, all right. Team Malaysia. Team Malaysia.
Spotters, T100.
Okay, spotters T100. Okay. Okay, India.
Sir, silicon stent.
Half answer correct.
Straight silicon stent.
No, wrong. Okay, Team Thailand.
Hourglass silicone stent.
Yes, hourglass silicone stand. That's the right answer. Okay, excellent. Next question, please. Team Indonesia.
Discoveries 100.
Again, sorry? Discoveries 400.
200.
Okay. Okay, Team Philippines.
Shigeto Okada, flexible bronchoscope.
Well done. You're right. Okay, good. Shigeto Ikeda. Okay. Next question, Team Thailand.
Spotter 300.
Okay. Sorry, I don't know what the question is.
Lymph nodes 4L.
Sorry, I don't see the questions there. I assume you're right, man.
The Philippines 4L.
Yeah. Okay.
That is the correct answer.
That's the correct answer. Okay, a technical fault again. All right. Okay, now finish first round. Okay, next Team India, please choose your next question.
T200.
Sorry, you have to speak out louder because I'm not controlling the. Yeah.
T200 and spotter. Spotter.
Okay. Okay, Malaysia.
Fogarty balloon.
The answer, that's the wrong answer. Yeah. In the Team Indonesia. Indonesia.
Balloon blocker.
Wrong. Okay. All right. So we'll review the answer. This is a bit difficult. Can we review the answer, please?
Can we have the answers, please?
It's a tumor resection, resector balloon. All right. Trivia. All right.
That was a tough one, actually.
Okay. Next, Team Philippines.
Discoveries T200.
Okay, Team Thailand.
Watanabe speaker.
Okay, the inventor. Yoichi Watanabe. Okay, great. Okay, next one. All right, Team Malaysia, please pick your next question.
Can we have the answers for the audience also? Can you display the answer once the correct is?
Yeah.
Okay.
Please keep up, technical team. Team Malaysia.
Okay. Personality 100.
Okay, Team Philippines, give us your answer.
Professor Atul Mehta.
What?
Professor Mehta.
Okay, you better say Karen. I can
Yeah,
hear
see, you'll have to help us out because there's some echo over here.
Yeah, that's right.
Can you be just a bit loud and clear? with
Samir,
your-
that's the right answer.
Professor Atul Mehta.
Okay, correct.
Thanks, yeah. All right, Team Indonesia, next question, please.
Outer 100.
Team Philippines.
Professor Ernst.
Felix Ernst.
Yeah, wrong answer.
So, Team Thailand.
Philip J. Hurst.
Again?
Felix J. Hurt.
No,
wrong
it's a bit
answer.
difficult, but anyway, can we show the answer, please? So, Momen Wahidi and David Ost. Okay, all right. Moving on to Team Thailand, please choose your next question.
Spotter 400. Spotter?
Oh,
Spotter. Spotter 400, right?
yeah.
Yeah.
Yes.
Okay, Team Malaysia.
Pick bronchus.
Okay, you're right. So it's a pig bronchus. It's not pigs actually, it's just pig bronchus.
Teams, hold your mics closer to your face and please answer because the team at the back end is finding it difficult to hear. There's a lot of echo on the stage. So can you be louder? Hold your mics close by and speak in, please. Who's the next team?
Yeah?
Who's the next team?
You broke my train of thought. Who was the next team? Team India. Okay, anyway, it doesn't matter, okay, because all the questions will be answered, open to all. Okay, Team India, please choose the next question.
T500 for spotter.
T500 spotters.
Okay, Team Philippines.
Carcinomatosis.
Wrong. Malaysia, please.
Cobblestone appearance.
No. Can we show the answer, please? Yeah.
Sir, TPO, tracheobronchopathica,
yeah.
osteobronchoplastica.
Yeah. Okay, next question, Philippines. Please choose your next question.
Discoveries T300.
Team Philippines.
TBNA.
Yeah, who's the person? Oh, you didn't attend this morning's lecture? Anyone else wants to give a chance, give a try? Nobody? Okay, we'll review the answer. It's Professor Kopan Wang, right, with the TBNA needle. Wang's needle, huh? Okay. All right, and then Team Malaysia, please choose the next question.
Courts 100, T100. Courts T100.
Any takers? Nobody? Cannot be. Indonesia, yes.
Is it Prof. Palaf?
Prof?
Palaf Shah?
No. Anyone? Okay, it's Prof. Atu Mehta. Okay, yeah. Okay, let's move on to the next question. Yeah. Before you become an interventional pulmonologist, you're first of all bronchoscopist. Okay, really wise words. Okay, and then now back to Team Indonesia. Next question.
Discovery 100?
Okay. It's the same question. Can we have another question, please? Skip the question. Yeah. Okay, maybe just go for, I'll just choose for you. Discoveries T500. Name the device and inventor. This is difficult. Give them the answer. Okay, I think this is really, really tough. Okay, so the answer is, okay, A.V. Levine, and this is a valvular bronchial blocking for very complicated TB, yeah? But I've never seen it, so anyways, trivia. Okay, let's move on to the next question. Team Thailand.
Personality 200.
$300? Okay.
Two.
So name the eminent personality. Okay, I think this is also difficult. All right, I think let's just review the answer. Can we have the answer? Professor Chris Bollinger. Okay. All right, now back to Team India. Please choose the next question.
Order to T200.
Okay, identify one of the authors of the book.
Broham Brothers.
It's going to be difficult. Yeah, it's fine, don't worry about it. Okay, can we just show the answers? Two Japanese. Yeah. Okay, Takehiro Izumo and Shinji Sasada. Okay, next question, Team Philippines.
Personality is to T200.
Okay.
200.
200. Personalities 200. Name the eminent personality. No takers?
Okay, so nobody's buzzed in, you can still give it a try, just for luck's sake. Okay, so can we have the answer? Is Dr. Praveen Mathur?
Okay, Team Malaysia, next question.
D300.
Who said this? If you're trained by the best, you can sustain the worst. Any takers?
Melvin, there is nobody taking it. So is there anybody in the audience who wants to take it? Anyone in the audience out here? Please raise your hands. Anyone? Anyone?
By Dr. Kelvin Lau.
Kelvin Lau? No. Anyone out here? Come on guys, there's somebody out here. I'll run, okay?
Dr. Pallav Shah.
No, it's not Dr. Pallav Shah. Anybody else?
Anyone from Cleveland Clinic over here?
Yes, anybody from Cleveland, they may be able to answer. I mean, that's
When
more
it
than
comes
a
to
few.
quotes, just
Yeah.
keep saying one name.
Can we have the answer, please?
Kyle Hogarth.
Who? Kyle Hogarth. He'll be elated. It's not Kyle.
Can we
Anybody
have
else?
the answer?
Anybody else? It is Atul Mehta, yes.
Yeah, I
Yes,
gave
it's
the
Atul
clue,
Mehta.
man.
Okay, next question.
Okay, it's Professor Atul Mehta. All right, yeah. Okay, next question, Indonesia.
Quotes 500.
Quotes 500. Who said this? The aim of medicine is to prevent disease and prolong life. The idea of medicine is to eliminate the need of a physician. Indonesia? Yeah.
Is it William B. Osler?
William?
William Osler?
No, but quite close. You got the first. You got the.
Okay.
Okay. Let me give you a clue. Okay. Besides Cleveland, right, which is the other very famous clinic in the U.S. Bus. Anyone?
Okay, so they gave half the answer, but that does not qualify. So can we have the right answer? That's Dr. William J. Mayo.
Okay. Team Thailand. Next question.
A lot of points to be grabbed, so choose the 500s.
Answer 500.
Author 500.
Okay. Name the editors of the book. Just name one. Okay. Not. There are two of them, I think. I'll give you a clue. Both Americans practicing in the United States.
No one? Did no one answer?
Okay, Malaysia.
Just a try. Borham's brothers.
Sorry?
No. Indonesia?
Maybe Prof. Ali Musani?
No.
Ali Musani? No, not Ali Musani. That's it? Nobody's taking this question?
Okay, let's review the answer.
So we'll ask this to the,
Yeah. Henri Cole and Team Mergu. All right. Okay, is it Team Thailand's turn now? Or you have already chosen the question? Okay, so back to Team India.
Personality T500.
Okay, personalities 400. 400. Name the eminent personality. Okay, Team Thailand.
Professor Kurimoto.
Excellent. All right. Okay, next question. Team Philippines. Continue.
Personality T500.
Okay, name the eminent personality.
Team Philippines.
Henry Cole.
No. Any
That's it, we
takers?
don't have any more.
Okay, no more takers. All right, I'll get Samir to tell you the answer.
Yeah, do you need any clue?
Do you want a clue? He was the head of department at the Marseille hospital till recently, and now he's been taken over by somebody else. Who is he? He's done a lot of work in fluoroscopy. I can't give you more clues than you.
Okay, so I give this question to Dr. Rakesh Panchal. Yes.
Yes,
correct
that's right.
answer. Can we
It's
have
really
the answer,
possible.
please? Okay, so Dr. Panchal, you get a free fluoroscope from Hari, not from me.
Okay, next, Team Malaysia, the next question. Okay, we are finishing up the first round. Okay.
T400.
Quotes 400. Yeah. 400. Who said this? I'm still learning. Okay, I think in the interest of time, if there are no takers, I'll get Samir to tell you the answer.
So there's no buzzer. We have Team Philippines.
Professor Adolmet.
Okay, so the correct answer is me. During my final exams, Viva, I said, I'm still learning. That's a joke. The correct answer is Michelangelo.
Yeah, but honestly, can we just give it? I'm just going to break convention rules, okay? I think I'll just give it to Team Philippines because Atu Meta, if you say Atu Meta for quotes, you're almost always right, okay? So I think we'll give it to Team Philippines, okay? Okay, all right. Final question, Team Malaysia. Who said this? There are only two sorts of doctors, those who practice with their brains and those who practice with their tongues. A clue. I think just now one of you mentioned the name. Old-time physician. He has got. Okay, Philippines.
Henry Cole.
Who?
Henry Cole.
Oh no, wrong answer. Someone older.
Atul Mehta.
Okay, you cannot try the same trick twice, okay? So, no, wrong,
Atul would
okay.
be related listening
All right.
to this.
I'll
But
get
since
Samir to
both
tell
the
you the
teams
answer.
have not answered, does anybody in the audience want to take this? Yes, there's one lady out there. I'll come to you. Remember, Hari is giving away bronchoscopes for correct answers. Yeah.
William Osler.
Yes, that's right. It's William Osler.
Correct answer.
Yeah. Okay, so can we just tabulate the results so far? Wow, it's a tie between Team Thailand and Team Malaysia. All right, so there are 3 rounds. I'm not sure whether we'll be up to it, but we'll try, okay? But now I think I'm going to hand over to Dr. Keda and Dr. Samia. It's going to be an audience participation round, okay? I'm not sure whether Hari has got prizes for you, maybe, a car, or something like that. So try your best, okay? Try your best to answer. Okay, take it over,
Can
guys.
we have the question on?
see, the primary requirement here is that you guys need to make some noise. Can we have some noise in the hall? This is the benchmark, you need to be louder than this. Okay, so Kedar, we can go ahead with the audience question.
Can you just put on the first question, please? The first question on the audience.
I have it here.
It needs to go online.
So can we have T100 for audience round 1? Question T100. Yeah,
Okay,
we have
so
the question.
here's the question. There's one stent that's come up on your screen. Can anybody name this stent? And if you can add an additional point about how it is deployed or where it is deployed. Anyone out here in the audience? I don't see any hands. Here? Okay.
And can you please
it the hood
introduce
stent?
yourself, please?
No, it's not the hood stent.
We
It's
need
not
the
hood
audience to
stent.
introduce.
Yeah, there's Gela out there. Gela, you get a car if you...
No pen stent?
It's not.
Montgomery by stent.
No, it's not a Montgomery by stent, but you're a little close by.
Vestabi T. Vaishan.
Yes, it's the Vestibular TY stent. Lady, you've answered the second question right. What's your name?
Madhuri, sir.
And what are you doing?
Sir, intensivist, sir.
Intensivist. Okay, that's great.
Can
So
we
it's the
have a huge
Vestabi
round of
TY
applause?
stent. It's very close to what a Montgomery stent looks like. So if you go back to the question and you look at the stent, the two limbs of the stent go into the Y and the other one pops out. So it's basically a Montgomery with a Y stent combined. Okay? So the next question, T200. Name the procedure and name the indication. Audience, what procedure is this and what is the indication? Jump shake, okay. That's going to be a bias thing, but still.
It's a bronchial bypass.
Yes. So that's a airway bypass procedure and an indication.
The COPD.
Okay, that's right. We'll give it to jump shake. The next question.
So we are left with T300.
So these are the different imaging modes, but you'll have to identify each of the imaging modes and tell me. All the three. All the three. Please don't attempt one. Please tell us all the three. Yes, there's one here. I'm coming. All three?
NBI.
Which is the NBI? Which is the NBI among these?
The blue-green.
The blue-green, okay, that's the NBI.
White light.
The white light. Which is the white light?
On the left side.
On the left side is the white light?
I know, sorry. The upper.
Yeah,
right
the upper one on the right is the white light. Okay, what's the other one? No, you can't take Gela, sorry. Anybody else? What's the other one? What's the other one? LCI?
So I'll
No,
give
it's
a
not.
clue if anybody attended pulmonology on air with Dr. Vishwesaran's presentation.
Okay, there's... okay, one more here before we go back to you, Samir.
RDI?
Yeah, what does RDI stand for?
Red dichromatic imaging.
Dichromatic imaging. Yes, RDI, that's the red dichromatic imaging.
Can we
The
have
one-
the answers?
The one on the right base is the NBI, narrowband imaging, and of course the one on the right top is the white light imaging. Okay? So, Samir, I think we're done with this round of audience questions. We'll go further to the next round. The next round, please.
So We are going for Bronchus Quiz Challenge 2. And let's start with Team Thailand this time.
Okay, remember now the higher questions that you choose, the more points you get. So this is the last round and this is going to decide who's going to be the winner. So please try and choose your questions with the appropriate points. Okay? 3 rounds. Okay, sorry. There's one more round to go. Okay. Can we have the panel on the stage? The panel on the screen, please.
Technical team.
So we are starting with Team Thailand this time.
No, I'm fine.
Backend team, can we have the panel displayed?
So Team Thailand, do you have the display?
You know, this reminds me of a moment like in the OR when people are still trying to get everything ready and, you know.
Okay. So the panel is on display right now. So Team Thailand, what's your choice? There are 5 rounds. Here we have BAL, biopsy, EBUS, identification of an abnormality and questions related to pleura. So choose your questions, tell us the topic and choose the appropriate points that you want to win with the question. Team Thailand?
Plural question 200.
Can you be louder, please?
Plural question 200.
Plural question?
200.
200, okay. Identify the stethoscopic finding.
Team India, answer.
Sago grain appearance.
You're right.
Yeah.
Okay,
Can you give the diagnosis?
Yep.
Yeah.
Okay, guys, I think it's getting a bit like too lazy, right? Yeah, can everyone just stand up, you know, move around? Is it okay? We're trying to get the energy high a little bit. Can? Yeah. Please, okay? Yeah. Then we'll go for dinner. Okay. All right.
Team India?
Indonesia. We go this way.
Team Indonesia? Your choice?
EBUS T200.
EBUS T200 question. What has the EBUS operator done here?
Team India? Answer, Team India?
EBUS scanning.
No. Team Philippines?
Lymph node identification.
No, I think, can we just play, okay, I think, can we just reset the question? Can you just play the video again and please do not put the cursor, on it. So, okay, look carefully.
So what has the operator changed that's changed the image later in the later course of the video? That's the question.
Sir, they changed the frequency.
Sorry?
Frequency they have changed.
Frequency? No, it's not the frequency.
It changes the depth.
Change the depth. Yes, that's the answer. So
Okay,
the
Team
points
Philippines
go to
goes
team,
to Team Philippines.
Team Philippines.
All right, Malaysia, please choose the next question. Team Malaysia.
T500 Pura.
T500
T500
BAL, is
pleura.
it? Or, okay, pleura, okay. So as per existing evidence, cryo-pleural biopsy increases yield compared, okay. Philippines?
True.
True. All right, that's true. Is it true?
Yes.
Really?
Yes.
No, I'm going to give you a chance to... Confident? Samia?
Yes, true.
No. Yeah, so that's the wrong answer. So we have analysis where pleural cryobiopsy is safe but does not increase the diagnostic yield over flexible forceps biopsy.
Okay, so there is inadequate evidence to prove that. All right, so Team Philippines, next question.
EBUS T300.
EBUS T200.
So what does this image signify? Team Thailand.
I don't know.
Come on, Team Thailand.
For the scope, change the direction of the scope.
No. Team Malaysia?
Wedging.
No. Okay, I think we have to give you the answer. Actually, it's probably not a very good drawing, but Samia? Yeah. So it was just trying to illustrate the intubation with an EBUS scope, right? Because the field of view is different as compared to your straight-on vision of the normal bronchoscope. All right. Okay, and Team Philippines, question, next question.
BAL T200.
BAL
200.
200.
Name the condition, describe the cytology image. Okay, who's the first? Team Malaysia.
Diffuse alveolar hemorrhage.
Okay,
Hemosiderin-laden macrophages.
excellent. All right. Okay, next question, please. Team India, back to you.
BAL T500.
Okay, can you repeat again? Because for the back to listen, to hear you. BAL 300?
BAL T500.
T500, okay. Name the condition. Okay, Team Malaysia. Team Malaysia, your answer, please.
Protein alveolosis.
No?
No.
Team India. Team India.
Nephrotic syndrome.
No. Okay, I'm going to get Samir to tell you the answer.
So, anybody in the audience?
Anybody in the audience wants to take this? Oh,
It's
there's
a
lots of
bronchobiliary
We have the answer
fistula.
on screen.
Okay, all right.
Okay,
Back to Team Thailand.
let's see who
Next
wants to
question,
answer.
please.
1 second. Can we have somebody raise the hands here? Oh, they answered. Okay.
Kada, the answer was already revealed. So, Team Thailand, next question, please.
Biopsy 300.
Biopsy 300. Okay, post-renal transplantation, bilateral lung nodules. What is the diagnosis? Team India.
CMV.
Wrong. Team Thailand. Team Thailand.
Cryptococcus.
Cryptococcus?
Yes.
Excellent. Yep. Great. Well done, Team Thailand. Okay, next question. Indonesia.
Pleural T400.
Okay, plural T400. 400. What is the chemical composition? Chemical composition. Malaysia, Team Malaysia.
So 4 gram per a vial. We usually take we'll get in 15 million units. We have to dilute and take 2.5 million units.
Oh, yeah. That is how you sort of like dilute the mixture, right? But
It's a
what is the
graded-
chemical
graded top.
composition?
Graded talc powder.
Again?
It's a graded talc powder.
No. Okay, Team Philippines?
Medical grade talc.
Yeah, but what is the chemical composition?
So we need the chemicals involved.
Yeah, chemical symbols, or it's trivia actually.
Calcium. Calcium carbonate.
No. Can we move this to the audience?
Yeah, let's move to a plural person.
Yes, the plural
So
person is
Dr.
here.
Rakesh will not get to answer. No, not you.
No. Why?
You are the master, Rakesh.
Magnesium trisilicate.
You mean the chemical composition of talc, magnesium, hydrogen, silica, and oxygen?
Magnesium trisilicate.
Almost there.
Magnesium,
yeah.
oxygen.
Yeah,
Sorry,
so
it's a language barrier.
what's the cation, the anion?
Yeah, so we are left with Dr. Rakesh.
Rakesh.
Hydrated magnesium trisilicate, isn't it? Yeah.
Yeah.
Oh, you want the actual symbol?
Hydroxylated?
MgSiO4, I can't remember the whole...
Yeah, so it's hydrated magnesium silicate. That's the right answer.
Right. Okay, team, next up, we have Team Malaysia. Please choose a question.
EBUS 500.
EBUS 500, okay. So no mediastinal involvement at CT and or PET CT. Okay, India, Team India. What's the answer? When should EBUS TBNA or EBUS BFNA be performed?
Sir, when there is suspicion of the infiltration of the wall at that time.
Or the other question, the other way to phrase it is, when should it not be performed, or rather, can be omitted? But obviously, this is controversial.
Of alternate diagnosis.
Okay.
Alternate diagnosis.
Okay, no. Team Thailand.
Okay, the third one have to done the EBUS staging because the mass more than 3 cm, yeah, and the central and N1.
Yes, that's right. Okay, very good. Team Thailand. Okay, that's right. So this is just EBUS must know. Okay, next. We have Team Philippines. Please choose a question.
EBUS T100.
EBUS T100. Okay. What is the modality of imaging? Okay, Team Malaysia.
Elastography.
Yes, that's right. Well done. Okay. Team India, back to you. Choose the next question.
Our screen had a problem.
Oh.
Our screen had a problem.
Oh, sorry?
Our game screen had a problem, sorry.
Oh, you have some problems with the buzzer? Technical team, can you please help out?
Sometimes I delay when we can press the bus.
Okay, all right, are we ready to resume? Okay. All right, Team India, next question, please.
BAL T400.
BAL, okay, BAL 400. Name the condition. Okay, Team India.
So the condition is PAP, pulmonary alveolar proteinosis.
Okay, that's correct. And what's the criteria to perform whole lung lavage? Just name a few. because there are
Sir,
no...
when the FVC is less than 40%,
Not quite there, but actually it's a composite, yeah? It's a composite. So it really depends, but it can be like worsening symptoms, radiology, pulmonary function, right? As well as SpO2, okay? But I think we'll give it to you. All right. Okay. Okay, I've been informed that the buzzer is not working. Technical team.
Yeah, technical team there. The teams are having some issues with the buzzers. Okay, so we go old school. We can't recalibrate right now. So whoever knows the answer, you need to, and we need Kedar to tell us who's raised the hand first. Okay, so buzzers are out. If you know the answer, lift up your hand.
Okay, so let's move on to the next question. So you guys, okay? All right, don't be stressed, it's fine, okay? Just raise up your hand and then Kedar will tell us, okay? Okay, next question, please. Next question, back to the...
Philippines.
Yeah.
So last, we had Team Philippines or Team India?
Okay.
Philippines.
BAL T300.
Biopsy T100? Correct?
BAL T300.
Okay, name the organism and name the condition. Okay.
Team Malaysia, then Team Philippines.
Filariasis.
Team Thailand.
The parasitic lungs.
Okay, but is
Name
team just now? Who was the second? Sorry.
The first one was Team Philippines, Malaysia, and then Thailand.
So it was Malaysia first.
So now it's turn for Thailand. They both answered. Now
so
it's turn.
okay, Team Thailand.
It's the parasitic lung, the paragonimus.
Parasitic.
Parasitic
So she says
lung.
it's paragonymous.
Can you be more specific?
Can you be more specific?
Melvin, she says paragonymous.
No, we
Is that
just
right?
need a more specific answer.
Strongyloid.
Yes.
Yes,
Okay.
that's the right
Well
answer.
done. Okay. All right. Now, Team Malaysia. Next question. Team Malaysia, pick your question. Or you picked already, is it? Sorry.
Biopsy 500.
Biopsy 500, okay. Does endobronchial cryobiopsy, okay.
Team India.
Okay, Team India.
no, it doesn't.
Yes.
What's the answer, sorry?
No.
No, wrong. Who was the second?
So
Team
it was
Indonesia.
Indonesia.
maybe? Okay, Indonesia.
Yes, it does increase.
Okay, yeah, it's all right. It's quite unfair, but never mind. Okay, all right. Okay, next question. What's happening again?
So last question, we have raised the I told the answer. Last question, I have raised. Okay, now we have to.
We can now use the buzzer. Okay. No more racing.
Okay. Any issues? Sorry. What's going on? Okay. The buzzers are online. Sure? Okay. Sorry, everybody. Apologies for the technical faults. Okay. Can we resume? Is okay? All right. Who's next? Sorry, just remind me again. Next question. Indonesia.
Identify the abnormality.
Okay.
T300.
T300. Okay. Name the condition in this 1 year row. Okay, Indonesia.
Is it tracheobronchomalacia?
Again?
Tracheobronchomalacia?
All right, I think I'll just give it to you. Okay, it's laryngomalacia. Okay, good. Okay, next question. Team Thailand.
Biopsy 200.
Okay, biopsy 400. Okay, what is your diagnosis? Team India.
Sir, amyloidosis?
No.
Wrong.
Team Malaysia.
Tracheobronchopathia, osteopathica.
No. Okay, we'll give it to maybe Team Philippines.
Please see the histopathology on the right.
Squamous cell carcinoma.
Please see the histopathology on the right side as well.
Squamous cell carcinoma, that's keratin pearls.
Sorry, again?
Squamous cell carcinoma.
Oh, no.
Audience.
Okay, we'll just, never mind, we'll just make do, okay, Team Indonesia.
Sarcoidosis?
Yeah, that's right, sarcoidosis. Okay. Okay. Next up, choose the question.
Biopsy T200.
Match the following. Okay, Team Indonesia.
A for 3, C for 4, B for 2, D for 1.
Can you just repeat that again, just slowly? Yeah.
A for 3,
Okay.
C for 4, D for 2, B for 1.
That's wrong.
Sorry.
No.
Okay, Team India, you have a try.
Sir, A for 4.
Okay, A for 4. Okay.
Why don't you tell us the names? What forceps is that?
Yeah, just name the forceps.
Names the forceps.
Rat tooth forceps.
Yes, so A4, next one.
B, peanut forceps.
Peanut forceps. So B is attached with which picture?
3 is D. 3D.
No, please go in order. So A is done. What is B for?
B.
B is for what?
Okay, I think in the interest of time, I'll just get Samir to show you the answers, all right? Can you just review the answer and Samir will just bring you through. Okay.
Yeah, so we see that the first one is the rat tooth. The second one should be easy. It's the cup forceps. Hot biopsy was a bit tricky, but yes, you can see the fire over there. And last, obviously, is the alligator forceps. We move to the next question.
BAL T300.
Okay, the patient presents with hemoptysis. Okay, Team India.
Sir, actinomycosis or TB? Tuberculosis?
No.
No.
Team Malaysia. Team Malaysia.
Bronchiectasis.
No. Okay, Indonesia. Want to try?
Is it multiple cystic lung?
No.
No. What is it trying to show you actually?
We move to Dr. Kedar.
Anybody in the audience here?
Dry bronchiectasis, Brock syndrome.
Dry bronchiectasis.
Nocardiasis. Nocardiasis.
Yes, the answer is nocardiosis.
Yeah, so it's always like what are your differentials of a AFB positive smear, right? Okay, moving on. Yeah. Next team, please. Choose the question. Yeah, I think Team Indonesia, yeah, it's okay.
Identify the abnormality 500.
Okay, identify the abnormality T500. Okay, 8. Wow, Team India. Answer, Team India.
Surgery?
Okay, would you like to elaborate a little bit more? What kind of surgery? Okay, anyway, it's fine. Surgery is good. Okay, you.
Yeah, so it's surgical resection anastomosis. You get the points, right?
Yeah, but you get the points. Okay, all right. Team Thailand for the next question. Show the answer, yeah?
Pura T100. Pura T100.
Okay, Plura, 300. Okay, identify the procedure performed. Team Malaysia.
Pigtail insertion.
No.
No. Team Indonesia. Come on, Ray.
Pleural catheter insertion. Intrapleural catheter insertion. Intrapleural
Okay, that's right.
catheter
ICC insertion. Great. Okay. That's right. Okay, let's move on.
That answer didn't get reflected in our score. We got that surgery wala answer 500. It's not showing here in the system.
Sorry, you just give us a while.
Can you just be a bit more clear?
Sir, that answer which we got, surgery, T500, it's not showing in our scoreboard.
Yeah, Kedar, can you help with the query?
Saying that the question that was answered is not showing up on their points table.
Oh, okay. Just now that question, the IPC question?
Sir, it actually happened 2 times. One for the PAP question and one for that endobronchial ISET surgery. That both the points are not shown in our system.
Yeah, technical team, they're saying that they've answered 2 correct questions. One was for the PAP and the recent one.
Sir, the PAP one and the surgery, which one?
Yeah, and the points have not been added.
Okay, I think we'll just carry on first. We'll sort it out. Yeah, any question? What's up? Sorry.
The buzzer, it's gone.
Oh, it's not working. Okay, technical team.
Excuse me. Actually, I already answered a question about the cryobiopsy, whether it increased the yields of diagnostic. It doesn't come in our points also.
Oh, it doesn't show on the screen too. Oh, so this is so bad. Okay, technical team, Okay, anyway, I apologize, okay, on behalf of the technical team.
We'll sort that out.
Yeah, but let's try to get this over. We'll just have 2 rounds, okay? Because I think everyone is hungry and hangry, so we'll just move on. Okay?
Sorry. It's not
I know there'll
working.
be a bit of unfairness, all right? Because, you know, everybody's like giving some problems, but we'll just take it in good, you know, just good faith and, you know, just have fun, all right? Okay?
Sir, sorry, it's not the application is not working on.
Oh, application has stopped. Okay.
So the points are still not showing. T500
Okay,
word order.
I think we've had enough. So let's just round up. Can we just tabulate the results? Okay? Yeah. Okay, tabulate the results. Sorry guys, yeah, but we'll tabulate results. Can we just show the results so far? Can we show the points so far?
Okay, we'll continue and we go old school. You raise your hands and we'll specify the points that you've won. Okay?
Okay, yeah, we'll just finish up the remaining questions, okay? All right, who's next? It doesn't matter actually, just someone, okay, maybe Team Thailand, can you just pick the question? What, sorry?
So we are raise hand. After this, okay.
Who's next? I forgot.
Okay,
Who's
Team
next?
Thailand is okay? Yeah, just move along, yeah, it's okay.
E-bus 400.
Okay, E-bus 400. Okay, look at the questions. Okay, Team India.
Gauge, needle size.
Okay, that's right. Yeah. Yeah. So size of E-bus, TBNA needles. All right.
Yeah, so that's 400 for India.
Okay, Indonesia, next question.
Pleural question T100. Pleural.
Okay, plural T100. Okay, Team Philippines.
Lam.
Okay, Lam, that's right. 100 points for Team Philippines. All right.
So that's 100 points.
Okay. Let's move along. Let's move along. Next. No. We're trying to get the, yep. Okay, Team Malaysia, question.
Biopsy 100.
Okay, biopsy 100. Okay, uncontrolled diabetes, stridor. Okay, Indonesia.
Aspergillosis.
Nope. Who was the second? Kedah? Second team? No?
Kedar, who's second to lift the hand?
To lift up the hands.
So, I don't know. I didn't see it.
Oh.
Okay.
Okay, all right, Kedah. All right, never mind. Sorry, I'm just going to. Okay, maybe Team Thailand.
Rhodococcus. The black fungus, Rhodococcus.
I cannot hear you. Sorry.
Rhodococcus.
Rhodococcus. No, it's not Rhodococcus.
No, sorry.
Okay.
Mucor?
Mucormycosis.
Yes,
Mucormycosis.
Okay, so
That's 100 points.
for Team Malaysia, is it? Okay, Team Malaysia, mucormycosis. Okay. Okay, next up. Yeah.
I identify the abnormality T200.
Okay, identify the abnormality 200. Wow. Okay. Indonesia. Indonesia. Yeah, you already put up your hand before everything. Team Indonesia.
Is post-segmentectomy or lung transplantation?
Sorry?
After segmentectomy or lung transplant?
You can only choose one.
After segmentectomy?
No. Okay. Team Philippines.
Right pneumonectomy.
No. Okay, Team Thailand.
Lobectomy.
No. Okay, Samir.
We have Team Malaysia. You want to give it a try?
Post-lung transplant.
Yes, that's the right answer.
That's right. Okay. Okay, Team India, next question.
T100.
Yep, Team India.
Tracheo Malaysia or EDAC.
Okay, that's right. All right, and what's the collective term for it? For this EDAC, TBM?
CPAP, we need CPAP for EDAC.
No, the collective overall umbrella term as
So pardon, sir?
Indonesia?
Excessive dynamic airway collapses.
Not quite, but that's EDAC, right?
Yeah,
So
that's
EDAC
still
and
for EDAC.
TBM, like Team Mergu and gang, they call it?
Thank you, Malaysia.
No, it's just excessive central airway collapse.
ECAC.
Yeah, ECAC, okay, but it's fine, okay. All right, okay, so
Sir-
India has the points.
Sir, I have one doubt. Sir, we answered this EDAC also correctly, but still the points are not being shown under our, I don't know.
This one I don't know answer.
Yeah, I've given the points. No problem. Okay, final question. Okay. Team Malaysia.
Tracheitis, tracheal crust,
Tracheal?
tracheitis.
Nope. Team Indonesia.
Mucus crust from inflammations?
No. Team Thailand.
Is a tracheal cartilage rupture?
Okay, the tracheal cartilage. So what happened? What do you think happened? Like it's a A shape, right? What do you think happened? What do you think? What's the underlying condition? The condition that led to disappearance?
It's maybe the chronic infection or from the intubation or trauma.
Yeah.
Okay,
That's the right
yeah,
answer.
that's right. It's a traumatic kind of tracheal stenosis, right? Yeah, typically when you get this, probably more likely tracheostomy, post-tracheostomy rather than post-intubation.
So that's 400 for Thailand. Yeah. So can we have Dr. Kedar, please?
So, go ahead, Samir. The next question.
We'll have the...
Okay, the winner.
So, Kedar, we go ahead with the Quiz B challenge. Quiz B challenge for the audience. Can we have the lights on for the audience?
The next set of questions for the audience, there are just 3 of them. can we have the back-end team put on the first question, please?
So we start with T300. We'll start with 300.
Yeah. Team back-end, the first audience question, T300.
Bronchus quiz B challenge T300. Yeah, we have the question. Yeah, that's the question. Can we have the question on the screen?
So can anybody identify what procedure or what instrument this is? Sorry?
BTPNA.
No, it's not the BTPNA. And what does BTPNA stand for? It's bronchoscopic transparenchymal nodule access, but that's not the catheter we are looking at. What is this? TBNA needle? No, it's not the TBNA needle. Here, Gella. Gella, you.
This is a different periview flex.
No, it's not the periview flex. Anybody else? It's not the periview flex.
Histology needle. Histology
it's not
needle.
BTPNA.
Histology
Anybody in the
needle.
first two rows out there? Okay, Nishant's here. First two rows. No, Melvin, you don't get to answer. Ablation needle. What ablation needle?
It's a peripheral nodule ablation needle.
What? Peripheral?
Peripheral nodule ablation needle.
Can you tell us the name?
Name, I'm not remembering.
Okay. No name. Anybody here? Yeah.
Galvanize the pulse electric field. Yep. Kedah Hibarik.
No. Okay. Can we have the answer, please?
So the clue is a Bollywood actress.
So this is the okay, Alia PF system. Okay, no, so this is again for chronic bronchitis.
Anyone wants
Next
to
question.
Kedar, anyone wants to elaborate on this answer?
Anybody wants to elaborate on this answer?
Melvin?
Okay, I think we'll, in the interest of time, we'll go to the next question.
Okay, so we'll go for Bronchus quiz B challenge T200.
So what balloon is this and what do we use this for? What? Okay. One second.
What is it? Tumor resection balloon.
Okay, but what is it? Do you have a name for it? Okay. Anybody else? That's not a right answer. Anybody else? There's somebody at the back. Okay.
Volume reduction.
No, that's already told. It's not the tumor debulking balloon. So that's
Dr.
what-
Rakesh, are you saying hi or are you?
Yes,
Yeah,
it's a
so
dissection balloon, and what is it used for? Can you tell us one of the indications for it? 1 second, somebody.
It is for the
Condition. Just name the condition.
cartilaginous.
So this is a Karakora resector balloon. It's used for tumor dissection, but it's mostly for chronic bronchitis. Basically, it's one of the older treatments which was tried for chronic bronchitis. There's an ERS paper on this. Can we have the next question for the audience, please?
Yeah, so last question T100 for the audience.
Okay, what is the confocal laser endomicro finding in this particular video? Confocal laser endomicroscopy. I know this technology is not available, but if anybody wants to take this, any one of the interventional fellows, somebody who is into interventions already.
Anyone from the first two rows?
First two rows, yes. Let's trouble the first two rows. Rakesh. Let's catch Rakesh. Rakesh.
Something infection related?
Something infection. Okay, it's not infection.
Emphysema.
No, not
Infection.
AB, you were like this and now you're like this.
Some kind of infection.
infection. Anyone here? AB.
A blood vessel.
Blood vessel. Okay. I think you're very close by. Can we have the
Yeah,
answer
so
here?
yeah, you get the
it in some
points.
case.
Yes.
He got it? Okay. He gets a card for that.
Can we have the answer?
Yeah, he gets a card for that. Don't worry about it. Okay. Can we have the answer, please? So
Yeah,
it's
can we have the
basically-
answer?
So it's basically the in vivo confocal laser endomicroscopy. It's a blood vessel with RBCs moving, So this is an in vivo technology which is basically laser guided, and you are able to see everything at the microscopic level as it happens. So that's basically what it is. Over to you, Samir.
Yeah, Kedar, you can come up now. Okay, so we come back to our teams. So this time again we'll start with Team India. What was our last status? Were the buzzers working or no? So we go for the manual way. You need to lift your hand. Kedar, I need you here. So can we have the quiz 3 challenge? We need the tabs for quiz 3 challenge.
Can you open that? Can you open that? Yeah. 1 minute. 1 minute. I have to do this, right? Because other people are waiting.
Okay. 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 So,
1 minute.
So, we are done with the quiz as of now.
Okay guys, before we end this, there's an important announcement to make. Tomorrow morning there's a 2K run, and we would like you all to be there. And it's the BRONCHUS 2K run. It starts right outside, and we want maximum participation. So can we have a loud cheer for the tomorrow's run? 6 o'clock morning outside. Okay, 2K run. That's it, and let's see who wins the car tomorrow.
Okay, so for the interest of time, we are done with the quiz. But I would want all the quiz team members to come in center. We'll have a picture, and can we have a huge round of applause for their spirit and their enthusiasm? Guys, can you please come in the center? We just need a group photo.
Come to the center.
So you see, that's the difference. You see the generational gap. They are more occupied with the selfies.
Oh, thank God.
Please, can we have you at the center? So I know you guys are pretty hungry and waiting for food, but can we have a huge round of applause for all the team members? So I believe everyone played well, and that was for the spirit of IP and the spirit of knowledge. So I hand over the proceedings to the technical team now. Thank you. Thank you on behalf of Kedar and Melvin also.